female more than male, and pain is especially at night. Clinically, tinel sign and fennel sign is present. Tinel sign means you just stroke the median nerve, patient will feel pain, and fennel sign, you just ask the patient to dorsiflex the hand, patient will feel severe pain. Next is diffuse idiopathic skeletal hypostosis or DISH is seen in about 26% of diabetes patients, characterized by excessive bone growth and calcification of paraspinal ligament due to hypostosis effect of hyperinsulinemia, that is osteoblast stimulation and osteoclast inhibition. The disease is most common in the thoracic spine, cervical spine, and finally the lumbar spine. But fortunately, the intervertebral disc, facet joint or sacroiliac joints are spared. In patients with type 2 diabetes and metabolic syndrome, increased level of insulin-like growth factors, sorry for spelling IGF-1, stimulate bone growth. Now the bone metabolism in diabetic patient, in type 2 diabetes, osteoporosis is more prevalent due to lack of IGF-1, which stimulates osteoblast. Microvascular disease, oxidative stress, advanced glycation, increased parathormone and hypercalciuria, thus leads to osteopenia and osteoporosis. Incidence of osteopenia is 18 to 54% in different stages. Retinopathy is more prevalent in patients with osteoporosis. Other musculoskeletal conditions or disorders are like infection of the bone and joint is commoner in diabetic patients in the form of osteomyelitis. Shoulder joint is most commonly affected and usually caused by E. coli, then the hip joint by Campylobacter and the small joint by Streptococcus. Gout in female is a risk factor for diabetes and glycemic good control prevent gout. Gout and pseudo-gout are prevalent due to insulin resistance or medications like diuretics. In conclusion, patients with diabetes may present with a variety of musculoskeletal complications. Most of these complications point to long-standing disease and poor glycemic control. Early diagnosis and treatment improves glycemic outcome. Similar musculoskeletal manifestations may occur in other endocrine or metabolic diseases. Thank you.
Thank you and congratulations, Dr. Umesh Khan, for a very wonderful deliberation. As we all know, it is chairman's oration, so there is no scope for questions. But then, I would definitely like to say a few things. We all know that musculoskeletal problems are very common in diabetic patients. We know about certain things like dupuytren's contracture, frozen shoulder is very common, amyotrophy of the thigh muscles, osteoporosis, etc., etc. But you have given a very big list, which makes us very scared. As a very committed practitioner, as well as academician, though it is not permissible, but I need your comment on one thing. Since it is a very common problem, is it possible to prevent these things in a diabetic patient? I mean, what do you don't tell me tight glycemic control, that is understood. But other than that, can we do anything so that these problems can be prevented? Because frozen shoulder and dupuytren's contracture, even osteoporosis, amyotrophy are very, very troublesome problem. So you comment, Dr. Umesh.
Dr. Lohane, you are very right. As you have already said, the glycemic control is most important. Because many patients come with us with knee pain, ankle pain, and once you control the diabetes, it improves automatically. This is one. Second is genetical predisposition. There are certain diseases which is genetically predisposed where we cannot prevent. Third, the most important part that can be prevented is good health by regular exercises, proper physical activity, proper posturing. These are the three conditions by which you can prevent at least many of this type of diseases. This is well known. So, asking the patient to regular walk or regular physical activity and movement of all the joints. Use proper shoe. This is also important. The use of proper shoe is very significant. So these are the few points that can at least reduces the incidence or reduces the progress of the disease.
Well, one thing more I would like to know from you. Nowadays it has become a very common practice to prescribe vitamin D and calcium to all patients in the hope that this musculoskeletal problem will be either reduced or will be prevented. So what is your comment on this issue?
This is a very important issue.
Has it got any correlation with
it is a very important issue. As far as vitamin D is concerned, you all will agree that I don't know what is the reason behind it, but 90% of the patients, if you ask the vitamin D, it is low. In 90% of patients, it is found to be low. How clinical correlation very difficult. But in our clinical practice, we have seen that the polymyalgia type of things sometimes clinically improves with use of vitamin D. As far as other effect is concerned, that is the other part. But as far as this musculoskeletal part is concerned, the use of vitamin D in certain cases, yes, it helps in at least reducing myalgia or arthralgia like things. But as far as arthritis is concerned, no, it is not very useful.
Thank you very much, Dr. Umesh, for wonderful deliberation. I know you have run API Jharkhand and you have experience of running IMA Jharkhand chapter very effectively, and I am quite sure, and we all are very hopeful that under your leadership, Ccdsicon Bihar and Jharkhand will reach newer heights, and hope to see you all with your team at Jamshedpur during next annual conference. So all the best. And again I repeat, I did not ask you a question, I just invited your comment on these issues, because in chairman oration there is no scope for question. So thank you very much. Thank you.
और सभी dignitaries से I would request all of you to kindly remain on the stage and come forward for the photograph, official photo opportunity. Once again, thank you so much to each one of you. Thank you so much, sir. I would request all of you to kindly have your faces. And now we are all set to commence our next session, which is the 8th session. And in order to moderate this particular session, I would now like to join on stage our honorable and esteemed moderator, Dr. R. Chaudhary, sir, who has come all the way from Delhi in order to attend this particular conference. A very, very warm welcome to you, sir, once again. And let's have a huge round of applause in the honor of our moderator, Dr. R. Chaudhary, sir. I would now like to hand over the proceedings of this particular session to you, sir. Thank you so much.
Good morning, everybody. This session is Heart Failure Symposium, and the chairpersons are Dr. Amit Kumar Sinha from Gaya. Is Dr. Amit? Dr. Nitish Kumar Ranjan from Patna. Is Dr. Nitish is here? Dr. Sushant Kumar Pathak from Patna. For chairing this session. Dr. B.K. Sharma. Dr. Samsad. For this session, we have 4 speakers, but there will be a slight change in the schedule of the speakers. First of all, we'll invite Dr. E. Prabhu, and I will request. The subject is heart failure in elderly.
Good morning. Dr. E. Prabhu is a founder and he is the master of clinical nuclear imaging department. He is head.
Good morning, most respected Chairman. In fact, I bring with me the warm greetings of the physicians of Association of Physicians of India, Tamil Nadu, as its chairperson. I consider this as a pilgrimage. Also, The founding fathers of the APA, Dr. P.P. Thakur, I got an opportunity and get blessed by him. And it is an amazing experience to be under the virtual leadership of the medical education and the practice of medicine in general. In fact, I like this opportunity to share a few of my thought process about the challenges as we physicians face in management of heart failure in elderly. There are a lot of, as physicians over a period of time, we already know that heart failure is more commonly prevalent as and when we grow older. In India, we still have rheumatic heart disease in many parts of our country. Hypertension, diabetes, ischemic heart disease, coronary heart disease, everything is a major cause of heart failure. And elderly people suffer from preserved ejection fraction, heart failure with HPF and with multiple comorbidities and atrial fibrillation and all, that may limit the symptomatic improvement. They are already on major drugs. Many of them we visit, they will be taking a handful of drugs in the morning, a handful in the afternoon, handful in the night, in addition to a lot of Ayurvedic preparation, home remedies and all. And there may be other comorbidities like acute kidney, like chronic kidney disease, bronchial asthma, COPD and all. So many other medications that we have to rightly balance when we are managing them. There are other psychological, so many other untold amount of factors that will intervene in the management of heart failure in elderly, socio-economically. And some of them may have a friend, their son or daughter, whose friend is a physician in US. They will be advising something in parallel to what we are going to treat. So many other challenges we normally face. Heart failure, as previously it was simple. Heart failures are preserved ejection fraction and heart failure with reduced ejection fraction. Then as and when technology advanced, the AHA revised its guidelines as HRF, moderately reduced ejection fraction was inserted, then preserved ejection fraction. Then it further subclassified with so many other based on the LV ejection fraction. Then nowadays we are also hearing about improved ejection fraction, heart failure with improved ejection fraction. Talking about elderly, it is very difficult to set a time limit, age limit for being an elderly nowadays. So when we went through the data about the age associated risk factors, in our practice we suddenly see a lot of government people who become older overnight. 60 years they'll be all right. 61st year we find that they have become old. But generally, because of the advancement of science and technology, nutrition status and all, the average person in most of the developed metros and all, it is about 89 to 90 years. As a consequence, the cost, one of the price we pay for living longer is heart. And we can see that the numbers are higher on always on the right side. There are several comorbidities that happens as and when the patient becomes older. These are the risk factors: obesity, hypertension, diabetes, current smoking, previous MI itself is a predisposition for heart failure, previous atrial fibrillation that increases morbidity. The clinical scenario. This is one condition where we commonly come across 83-year-old man with the COPD, diabetic, hypertensive, medication, smoker for more than 30 cigarettes a day. And he is on a variety of drugs because he had an effort angina about 20 years ago. He underwent an intervention and echo showed atypical dyskinesia, LVEF about 40%. He underwent coronary angiography, all three vessels were diseased. And after about 15-20 years, he developed retrosinal chest pain. PCI was done. The patient became more symptomatic and he was put on optimum medical treatment. Diabetic medications and hypertensive medications were further optimized. And then subsequently when he came to us, it was LVEF was about 19%. He had dilated ventricles, reversible perfusion defect in antiseptal inferior lateral leads, fixed perfusion defect in anterior wall, and he was managed with standard routine of medications, and now he is asymptomatic, he is on regular follow-up. This is one clinical scenario we get. The other one is a female, 84-year-old, long-standing hypertension, diabetes, increasing breathlessness and dyskinesia. By and large, this lady was living all by herself. She has a software engineer son who is in States and a medical doctor who is, lives in UK. And as a consequence, she has nobody else with her. She lives all the way alone. And she used to go to her neighborhood shops for purchasing her provisions. And of late, she has noticed that it has become increasingly difficult. And her friends and the caretaker takes care of her, support her once in a while. And she was put on a variety of medications. She had hypertension, diabetes, serum creatinine was on the higher side, cholesterol was 330, LDL was high, and the BNP level was 430. This is one of the risk factors. We can help us to diagnose heart failure. Echo no wall motion abnormality, and it was there. Left ventricular hypertrophy was there, and EF was about 52%. The third scenario is a male CKD with end-stage renal disease, heart failure, diabetes, shortness of birth, progressive edema, liver limbs, 6 months for about 6 months duration. The person denied that he has fever, easy cough, tightness of chest, any of the such complaints. But otherwise, he was asymptomatic. ECG had sinus rhythm, RBB, LAFB, and all. And the blood test and all was routine done, and it was found out that NT-proBNP was elevated. These are the common clinical scenarios we come across when you are managing heart failure in elderly. There are few challenges in the diagnosis of heart failure in elderly. Prevalence of it is abnormal systolic function of more than that indicates a mortality of almost 30% or more. Elderly with normal systolic function with indicates the possibility of mortality in the next 5 years will be about 40%. The other symptoms like dyspnea, orthopnea, peripheral edema may also be the cause of increasing severity of heart failure. Only thing is we have to use whatever investigations we have to objectively evaluate heart failure and carefully select the patient who are to be benefited. If you are planning for a higher intervention, and we have to keep into so many other considerations, including the cost factor to keep into while handling heart failure. And the prevalence, as we know, is increases with age. And contemporary clinical trials, when I went through the literature, more than 960 clinical trials are available in heart failure management. It is very difficult. Each and every clinical trial has its own strengths and weaknesses. So I thought I will keep away from clinical trials because it is more for the researchers and not for the practitioners. Women with heart failure. This is something which we are wondering because most of the women, they don't complain. And they don't even understand that they are at higher risk. And they often complain of atypical symptoms, what we call in Tamil as Kai-Kaal-Karichal syndromes. And they delay seeking medical attention. They try to go for all sorts of home remedies. They are less likely to be, they think that for heart disease is less common in women. They are not treated by cardiologists in highly equipped centers. And they give some simple home remedies and simple pharmaceutical therapy. They don't get access to all sorts of coronary interventions, and they don't have access to secondary preventive programs. They are older by the time they report to us with a variety of comorbidities, and there are several psychosociological and economical factors. And when the literature also says that women are less studied in all the clinical trials. Many of them, they do have CR breast and lung and all, for which people are exposed to untold volumes of antimetabolites and radiotherapy. This inherently reduces the volume of the cardiac muscles, and we can see that they have, because of the hypertension, it precipitates and endothelial dysfunction, then the thrombosis. So all these factors influence the cause of heart failure in chemotherapy patients. There is a distinction pathology process involved. There is increased collapse of the bone collagen distribution. There will be a larger scar tissue. Then there will be altered calcium and handling metabolism by the myocytes. The mitochondria is less, so since the mitochondria is less, the ATP production will be less. And there will be decreased telomeric length. Telomeric length, nowadays we are studying for understanding the prognosis of the patient. And there is a decreased telomeric length in all these patients. As a consequence, it causes cell dilatation and hypertrophy, which results in heart failure. And also there is neuroendocrine mechanisms. Several neuroendocrine mechanisms are involved. These are the just broad outline how the neuroendocrine mechanism works. Bottom line is There is an imbalance between the vasoconstrictive effect and the vasodilatory factors. This causes the myocardial stretch, that ANP, BNP, all these things are being secreted as a consequence, and this causes LV dilatation and hypertrophy. When the relationship between the ejection fraction and volume, LV volume is calculated, this is how as and when the volume increases, the EF comes down, and these are the main culprits. The coronary risk factors are the hypertension, diabetes, obesity, they are the major contributors for the volume, increase in volume and decrease in contractile function. These are just to list out the common causes or differential diagnosis of the patients. The common causes include rheumatic heart disease, MI, history of previous MI, coronary artery disease, LVH, renal vascular hypertension, atrial fibrillation, rapid ventricular response, anemia, thyrotoxicosis, and infiltrating proteins in the myocardium. And the risk factors include COPD, hypothyroidism, depression, anemia, diabetes, venous insufficiency, liver diseases, pulmonary embolism, renal parameters. When things were all happening, the president of the American Heart Association and so many renowned experts all over the world, they become very alarmed. They were wondering why there is increasing incidence of heart failure. A lot of thought processes were applied, and they found out they listed out some of the missed opportunities where the preventive causes of heart diseases can be avoided. This is where we lack. Failure to make the risk factors and appropriate modifications as and when we are handling the patients. Failure to elicit what are the patient's requirements and goals. We fail to understand. There is also failure to diagnose. There is hesitancy in using advanced treatments and advanced investigation modalities. And some of the proven lines, they were not being used, and there was what you call tendency to use what are the modern medications and what are modern methods. And the failure to give supportive care. These were the various areas where we slip up in the management of heart failure patients. Just gives to some of the managing pathway. If the patient becomes sick and we need to hospitalize them, this is the pathway it is. Initial contact, when we are to alert the hospitalization, and when the patient is put into emergency, and then to manage once the patient's clinical condition is stabilized, the patient is comfortable for discharge. Once we discharge them, we have to follow. That means that we have to involve a multidisciplinary team. The trick of management heart failure successfully, it involves the multidisciplinary team. Nobody can say that I am the only fellow who can handle, I am the only stakeholder. So we have to establish, as a team leader, as a physician, we have to establish a clear-cut pathway in handling all these situations. The role of cardiac biomarkers. There was an interesting study like Satyam Butti and his team. They published in the Indian Heart Journal, in which they said that in India the incidence happens in lesser age group than compared to the Western population, and the incidence of heart failure relatively less, about 15 to 18% is lesser than what is in the Western population. There are different biological processes in the sense more of inflammation, oxidative stress, neurohormonal activation happens in Indian patients, and there are other biomedical. This is how it is. The pro-BNP is found in the intracellular level, and the extracellular compartment, the anti-BNP is produced. So by estimating that, we'll be able to understand heart failure. These are when we are interpreting the BNP results, we have to keep it in mind that these are the other conditions that causes BNP elevation, like LV dysfunction, previous heart failure, advanced age, renal dysfunction, acute coronary syndrome, lung disease, pulmonary embolism, high output status and all. At the same time, BNP levels are decreasing in obesity, in acute conditions like flash pulmonary edema, heart failures, cardiac tamponade, pericardial constriction. These are the imaging options we have as of now. We have the ECG, echo in the hands of a very skilled operator. It is the best possible equipment, gives the maximum amount of information at the bedside of the patient. And we have the chest X-ray. We were taught by the conventional old methods. When we look at the chest X-ray, we give volume of information, treadmill test, and of course the cardiac spectrum and all. Being a nuclear medicine physician, I thought I should not leave the opportunity to learn what we do in nuclear medicine to understand the cardiac function. By using nuclear medicine methods, we can assess myocardial ischemia, we can find out global or regional LV viability, we can understand the LV function preservation, regional wall motion functions, LV ejection volumes, LV volumes, and there is the eccentricity of LV thickening and LV desynchrony, and assess which are the which segment to contact when you are planning for cardiac desynchronization therapy. This is what I do in my practice. Whenever a patient comes with heart failure, we do a myocardial perfusion study, classify whether it is HPF or HRF. If it is extensive coronary artery disease, we do when the viability is present, revascularize, put a CABG stent, whatever it is, to restore the viability. If there is no viability is present, we have to go for guideline directed medical therapy. And this ICT, CRT, VAD transplantation, they are very expensive procedures, and we have to reserve it if the patient's lifespan is expected to be more than 1 year. Otherwise, we don't generally opt for it. We still maintain it in the guideline directed medical therapy. There are so many other trials, like the STITCH trial, COURAGE trial, so many trials told that if you give optimal medical therapy, that is as good as there is any intervention. In the event of reduced ejection fraction, there is no extensive cardiac coronary artery disease, we have to go study the cardiac sympathetic innervation by doing MABG studies. By doing iodine 123 or 131 MABG spec, we will be able to identify any abnormal innervations there, infiltrative heart disease like amyloidosis, sarkar disease, all these are present. Just to give an idea how the LV function normally looks like, how it is seen in a nuclear scan, and when its heart is dilated, the images will speak for themselves. This is a generic plot. We need not get carried away with the coronary arteries. This is just a generic diagrammatic representation, and we can see how the ventricle is dilated when compared to the normal ventricular size. And the same patient, we can do a SPEC CT also, where we can see the anatomical as well as function information. Some of the patients we do find in patients severely breathless and acute conditions, pulmonary pleural effusion and all. And we have, this is something which I want to sensitize in the sense, Bihar quickly is going to have this gallium-68 pentoxifar. Once the PET-CT becomes functional in AIMS Patna, I think Dr. Pankaj Sinha will be more than happy to provide all these services to image myocardial information with gallium-68 pentoxifar. And fibroblast activity where extensive fibrosis and scar formation can be imaged by using FAPI scans. Gallium-68 FAPI scans, it gives us information about the inflammation and fibrosis. We can also image myocardial apoptosis by using annexin. This is the images we get in annexin images which we will be seeing. And this is for the iodine 123, iodine 123 MABG spec for innervation. We also see the amyloid protein deposits where we will be able to quantify the amyloid proteins when there is heart is not seen, it is normal. When it is equal to the mediastinum, it is slightly increased, and we can see the amyloid deposits in the heart. And also extracardiac sarkite with the help of PET-CT. There are strategies which help in nuclear cardiology helps in patients who are going, just a minute, I will finish off. Where this is both during the pre-treatment process for establishing the baseline heart function and monitoring the therapy and the post-therapeutic surveillance of the patient to be able to find out heart failure. Just to summarize what the strengths and weaknesses of so many other modalities, and it says that if we have a good echocardiogram and which can be put into routine use, it gives a lot of information. In the management of heart failure, there was a study done by Hari Krishnan, Abraham Oman and his team, and it found out that in India we are already treating with diuretics, AC inhibitors, beta blockers, spinal lockdown, and SGLT inhibitors, angiotensin inhibitors, digoxin. So many other drugs were there, and this was the treatment outcome. And this is the current strategy for HPF and HRF. We are extensively using ARNIs, beta blockers, SGLT inhibitors, and mineralocorticoid antagonists. We cannot treat heart failure without mentioning a word about SGLT inhibitors. This is a wonder drug, and we can see the patient become symptomatically improved, and it gives a dramatic clinical improvement of the patient over a period of time. And to sum up, heart failure is more prevalent in elderly. It's a multidisciplinary approach in managing, in the sense that it causes structural, functional, clinical, social, socio-economical, so many other manifestations are there in heart failure. Genetics has its own role, then the sedentary lifestyle, tobacco, diet, hypertension, obesity, CAD, and so many other factors are involved. You have to do BMP and anti-proBNP, non-invasive imaging modality should be optimally used, and the fantastic four, SGLT inhibitors, RNAs, MRAs, beta blockers should be used, and device therapy can be used, more expensive interventions can be used only when we clinically suspect that the life expectancy is more than 1 year. Thank you very much.
Thank you, Dr. Prabhu, for your excellent talk. I would like that, as in the introduction I told, in elderly, they all suffer from comorbid like hypertension, diabetes, CAD, but AIDS itself is a problem.
Yes.
But and they have both type of systolic, that is preserved ejection pressure, reduced ejection pressure.
Yes.
That is there.
Yes.
But where is the indication? Which do you do nuclear imaging in all the cases of heart failure and elderly? Or is there a specific indication?
If in the event of a strong clinical suspicion, there is a heart failure, when I have access to a good nuclear medicine laboratory, I would prefer to do for all patients in the sense that it is not an invasive procedure at all. There is no radiation risk. We are going to introduce very microgram, nanogram of a substance to the body, and he is going to continuously emit gamma rays, which we can track down. And this gives a three-dimensional information about the left ventricle, the ejection fraction, the amount of perfusion, and it helps us to understand whatever treatment we adopt, whether it is optimally working or we have to modify the line of management. If any intervention has to be done, like for example, CRT has to be done, and if you are placing a CRT, which is a viable segment of the huge big dilated heart, all these things can be understood by a simple test and takes only about 20 minutes. Patient is comfortable, and modern methods are available where in patients who are having severe overload, breathlessness, they are not able to lie supine. We can make the patient sit and take a picture and know where the machine comes in contact. I think if the facility is available, I would prefer to do it for all the patients, irrespective of the age, and especially in the older age group where there is no intervention involved.
Thank you, Dr. Prabhu, for your brilliant talk.
One more thing, when we consider nuclear medicine, nuclear imaging for our cardiac patient, usually we are not in a way to prescribe nuclear imaging for every patient of heart failure. There are specific guidelines. First of all, when we need to say that where there is a perfusion mismatch, that whether we are dealing with a non-viable myocardium or not. So usually whenever we do an angiogram, and if the vessel is 100% occluded and we are not sure whether the revascularization is going to help this patient or not. Second thing, when we need to document stress-induced ischemia, if it is leading to LV dysfunction and heart failure. And third, the third is the context where your statement might be partially correct. These are those patients, especially CKD patients or those patients in which an angiogram could not be done, those patients who are in heart failure. So in these patients, nuclear imaging is quite helpful to determine whether ischemia is there or not. But going to say that doing nuclear imaging in every patient of heart failure, I don't think it can be an apt.
Yes, I fully agree. It's a valuable comment. One is during the early stages, there was no limited access to nuclear medicine department. Number one. Number two is heart is already dilated. When you are injecting about 120 ml of dye and in a compromised kidney function, you are already challenging the heart and already challenging the kidney, which is hyperperfused. I would rather recommend that this should be done, intervention procedure should be done only when you are planning for any sort of other higher intervention like putting a CRT or doing a bypass or any stent or something of that. If you are planning for the patient, only then it has to be done. And if we went through the guidelines, during the early stage they preferred angiogram because it was easily available. Every institution had an access to their coronary angiogram. There were no regulation as such. Every cardiologist was able to do intervention procedures. When you go through the recent guidelines, now everybody is now asking for nuclear test as a first modality in the sense next only to echo. The reason is it is now more easily accessible, and it is now better equipment, better technology, better radiopharmaceuticals, better understanding has come. So if we have access to a nuclear medicine department, I think the best is next only to echocardiogram. This should be the first modality. And when the patient doesn't want any sort of further interventions, but then we need other further information how to proceed in this given clinical condition, I would rather strongly recommend that we should go for a nuclear test.
Thank you.
Thank you, Dr. Prabhu.
Thank you, sir.
I request the organizers.
Hello. Excuse me, Mukta. One more question. Sir, excellent presentation, sir. And I think you left no corner. But for management of heart failure in elderly, I think it should also be individualized. I am putting some examples. Like it is common in our geographical area, a patient with heart rate of 40 comes with presentation of shortness of breath on exertion. When you do ECG, you say that this is a complete heart block. But patient does not say he has any syncopal attack. He has occasional dizziness but no syncope. So in that group of patients, you need pacing. Pacing will improve your patient. In second group of patients, suppose a patient of elderly patients, there is with a case of CKD, there is chances of, if he is on dialysis or without dialysis, chances of pericardial effusion. So in that group of patients, we should, and we do echo, ejection fraction is normal, but there is pericardial effusion, and maybe if no cardiac tamponade, there may be effusive constrictive physiology. In that group of patients, the management plan will be different. Coming to the next patient, if a patient of LVH, since atrial fibrillations are common in elder group of patients, and a patient with left ventricular hypertrophy, if goes in recurrent atrial fibrillation, there will be recurrent deterioration, recurrent chances of heart failure. The treatment will be different. Patient have normal EF, that may be diastolic dysfunction. Patient may have heart maybe in the group of heart failure with preserved ejection fraction. Fourth patient, elderly group of patients may have aortic stenosis. In that group of patients, dyspnea is also the cause, and that may lead to heart failure, symptoms of heart failure. In that group of patients also, the treatment plan will be different. So, whenever we are dealing with a patient of heart failure in elderly group, it should be individualized. Thank you.
I fully agree. As a physician in a community practice, if we don't have access to all the modern investigation modalities, our bare hands and the clinical information, the way somebody walks in, talks in front of us, choice of all the clinical skills that are put into forth, that is the most powerful. But then, when we need certain evidences to convince the patient to make them adhere to a line of management, then we need some investigations.
Definitely, sir.
And that has to be investigated, that has to be optimized, depending upon the availability, accessibility, affordability, and so many other factors by the patient.
Thank you, sir.
Thank you, sir.
Thank you so much, sir. And I would now request Dr. D.K. Sharma, sir, to come forward and have our wonderful speaker, Dr. E. Prabhu, sir, personal candidate from Chennai, in order to be present over here. And I would request all of you to kindly put your hands together for Dr. E. Prabhu. Put your hands together. I would request all the
I'd like to congratulate the anchor, the first place, right from the day I come, as she has been doing a wonderful performance, getting everybody together, not allowing anybody to sleep. That is fantastic.
Thank you so much, sir. I would request all of you to kindly put your hands together for Dr. E. Prabhu, sir, and for our honorable chairpersons, and for our esteemed moderator, director. And it's a very, very beautiful moment for each one of us. एक बार शानदार तालियां आप सभी लोगों की ओर से। And it's been truly an honor and delight for each one of us to have you over here, sir. We expect that you too have a very amazing experience over there.
Thank you, Vita. The next speaker is Dr. Chandmohan Belawa from Dehradun. Dr. Chandramohan, please introduce. The subject is heart failure with preserved ejection fraction.
As we know that heart failure treatment with preserved ejection fraction and reduced ejection fraction, the management is different. And we are going to discuss first heart failure with preserved ejection fraction. Dr. Chandramohan Belwal will speak on this subject, and he is DM Cardiology Associate Professor, Department of Cardiology, Himalayan Hospital, Dehradun. Dr. Chandramohan, please.
A very warm good morning to all. First of all, I would like to thank Clinical Cardio-Diabetic Society of Bihar and Jharkhand and my dear friend Dr. Sumit Kumar Verma, who invited me over here and gave me an opportunity to come back to Bihar, where I pursued my MD, to meet all my senior colleagues, my juniors, my respected sir, who's sitting in the front row. Thanks to all. And today my topic of discussion is heart failure with preserved ejection fraction. Heart failure itself is a very big topic which cannot be, whole spectrum cannot be covered in 15 minutes or 20 minutes. But I would like to give you an overview and the updated version of its evaluation and management, which has been recently revised in 2022 by the AHA and ACC guidelines, So we'll start with. So heart failure is a clinical syndrome. We need not to go into detail of the symptoms and signs, but it's not. So heart failure has two clear-cut subtypes of heart failure which we come across in our daily practice and when we see the patient. And two are very clear subtypes. One is with reduced ejection fraction and one is with preserved ejection fraction. That is there since our 2012 ACC guidelines came, and before that also. Initially it was known by systolic and diastolic heart failure. Older than that, forward and backward heart failure. But later on, when all the guidelines and the consensus came that it should be classified on the basis of ejection fraction, so two clear-cut denominations were given. One is with reduced ejection fraction, in which LVEF is less than 40%, and with preserved ejection fraction, in which LVEF is more than 50%. And it is mostly because of the systolic heart failure, the pump failure, that ejection fraction has gone down. And in preserved ejection fraction, it is because of the diastolic function, the relaxation of the myocardium is impaired, so that the filling is impaired, and it is preserved, the ejection fraction is preserved. And there, in 2015-16 guidelines, then there one more term came into existence, that mid-range or mildly reduced ejection fraction, because there was a gap, less than 40%, more than 50%, but the gap of 41 to 49% was there, so it was named mid-range ejection fraction with heart failure. It was till 2022 that this nomenclature was coming, and it was in practice that there is reduced ejection fraction, preserved ejection fraction, and there is mid-range ejection fraction. Then in 2022 AHA guidelines, one more term came, heart failure with improved ejection fraction. Why it came? Because it was evident and it was shown that the category of heart failure, either reduced or either preserved, it never goes, it's never same. Preserved ejection fraction tend to be reduced ejection fraction after some time, or if there is any precipitating factor. Sometimes the reduced ejection fraction improved to preserved ejection fraction, or mid-range improved to preserved ejection fraction. So now the term gains trajectory of heart failure, like our
sir showed in last image. So the improved ejection fraction is said when the previous evaluation showed that ejection fraction was less than 40% and subsequently the ejection fraction improved. So now the latest guidelines talk about the trajectory of heart failure, which gives you an initial evaluation and subsequent evaluation. If initial evaluation your ejection fraction was reduced, it can move in two directions. It can reduce further and remain in the same category, or it can improve and come into improved ejection fraction, like in myocarditis. Sometimes if patient is having viral myocarditis, or we see in a lot of patients in corona pandemic, a lot of patients came with reduced ejection fraction heart failure because of myocarditis, subsequently they improve. So this category. Mid-range can go anywhere. It can go into reduced, it can go into preserved, it can remain into mid-range. And preserved, if there is any coronary artery disease or any valvular heart disease, it can move backward into reduced, or it can go up and improve. According to that, the diagnostic algorithm was given, the updated diagnostic algorithm. We do the clinically, we assess, we diagnose heart failure as a clinical syndrome. We see the echocardiography, EF is assessed, and then we put them in this category. So the proportion of, it has been shown that proportion of the preserved or mid-range ejection fraction is increasing day by day because of the comorbidities and increasing living age of the patient. We are coming across with increased population of mid-range and preserved ejection fraction. Can it be diagnosed clinically, preserved ejection fraction? No, you cannot diagnose it clinically, because clinically you can diagnose heart failure. But how to say or how to label it? So in 2022 ACC guidelines, first time a clinical score is given, which has 6 variables, and there is a score of more than 6 or less than 2, and this gives you a likelihood of preserved ejection fraction heart failure, if there is. So what are these variables? Is obesity, then atrial fibrillation, age more than 60 years, treatment with antihypertensive medications, and echocardiographic parameter of diastolic functions, and PA systolic pressure. These 6 variables are used. If it is less than 2, then likelihood is very low. If it is more than 6, likelihood is very high. Now what is the pathophysiology of heart failure? Like I told, it is none but diastolic dysfunction of the patient. The systolic function is preserved, but diastole, the relaxation of the myocardium is impaired, and so the filling is impaired, the preload reduces, and the diastolic or the LA pressure increases. When we see the epidemiology, we see that if you see the preserved ejection fraction, more than 55%, age is subsequently high. Age is significantly high. It is 74, while reduced ejection fraction is 68. Women are significantly higher in number in this category with preserved ejection fraction. And if you see diabetes, hyperlipidemia, these are higher in number significantly. So this makes the precipitating factor or the causative agents of the preserved ejection fraction. We see that 50% of total heart failure patients and 20% of Indian heart failure patients are heart failure with preserved ejection fraction. Compared to reduced ejection fraction, patients with preserved ejection fraction are older, more likely to be female, and more likely to have associated comorbidities like hypertension, diabetes, and atrial fibrillation, and non-cardiac comorbidities like CKD and malignancy. Now when we come about, this is our evaluation, this has nothing very challenging. Once you diagnose clinically heart failure, after that only one thing to do is echocardiography and assess the EF. But the main challenges is heart failure with preserved ejection fraction comes with treatment guidelines. Since before 2022, there was not much to offer to a patient with preserved ejection fraction as far as pharmacology is concerned. For reduced ejection fraction, we have n number of drugs for mortality benefit, morbidity benefit. But preserved ejection fraction, we are limited. So first randomized control trial for non-pharmacological, which was from 2006-2007, it showed that exercise is one of the most important factor to prevent patients who are at category 1, category B at risk or with risk factors to prevent heart failure with preserved ejection fraction physical activity, that also aerobic physical activity is more important to prevent the progression of diastolic dysfunction and to prevent heart failure with preservation. That's why a patient who is having hypertension and diabetes but no cardiac comorbidity or no cardiac dysfunction, he should always be encouraged to engage in some sort of aerobic physical activity to prevent or to delay the progression of heart failure with preserved ejection fraction. But as I said, for reduced ejection fraction, we have so many guidelines, so many drug classes to treat, to reduce the progression, to reduce the morbidity, to reduce the mortality. But when we come to preserved ejection fraction, we are dealt with nothing. So we take a case, a patient, Mrs. Lakshmi, who has hypertension and type 2 diabetes mellitus with peripheral artery disease and chronic kidney disease, means lot of comorbidities are there. She presented with complaints of fatigue, weakness, clinically diagnosed as heart failure, and her echocardiography show EF of 50%, means preserved ejection fraction heart failure. Here, what is the things, what are the pathophysiologies going on? Are that insulin resistance is there, dyslipidemia is there, hyperglycemia, family history is there, which engulfs or which sync with the pathophysiology of heart failure, of myocardial infarction, toxins, idiopathic, arrhythmia, infiltrative, and what are the common risk factors? Age, sex, race, hypertension and obesity, and leads to diastolic or heart failure with preserved ejection fraction. Why we are stressing more on the oxidative stress and the association of diabetes with heart failure? Because very recently in 2022 or 2021 to be precise, few trials have shown one class of drug which is giving us promise to be the first approved drug to reduce the morbidity and rehospitalization and CV composite death in a case of heart failure with preserved ejection fraction, which we never had before in past. What is that class of drug? It is an anti-diabetic drug, which is initially used to reduce the hyperglycemia in type 2 diabetes mellitus, but it has shown that it reduces CV composite death, it reduces rehospitalization in patients with heart failure with preserved ejection fraction. What is that class of drug? That is sodium glucose cotransporter 2 inhibitors like SGLT2 inhibitors, and they have shown to be associated with improved heart failure and cardiovascular outcomes, glycemic control, blood pressure, body weight, and diabetes. What it does? It has kidney effects, it has metabolic effects, it has blood vessels effects. It helps in glycosuria, diuresis, natriuresis, insulin sensitivity, decreased blood pressure, arterial stiffness is decreased, oxidative stress is decreased, which these all physiologies culminates into causing the diastolic dysfunction or myocardial dysfunction. They are hindered. So, first study for dapagliflozin was DELIVER trial. DAPA-HF trial came initially, which shows that dapagliflozin has mortality benefit in patients with reduced ejection fraction. But after that, a subset of heart failure who had preserved ejection fraction, the separate arm of the trial was there, DELIVER trial, which showed that with preserved ejection fraction, where the population was more than 40 years and EF was more than 40%, they were put on placebo and one arm was put on dapagliflozin. A lower risk of primary endpoints, lower risk of CV deaths. We don't say death because of heart failure. CV composite death were taken as primary endpoint. They have not separately taken the death from heart failure, CV composite heart death, fewer total worsening and similar incidence of adverse outcomes with placebo. So this was a little detail of DELIVER trial. Before that, the trial which came was Emperor Preserve. First was Emperor trial, which showed that empagliflozin, a class of SGLT2 inhibitors, was shown to reduce mortality or CV deaths in reduced ejection fraction. But after that came Emperor Preserve trial, which showed that preserved ejection fraction also SGLT2 inhibitor empagliflozin is beneficial. Then in a sprint trial, when we take the subsets of patients who had ejection fraction more than 40%, it showed that better or strict the BP control is better the outcomes. So blood pressure control is very important. Then in other class of drugs like mineralocorticoid receptor inhibitors, which was studied in TOPCAT trial, or ARBs in CHARM Preserve trial, or ARNI in Paramount HF and Paragon HF trial, they did not show to significantly reduce CV deaths or morbidity in patients with preserved ejection fraction. Though there is a subset of patients who had increased nitriuretic peptides and on the lower side of the ejection fraction. Like if we take 40% as the cutoff, we take mid-range and preserved combinedly. So when we take patient less than 40% and more than 40%, so ARBs, MRAs, and ARNI group of class, they showed improvement in patients who have higher baseline anti-proBNP and on the lower side of the ejection fraction, like 40 to 45%. But when we take cutoff as 50%, like more than 50%, they did not show much of significance as far as CV outcomes are concerned. So this is the guidelines which came in 2022 for preserved ejection fraction. We can see that patient with preserved ejection fraction, first and foremost, class 1 is hypertension control. Class 2, SGLT2A inhibitor, 2A AF control. So most promising is treatment of comorbidities like heart failure, diabetes to heart, hypertension, diabetes. Then class of drug first to be approved in 2A is SGLT2 inhibitor. 2A is treatment of atrial fibrillation, whatsoever may be the protocol for any patient is applied on this patient also. After that, MRAs or ARNI and ARBs, they all fall in 2B category, so not so promising. So again, similar picture, simplified one. If symptomatic, clinically diagnosed heart failure patient with more than 50%, give diuretic for symptomatic benefit, give SGLT2 inhibitor for morbidity and mortality benefit. Rest all, if patient has higher BNP baseline and lower side of the EF, give MRAs and ARNI and ARBs. So back to our case, now what we should do with Mrs. Lakshmi, just add SGLT2 inhibitor and our outcome will be better. So this was a basic overview for evaluation and management of preserved ejection fraction. I think in this much time we can cover this much only, and I would like to clear your seven moderators if anything to discuss.
Hello. Most important is how to diagnose a heart failure with the resistant patient. How to diagnose?
So, like diagnosing heart failure first is a clinical syndrome. A patient comes with typical features of
preserved ejection fraction.
Preserved ejection fraction. First, he should have the heart failure should be there. After that, the question arises: is this preserved ejection fraction or reduced ejection fraction? So, preserved ejection fraction. If you think that patient has typical symptoms of heart failure, which we know all that, if patient is having heart failure symptoms, after that the question arises that patient is having, then you go for transthoracic echo, get the EF. If it is heart failure with more than 50% is preserved ejection fraction. Now, to make the things easier, the ACC guidelines have given you 6 variables to concretely diagnose if there is any doubt. These are 6 variables. Score is 9. If it is more than 6, you can say with higher likelihood that patient is having heart failure with preserved ejection fraction. Over that, you should have to have a little higher threshold for diagnosing a patient. Some 50-year-old female, only hypertensive, uncontrolled hypertensive, every time she comes, like what I have seen in day-to-day practice, she is going in some clinics for some fatigue and dyspnea for so long, and she has given all types of supplements like multivitamins and nutrients and vitamin D, but this is the subset of the patient. For that you should have a lower threshold to suspect heart failure with preserved fraction. Her echo was done, which shows normal, but that time you start giving. Sir, you are saying something.
Yes, I'm saying what the role of anti-proBNP is, because what role of anti-proBNP in HFpEF, because it's very important. If you have a patient and he or she have dyspnea and you find all the parameters are within normal limit, then you should go with anti-proBNP, because it's very sensitive marker for heart failure with ejection fraction.
So like BREATHE trial and RAILS trial has already shown to rule in or to rule out as a heart failure as a cause of dyspnea, anti-proBNP is a very good marker. So you can always take help of anti-proBNP as a supplemental diagnostic tool to clear your diagnosis. But I still believe that if you diagnose heart failure clinically, NT-proBNP is mainly in the acute settings when you think that patient is dyspneic because of the heart failure or non-cardiac cause, that time it helps more. And with reduced ejection fraction, it has all prognostic and therapeutic values also. Secondly, preserved ejection fraction, like I told again and again, that those classes of drugs which are on the 2B classification, they again, you have to identify the subset who have higher baseline NT-proBNP and in the lower EF scale. For that, you can always take help of NT-proBNP as a diagnostic and to guide our treatment also.
I have one question, sir. Sir, I have one. In our undergraduate and postgraduate days, we were taught high output heart failure and low output heart failure. Are they still existence or they are deleted?
Sir, actually, that's why I told initially that these two types of heart failure which are now, like now the clear-cut guidelines are heart failure. There are many classifications to classify heart failure, stage-wise, symptoms-wise. But when we take about clinical syndrome, in this only EF has been given as a cutoff tool to classify patients as with preserved, with mid-range, with improved or with reduced ejection fraction. Sir, I could say high output and low output failure. That is again because of your cardiac function. Low output failure when your stroke volume is low. So that has been categorized into heart failure with reduced ejection fraction. High output failure when your preload is not impaired, the LV cavity is good, stroke volume is high, but patient is still having failures of like valvular heart disease, all valvular heart disease like MRAR are high output failure. So those terms have been declined or rejected, but the pathophysiology has been incorporated in our updated guidelines. The term only has been rejected.
So we'll have one comment from the chairperson.
Actually, the things have changed a lot when the universal definition of heart failure was proposed in 2021. Now it is not required that we need to go through a full battery of tests to diagnose heart failure. We need just any signs and symptoms of heart failure. Apart from that, whether a raised NT-proBNP level or a decreased ejection fraction on echocardiogram, the diagnosis of heart failure is made. Now, echocardiogram is necessary to diagnose whether we are dealing with a reduced ejection fraction or a preserved ejection fraction. So, and also when we need to go through a full battery of tests, so when we need to follow our patient, then we need all the tests which are required. But for diagnosing only NT-proBNP or echocardiogram, along with that signs and symptoms of heart failure.
So heart failure from the very first definition, it's always been diagnosed as clinical symptom. So the diagnosis of heart failure is always clinical to substantiate your diagnosis and classify it according to updated guidelines. We take NT-proBNP and 2D echocardiogram. Rest, it is still a clinical syndrome.
Thank you, Dr. Chandan, for your brilliant presentation. Please stay back. Please take your seat. Dr. Chandan. Now the next speaker is Dr. Sajid Ansari from Lucknow. That will be a virtual presentation. I request Dr. Abhishek to connect. And the speaker will introduce Dr. Sajid. Chairman will introduce Dr. Sajid Ansari.
Yeah, our next presentation will be Dr. Sajid Ansari. He is from Lucknow. Fortunately, I was there in Lucknow doing my DM training. And he has a lot of experience when it comes to management of heart failure especially. And he will talk on heart failure management in pregnancy. Yeah, I think Dr. Sajid Ansari is live now. So over to him.
Yes.
Welcome, Dr. Sajid Ansari.
Thank you, sir.
Go ahead.
Thank you, sir, and thanks all these dignitaries from this CCDSI I have seen on the dais Professor Rai and other dignitaries. Really great pleasure. I am since last 1 year associated with the CSI, my senior Dr. Burmani sir, Abhishek and everyone, Dr. Mrityunjay sir. Friends, you know, the topic given to me is heart failure during pregnancy. And this is time given to me is 15 minutes. And it is a subject that need maybe more than 15 hours to discuss the very well. Okay. So friends, you know, we divide our discussion in terms like already some subject having problem before conceiving and what the risk factor associated with pregnancy and what the hemodynamic changes after in the pregnancy. That is more important. Friends, you know, one thing that you go and see the data regarding the high risk pregnancy, it is gradually increasing day by day, and there is some definite reason behind it. Some social reason, some reason related to burden, disease burden. And important is you see the possibility of pulmonary hypertension. One thing is, if there is an absolute primary pulmonary hypertension, okay, that is absolute contraindication to pregnancy. But what about in the secondary pulmonary hypertension, secondary to cardiomyopathy, you know, peripartum and postpartum cardiomyopathy is very important. Somebody already having some well-behaved agent and she get conceived, what is their further course of treatment? So, who is on the more risk patient with a perinatal morbidity, mortality, low FCAR score, and prolonged neonatal intensive care unit stay of the mother and fetus both. So, in the past decades, as I told, this is the increasing incidence day by day. That postpartum PAH is increased by the 24% and complications in such pregnancies by the 18%. Two things are important: duration of hospitalization, the high risk pregnancy is increasing day by day, and postpartum period duration and peripartum is increasing, and complication high risk pregnancy is increasing. And heart failure does not perform only when patients subjected to NIH class 4. They are the early symptom also, and that should be came in the notice. Important thing is there is some definite physiological changes in the body, and that should be always in the, while doing echocardiography and because of hyperdynamic circulation, we are finding high velocity TRJ, and we go for the conventional calculation of PS, that might come in 50-60, that might be in the level of mild pulmonary hypertension, but that is because of hemodynamic changes. So we should be aware of what the hemodynamic changes is going in this maternal body. So there is an increase in plasma volume leading to physiological anemia, it is maternal heart rate, increased arterial blood pressure, it is systemic vascularization, that's why this causes increase in cardiac output and increased cardiac output. Discussed beginning in the early pregnancy because of an increase in stroke volume, and it is maintained further by way of tachycardia. So these are few very important changes. There is increase in cardiac output. Some of this created some hypercoagulable state, sometimes also changing the systemic vascular resistance. So this should be taken care in this notice. So this is maternal cardiovascular physiology during the pregnancy, labor and early that pregnancy there is increase in cardiac output, heart rate, stroke volume and plasma volume and LV dimension, but that is a transiently and that is reversible. If it is persisting, that is land up into cardiomyopathy. And there is decrease in systemic vascular resistance. During the labor, same thing will happen, but the patient is in the physiological stress and early puerperium and the peripartum period. The increase in systemic vascular resistance, and here that NP, BNP is a little bit rare. And reason behind it is, you know, my previous speaker was discussing, this is the hormone NP and BNP release only because stretching of myocardial fiber, and at this time, stretching of the myocardial fiber is on the highest level for NP and BNP, but that is not absolutely pathological, and there is a decrease in cardiac output in the early period. So, maternal and cardiovascular physiology, pregnancy, labor, and as I discussed in nutshell, that is going to happen. And what the cause and timing of heart failure? If you see broadly divide this heart failure in the maternal group, itself pregnancy can lead to heart failure. Their prior disease, especially well-behaved diseases, like me practicing in the cardiology and not my major patient in from this corporate sector. So we have a lot of patients, they are coming to us during the primary pregnancy and they are having the mitral stenosis, the pulmonary hypertension. And believe me, they know that she is having mitral stenosis because of social reason. These things is not going to explain to the at time of marriage, and when we are taking the history in the secretary, then the lady thinks, yes, I know I am because the marriage is necessary, and I go for the marriage, and she is having pulmonary hypertension, mitral stenosis. So that is a very, very important thing. Mitral stenosis is one of them. Then pulmonary hypertension, isolated pulmonary hypertension, and primary pulmonary hypertension, vasculitis sort of things is more common in female. We know of ischemic origin and congenital heart disease. There is congenital heart disease of adult also that persisting, and that is the one important cause. So divided the peripartum dilated familial hypertrophic ARVD myocarditis and chemotherapy related like this ischemic heart disease and chronic ischemic heart disease, pulmonary hypertension is, if it is a primary pulmonary hypertension, really it is a dangerous story. Some valvular heart disease, all kind of valvular heart disease and congenital heart disease also. Causes of heart failure is mentioned in the different trials, and this is ROPEC and national inpatient sample obtained through this healthcare cost. But if you go and see the data in a detail, what the exact story. So there is a peripartum cardiomyopathy, and this is going to increase. Important is how to overcome this problem, and that is more important. So if you go and consider timing of heart failure, so if we think of peripartum cardiomyopathy, or the peripartum cardiomyopathy can occur at any time of pregnancy, but most commonly occurs in the last trimester or in the 6th week of postpartum period. However, peripartum cardiomyopathy has been described as a late 5 to 12 months of delivery. Also, late onset was associated with 2 to 3-fold increase in risk of maternal mortality and MACE. Here, one thing is very subject to debate and discussion. Is it true that all the peripartum cardiomyopathy is reversible? No, this is not absolutely reversible. This is entirely dependent on the comorbidity of patient and what is going to happen in that part of time. I have so many patients that they are having poor LV function, improving LV function, still having some high and LV feeding pressure, the advanced diastolic dysfunction, but they are improving and doing gradually well. Same thing is here that this is a risk factor for heart failure associated with pregnancy, as I discussed, that the incidence is the highest among the black women and the lowest among the Hispanic women, as it is true for the maternal heart failure overall. Association between PPCM and pre-eclampsia is well established according to approximately 1/3 of the women. If you see this data and diagram, there is so many risk factors mentioned, and you know right now because of this corporate culture and everyone thinks to be when I will become stabilized and get married. So late marriage is very important because in the 35, sometimes 35, 36 like this. So the advancing is a very important concern. Anyway, there is some modifiable risk factors and non-modifiable risk factors also. So in the modifiable, obesity, tobacco use, alcohol, then hyperlipidemia, hypertension, and this is a sort of things. And there is some obstructive risk factor also, pre-eclampsia, eclampsia, gestational hypertension, gestational diabetes is the important concern. Then placenta previa, abruptio placenta, and multiple gestation, and there is comorbidity as I discussed, hypertension, CAD, NYHA class 2, pre-pregnancy heart failure, and CKD in the diabetes. So if this all together is there, there is definitely worse outcome is there, and no discussion about it. But how to overcome this is a combined effort from the gynecologist and this physician and the cardiologist. So I think when we are going to diagnose the peripartum cardiomyopathy, one thing is the timing. Discussed. The most common is just before pregnancy up to 6 weeks, and if there is no history of clear-cut shortness of breath, and if there during the antenatal period there is a clear-cut ECG, and I know that right now smart gynecologists always in the every trimester they are asking for the echocardiography. If previous echo is looking normal, so you make it that it is of the recent origin. Anyway, development of heart failure, we take the clinical history and the risk factor as disease, frequent descent, high blood pressure, prior toxin, and use of certain medication to prevent the premature labor. If you're going for these causes, undefined post-viral illness, abnormal immune response, nutritional deficiencies, coronary artery disease, small vessel disease, defective antioxidant defense, and genetic. One thing not mentioned here, cardiomyopathy, that is not entirely without pregnancy. Sometimes because of over stress and that is, we know, apical bilirubinemia, and that is especially for the diagnosis of this echocardiography where exactly presentation. So that can be stress in this cardiomyopathy can be transiently happen with this kind of patient. And then dimension, of course, if you diagnose with dilated cardiomyopathy, pericardial diagnostic criteria is same. LLV dilated, high and failing pressure, usually diastolic dimension more than the normally we know this should be more than 5.8 to 6 centimeters. I'm not telling what the index will be dimension, and ejection fraction it should be less than at least 40 when you are telling that LLV dilated and low ejection fraction. Up to anyway, we know that right now newer criteria for half-ref even divided 3-4 category by ACC, reduced ejection fraction, mid-range ejection fraction, improve ejection fraction. That then you can apply here also. That is for clinical concern how our patient is behaving. As we discussed, we go for the differential diagnosis. Tachycardia is the very important one. Familial cardiomyopathy, genetic counseling needed. Pre-excitation syndrome and tachycardia induced cardiomyopathy is very important one, and never forget. Recurrent pericardium, pre-excitation, hypertrophic cardiomyopathy here, LV is not dilated here because the gradient is there and there is a high and pressure. Myocarditis, ARVD, LVOT, non-compaction, some chemotherapy, and that's why this that whenever you are going for this chemo, there is mandatory to go for the stress imaging and say the LGR stain, valvular disease, congenital heart disease, tachycardia-induced cardiomyopathy, hypertensive heart disease, all these sort of things should be always in the pulmonary embolism. Acute pulmonary embolism is not supposed to be, because in that condition usually right side heart is dilated, but if you diagnose with dilated cardiomyopathy, that is again. The sign and symptom usually started with tachy, fatigue, dyspnea, edema, middle edema, shortness of breath, dyspnea and exhaustion, orthopnea very important, flares, weird sound, cough, and hepatitis. So, no need to discuss this as a audience here. What is the outcome? So, pericardial cardiac, 4 cases reported a different outcome. So, outcome is, as I discussed, practically in my practice also, a few patients really they are recovering well within the 1 to 2 weeks after this, but few are not getting it. So, this is data, and this is very small data, but this is in practical, this is going to happen. So serial monitoring during a subsequent pregnancy. So I know a smart gynecologist is starting from this post-conceiving from the every trimester. They are getting thorough cardiac investigation, and I have seen that from the corporate culture in the last trimester of pregnancy, they are asking from this pro-BNP also, anti-pro-BNP also. And they try to explain in which category you are falling, because in the era of this everything is going for the litigation, so it is important to be on this safer side. So this clinical assessment, echocardiogram, BNP should be performed at a regular interval with any concerning symptom, and this has been shown that how you judge the clinical. Coming to important aspect, how to treat the patient, and this is a big challenge. Suppose the patient of mitral stenosis already known as she is in atrial fibrillation, she needs some anticoagulation, how would you treat it? So there is a guideline for this, and no need to discuss in the detail here, but some dose modification and some things needed like this. So conventionally, if there is some emergency, something, ideally in the first trimester, you should try to avoid whatever possible. In the second, third trimester, if there is needed, you can go for loop diuretic and some beta blockers and low molecular weight parins, but don't give ACE-ARB and aldosterone. whatever possible you go for the early delivery. During a delivery, plan ahead with a cardio-obstructive team and fully equipped team. If unstable, consider hemodynamic monitoring and optimization. Caution for fluid overload, especially after the delivery. Yes, and after pregnancy, we know. Just to keep in the mind that if breastfeeding, which drug should be avoided, otherwise you can come for the conventional treatment. And here the issue is anticoagulation for the LV thrombus. Usually LV thrombus, I think in the cardiomyopathy, my cardiologist friend is sitting here, LV thrombus is not a very common. I find very few apical thrombus, and when we send it for intervention, that patient is gone. The problem is LA thrombus while the patient treating it is especially post-mitral stenosis, atrial fibrillation, and rhythm disorder. So again we can start the anticoagulation. Problem is the breastfeeding. And now here the debate and discussion that in the era of RNA and SGLT2 inhibitor in the peripartum postpartum cardiomyopathy can be used. Before that trial was there is no because of excision in the male, but some trial is going on that after the delivery you treat your patient like dilated cardiomyopathy to improve outcome of this mother. This depends on and living on your discussion and discussion. So I think there is a time constraint, so I will leave here. Thank you, and leaving some time for discussion because we know where our seniors is sitting. So thank you, this all from my side, and welcome for any comments and questions.
Yes, thank you, sir. That was a wonderful talk, especially on this topic, because there are a lot of confusions how to manage this patient. When it comes to management of heart failure in pregnancy, usually we talk about 4 pillars of management in heart failure. Beta blockers, ARNIs, MRAs, and SGLT2 inhibitors. But when it comes to pregnancy, only beta blockers are the drugs which can be used. All other 3 drugs can't be used. And the etiology of heart failure in pregnancy, it is very important. At times it is idiopathic, that is peripartum cardiomyopathy, the precipitating factor usually we can't see. But there are some specific reasons which lead to heart failure in pregnancy. Myocardial infarction especially. Spontaneous coronary dissection, they are common in pregnancy, and tachyphylaxis induced cardiomyopathy, these all are very common in pregnancy. So that was a wonderful talk. Thank you, sir.
Thank you, Dr. Ccdsicon Ansari, for your brilliant presentation online. Thank you again. Now, proceed to the next topic.
Dr. A.N. Rai sir is here. Can we give him mic, Dr. A.N. Rai sir?
Yes,
Dr. Ccdsicon Ansari, your talk was excellent. And actually we wanted your physical presence. We had very hard warm welcome at Lucknow during the UP chapter inauguration.
Thank you, sir.
I really we thank you for creating the UP chapter. You are the pioneer.
Thank you, sir. Thank you, sir. Thank you. Yesterday we was in Indian School of Hypertension with Neil Poulter. That's why I was not able to come. So definitely next time I will be there with you, sir.
Okay. We wish you. Thank you for your
Thank you.
Any question from the audience?
Any
question from the audience?
No, sir.
No. So once again, we thank Dr. Ccdsicon Ansari.
Thank you, sir. Sabko pranam, madam. Sare panelists.
Thank you. The next speaker is Dr. Nishant Kumar Abhishek from Patna. The topic is heart failure with reduced ejection fraction. Request the chairperson to introduce the speaker.
Heart failure with reduced ejection is very common because it's most commonly seen after heart attack. And Dr. Nishant Kumar Abhishek is MD Medicine DM Cardiology and has years of experience in cardiology. He has also worked at big hospital, Spectra Hospital, and he has training conference at Best Post Award UP CSI 2019 Gold Medal in MD and DM, and active participation across various national cardiology platforms like CSI, NIC India, Live, CSI, UP CSI, and Indo-Pacific. You may go ahead with your presentation, Dr. Nishant.
Good morning, chairpersons. Good morning in the august audience. A lot has been said and covered in detail by my senior consultant cardiologist on varied aspects of heart failure. So it's nothing much left actually, but the invitation as such was from my senior Dr. Sumit Kumar Verma, and he insisted that Nishanti will not utter any data or any trials in the PPT. So I was like, I could actually gauge the plight that he feels, that no matter how much we are talking on the data and the trials, on root level in such a population-filled country, the basic diagnosis of suspicion, ECG and X-ray still remains the gold line, and it should be strictly dealt with. There should be groups of ECG between doctors, groups of X-ray between doctors, groups of echocardiography between doctors to be actually dealing these cases of heart failure, rather than going deep and in detail in the presentations and the data. Because the data is coming and the data is so apt, the data is so brilliant over the past 3 years that there has been a paradigm shift over the treatment of the way we are treating heart failure these days. So let's move ahead with the presentation. This is just a brief introduction or the framework how to deal with heart failure with reduced ejection fraction. My first slide would be a take-home message contrary to the popular belief, because I still believe this is the most important part, and the most important parts are clinical suspicion is the clincher, as Dr. Chandramohan said. Heart failure is more common than we think. Contrary to the classical symptoms of shortness of breath, orthopnea and edema, any presentation is possible, like jaundice, loss of appetite, abdominal bloating, chest pain, syncope, cognitive decline, arrhythmia, and potentially directly as cardiac arrest. Low threshold for advising ECG, chest X-ray in symptomatic patient, more in high-risk patients, as we already have mentioned, like hypertension, diabetes, old age, should be done. Early stabilization is also as important as referral to higher center. IV fluid per se should be avoided at any point of treatment in any city that is possible, and diagnosing a case of shortness of breath, except other causes of shortness of breath are strongly clinically suspected. And following the 4 pillars of heart failure management and information about further possible treatment appears to be the most judicious approach at this point of time. Now the few clinical vignettes which I have encountered in the past 2 years of my clinical practice, which is quite young to be honest. An 18-year-old boy presented to medical ER with history of shortness of breath over the last 7 days, progressing to NYHA4. He was stabilized in CCU. His medical history was suggestive of rheumatic fever in childhood. Echo revealed moderate to severe aortic regurgitation, moderate mitral regurgitation with an LVEF of 25 to 30%. ECG had prolonged PR with raised ESR. X-ray was suggestive of pulmonary edema. He was treated with steroids and heart failure was managed with GDMP. Patient improved and is now doing good in follow-up with mild residual AR with normal LV function. The learning point being that the patient was young, still suffered heart failure because he had an episode of rheumatic fever, and the most likely the current episode was a reoccurrence of rheumatic fever with precipitous carditis causing the symptoms. A 43-year-old IT professional presented in the OPD with history of undiagnosed cough, more so nocturnal, for 6 months, taking multiple prescriptions for the same, leg swelling for 15 days and shortness of breath for 2 days. Non-hypertensive, non-diabetic. ECG and echo revealed severe LV dysfunction. CAG was normal. History of alcohol intake right from his teens was present. Patient was put on GDMT. Strict avoidance of alcohol was told to him, and he is doing good on regular follow-up. A 50-year-old long-standing diabetes patient presented to the ER with complaints of nausea, vomiting and jaundice. Liver enzymes were in a range of 2000 plus. Evaluation from the gastro side was non-conclusive for jaundice. As I'm working predominantly in a gastro hospital, so this case was actually interesting. Evaluation from the gastro side was non-conclusive for jaundice. A cardiac consultation was plainly taken for sinus tachycardia in ECG and cardiomegaly on X-ray. His echo revealed severe LVD of 15 to 20% with dilated IVC with no other causes causing this symptom. Troponin was negative, BNP was increased. So the patient was managed as a case of ADHF, though he never complained of shortness of breath ever in his life or in his hospital admission. So it's a plain case of congestive hepatitis with IV diuretics and GDMP. Patient improved over the course of hospital stay, and CAG later on revealed non-critical CAD. Patient is doing good on follow-up. A 62-year-old male diabetic and a known case of heart disease with decreased pumping was not improving well on GDMP, leading to frequent hospitalization. His echo was reviewed, which earlier showed mild to moderate AS with some LV dysfunction, which was suggestive. I was reviewing that echo. His echo was reviewed, which was suggestive of low flow, low gradient, severe aortic stenosis. Being a motivated patient and the earlier improvement that he felt from heart failure treatment, he actually went ahead for further treatment and was referred for a high-risk AVR. The angio revealed critical left main plus triple vessel disease, so he underwent the AVR plus CABG, and post-surgery, he's still doing good on GDMP, and that event has been around 3 months from today. So just to outline what can be the presentation in the clinical scenario, we have dealt with this things like stages of heart failure at stage A, the at risk for heart failure, patients with hypertension, cardiovascular disease, diabetes, obesity, exposure to cardiotoxic agents, genetic variants or cardiomyopathy, or family history of cardiomyopathy. Then comes the pre-heart failure stage, stage B, patients without current or previous symptoms or signs of heart failure, but evidence of one of the following, that is structural heart disease, increased filling pressures or risk factors or increased natriuretic peptides levels or cardiac troponins in the absence of any competing diagnosis. Then comes the most common stage that we clinically encounter, that is the symptomatic heart failure, that is patients with current or previous symptoms or signs of heart failure. And then the last stage, that is stage D, that is advanced heart failure with marked heart failure symptoms that interfere with daily life and require hospitalization despite attempts to optimize GDMP. The stage 3 is further, as Sir actually told, this is a trajectory of stage C heart failure, which is new onset, resolution of symptom, persistent heart failure, and worsening heart failure. Then the basic diagnostic algorithm for heart failure with decreased rejection fraction, or the basic classification. The assessment is sufficient on plain clinical history and physical examination with important markers on ECG like left bundle branch block, bifascicular block, LVH with strain patterns, atrial fibrillation, complete heart block. These are the ECG patterns which we can get with patients of DCMP. With a natriuretic peptide to substantiate our diagnosis, and transthoracic echocardiography to stamp our diagnosis. And additional testing is only required if necessary. The heart failure diagnosis is confirmed. The determination of cause and classification, of course, gives a good follow-up and the current admission. Evaluation for precipitating factors is very important. Treatment should be initiated and serial heart failure assessment should be done. The classification that follows is, as we have discussed it time and again, reduced ejection fraction, mid-range ejection fraction, we have this reduced ejection fraction less than 40%, and in patients who have earlier reported to have a reduced ejection fraction, but later on have presented with an improved ejection fraction, they are now classified with a new classification of improved ejection fraction. The classification of improved ejection fraction is only important, leading to the fact that we need to pursue treatment in that case also. Mid-range ejection fraction is LVEF 41 to 49%, and preserved ejection fraction is LVEF greater than 50%. Before going further ahead, I would like to actually point out a very important point of HFPEF, that apart from the clinical diagnosis and whatever we are seeing with the patient, the most important thing is that a good echocardiography can only prove HFPEF. A reduced EF is easy to diagnose, but HFPEF, a high degree of clinical suspicion with high volume echocardiography load should be diagnostic of HFPEF. Now these are the common causes of heart failure, the risk factors being the most population density, very frequently found, hypertension, obesity, pre-diabetes and atherosclerotic cardiovascular disease. The most common being ischemic heart disease. Every 4 out of 5 patients is like coming out of CAD and leading into heart failure. And other non-ischemic causes in detail, as we know, chemotherapy, cardiotoxic medication, rheumatological, autoimmune, metabolic causes, familial heart disease, heart rhythm related, that is tachycardia or bradycardia mediated. RV pacing as a cause of heart failure should also be pointed upon in patients of chronically paced patients in which single chamber were paced, or even if dual chamber were paced, sometimes after 10 to 15 years they do develop heart failure. That has actually come down and making the events of bundle branch pacing and conduction system pacing more into the current scenario of intervention cardiology. Then hypertension, infiltrative cardiac disease, myocarditis. Initial serial evaluation, biomarkers, class 1 recommendation, no doubt about that, in patients with dyspnea to rule out heart failure, in patients hospitalized for AF to rule in heart failures, as well as to give a prognostic markers, the trajectory in which the heart failure is going. They are dealt with the serial levels of biomarkers. In patients at risk for heart failure, that will come up as a community screen tool, not common in our part of the world, but sooner or later to rule out heart failure, they will become a very easy test. And in patients of chronic heart failure, we need to have BNP level measurements for risk stratification. False elevations of BNP has been dealt with in like increased age, anemia, renal failure, severe pneumonia, obstructive sleep apnea, embolism, and PAH. The basic serial evaluation, class 1 recommendation of chest X-ray to in a new onset heart failure with decompensated heart failure, ruling out other pulmonary causes that can be contributory to the admission. Transthoracic echo is a class 1 recommendation. Then if transthoracic echocardiography is not informative, then cardiac CT, CMR or nuclear imaging should be dealt with. Ischemia evaluation is a class 2A indication, and in patients with ischemia and CAD, class 2B recommendation is always there to be going for SPECT or nuclear imaging guided coronary revascularization. And in class 3, that is also important, in patients in which there is no clinical deterioration, there should not be further investigations or repeat echoes to actually see the effect of patients, because the echo will not improve very soon. It takes a period of time, 6 months to 1 year, echo can be taken, but not in the very close scenario. Recommendations, the recommendations are at risk for heart failure, the common elements that should be treated with nicely, like hypertension should be treated, diabetes should be treated, CVD, cardiotoxic agents, patients should be screened for genetic cardiomyopathy. In pre-stage, stage B of heart failure, preventing the syndrome, that has always, the structural defect has taken place, but we are not coming up with the symptoms, then we can early initiation of treatment with ACE, ARBs, ARNIs, beta blockers, and ICD in patients of decreased LVEF survival and greater than 40 days post myocardial infarction should be class 1 recommendations. Reduced ejection fraction in class C and D, the established diagnosis of reduced ejection fraction, then all the 4 pillars as we have repeatedly pointed out, that is ARNI, beta blocker, MRA, SGLT2 inhibitors, and diuretics as needed to remove the congestion should be the standard of practice. We should be, in the next step, we should be titrating the target dosing as tolerated, and the titration of dose is also very important. The point being that we should be initiating with the lowest dose. In common practice, like if the dose is 50 BD for ARNI, we are going ahead with half of 50. That is also not wrong, and we should be titrating it further, because any cardiac drug should be initiated at the smallest possible dose, but the titration should always be kept in mind. Step 3, patients, if the patient has improved In NYHA 3 and 4, in subset of population, we can go for another treatment. Now the interventional treatments that are covered in step 4, that is ICD or CRDD, according to the patient's profile. And finally, if the patient is not responding to all these treatments, then offer should be given for left ventricular assist device and higher therapies like cardiac transplantation. Additional medical therapies that after optimizing GDMT, these are the class of recommendations with these drugs: ivabradine, that is 2A, vericiguat, that has come out very recently, that has 2B, digoxin, PUFA, and potassium binders in case of increased potassium in patients. Ivabradine, though in 2A, I feel like it will sooner or later come up in class 1 recommendations. Now, coming up with the interventional that have a special place in patients of reduced ejection fraction, because in patients of preserved ejection fraction, further interventions are quite less, but in case of reduced ejection fraction, there is a battery of interventions that can be dealt with and can give mortality as well as morbidity benefit. The CRT recommendation being heart failure on GDMT more than 3 months and 40 days after MI. If the survival is more than 1 year, then we should be going ahead with the interventional treatment. And these are the strength of recommendations. In frank LVBB with greater than 150 milliseconds, this is class 1 indication. Non-LVBB greater than 150 milliseconds. LVBB with a lesser duration of 120 to 149 milliseconds have other recommendations. Special circumstances in which patients is in chronic AF where RV pacing is frequent or anticipated should be going for a CRT. In patients of normal sinus rhythm, in which RV pacing is frequent or anticipated, still like the patients of CHP and complete CHP with a background LVBB or CHP with complete pacing requirement should ideally be going for a CRT and not plain pacing. Evaluate LVEF in case of 36 to 50% high degree of complete heart block, 2A indication. In case of normal LV functions and bradycardia, patients should be going for plain pacemakers. Additional device therapies after optimizing GDMT with suitable coronary anatomy, surgical revascularization. In NYHA 2 to 3, severe secondary MR after optimizing with the GDMT, we can go ahead with the transcatheter edge-to-edge mitral valve repair. That's a class 2A recommendation. This is again talking about the mitral regurgitation that need to be tackled with reduced ejection fraction. In cases of coronary artery disease undergoing CABG, can be dealt with in the same surgery, MB surgery. But in case of greater EF is normal, then surgery is the given choice. But if the LVEF is less and patient is persistent symptomatic and on optimal GDMT, then mitral, if the anatomy is preferable, transcatheter treatment has taken over the surgical part in those subset of patients with a strength of recommendation 2A over 2B, that is mitral valve surgery. These are the recommendations for specialty referrals: continuous need of intravenous inodrops, decrease in organ dysfunction, multiple defibrillator shocks, more than one hospitalization, edema despite escalating diuretics, continuous low symptomatic less systolic BP. These are the indication of mechanical support devices. In select patients with advanced reduced ejection fraction with NYHA class 4 symptoms who are deemed to be dependent on continuous intravenous inodrops or temporary MCS, durable LVAD implantation is effective to prove functional status. Cardiac transplantation of the mean adult survival is greater than 11 years versus less than 2 years for patients with stage D heart failure without advanced therapy. I have just 2 minutes to complete the slides. Patient hospitalized with decompensated heart failure, I have dealt with it again, that what can be the precipitating factor, most commonly congestion, discontinuation of drugs, fever. Simple causes can be arrhythmias, can be simple causations of decompensation. Monitoring and giving the standard decongestion strategy with IV diuretics, combination of diuretics. Post-discharge follow-up is very important with cases of heart failure. They should be kept motivated. They should be taking an exercise protocol. These things we have dealt with in the previous slides. AF management is important in heart failure. Rhythm or rate should be given a chance for atrial fibrillation ablation. That is a 2A recommendation. Thanking you, and I'll like to say that I'm trying to maintain a continuous supply by indenting SGLT2 inhibitors as well as ivabradine, all those 4 pillars of drug in my parent place when I'm working, that is ESMCH beta. So if there are any patients motivated to be living long with heart failure, kindly refer to us. Those drugs are, the cost is taken out of the picture. Thank you.
Thank you, Dr. Nishant. Any question from the audience?
I request to show me the slide of that case, a 18-year-old boy case.
Yes, sir.
First slide almost.
Slide पे कर दो. Slide पे कर देना. अच्छा. Second slide. Second या third slide.
So, gentlemen, we are running short of time.
Okay, sir.
Thank you very much.
Okay.
Thank you, Nishant.
Yes, thank you.
And now I request Mukta to present the moment to all.
I will now request Dr. Shansar sir, who is the chairperson for this particular session, along with all the other chairpersons, to our speaker, Dr. Nishant Kumar Abhishek from Patna, and let's have a huge round of applause for Nishant sir for his very, very enriching presentation that he delivered over here. I would request all the chairpersons to kindly fill the stage and honor our speaker, Dr. Nishant Kumar Abhishek sir. एक बार शानदार तालियां आनी चाहिए. अब आप देख पा रहे हैं डॉक्टर निशांत कुमार अभिषेक जी को सम्मानित किया जा रहा है हमारे माननीय चेयरपर्सन की ओर से और हमारे माननीय मॉडरेटर की ओर से. और अब मैं अनुरोध करूं कि हमारे बीच एन राय सर, जो कि आज के सेशन के माननीय अध्यक्ष के स्वरूप में उपस्थित हैं, तो कृपया करके आए हैं. हमारे बीच हमारे दूसरे स्पीकर डॉक्टर चंद्रमोहन बेलवाल जी, जो कि देहरादून से हमारे बीच आए हैं, उन्हें सम्मानित करें. एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से. They are both really amazing, eloquent speakers. And I would now request our honorable moderator, Dr. R. Chaudhary sir, to kindly come forward and honor our honorable and esteemed chairperson for the particular session. I would request Dr. R. Chaudhary sir to kindly honor to the stage Dr. Ian Rai sir. एक बार शानदार तालियां हम सभी लोगों की ओर से. और आप देख पा रहे हैं हमारे माननीय मॉडरेटर, हमारे परम आदरणीय चेयरपर्सन डॉक्टर ए राय सर को सम्मानित कर रहे हैं. और अब मैं उनसे अनुरोध करूंगी कि हमारे बीच उपस्थित डॉक्टर डी के शर्मा सर को वो सम्मानित करें अपने कर्तव्य द्वारा. शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से. इसी के साथ साथ मैं उनसे अनुरोध करूंगी कि वो कृपया करके डॉक्टर शमशाद जी, जो कि हमारे बीच एक माननीय चेयरपर्सन के रूप में उपस्थित हैं, इस सत्र के दौरान उन्हें भी सम्मानित किया जाए. और अब आप देख पा रहे हैं हमारे तमाम चेयरपर्सन एक साथ हमारे माननीय मॉडरेटर डॉक्टर आर चौधरी जी को सम्मानित करें. बस शानदार तालियां आनी चाहिए. Let's have a huge round of applause for all of them. So we hereby conclude this particular session, and we are all set to begin our next session, which is going to be a panel discussion. And in order to moderate this particular session, I would now like to call upon stage Dr. K.K. Lohani, sir. I would like to call upon stage Dr. K.K. Lohani, sir, as the honorable moderator for this panel discussion.
Good morning. I take privilege to introduce the moderator of this panel discussion on lipid disorders, Dr. K.K. Lohani, sir. Sir is currently professor and head in Department of Medicine in Netaji Subhash Medical College, Quetta. Sir has served with the Bihar Medical College for long years in various capacities.
Under me. After that, he has become a very busy practitioner and settled at Gaya. Dear colleagues, as we all know, dyslipidemia is a very important and modifiable risk factor for atherosclerotic cardiovascular disease. And we manage dyslipidemia according to international guidelines, which keep on changing from time to time. All of us are aware of ATP3 guidelines, which was proposed by National Cholesterol Education Program in 2001. This guideline was revised in 2004, and according to revised ATP3 guidelines, we managed dyslipidemia for about 10 years. Then came 2013 cholesterol guideline given by American College of Cardiology along with American Heart Association. And for certain reason, this guideline generated unprecedented hue and cry. And again, it was revised in 2018. Precisely by 2018, due to so many changes in guideline, the whole scenario had become very confusing so far management of dyslipidemia is concerned. Then came 2019 European guideline proposed by European Society of Cardiology along with European Atherosclerotic Society during their annual conference in Paris in 2019 September, which came in international journal, especially European Heart Journal, in November 2019. In a nutshell, I can say this is a very comprehensive guideline and well accepted. And for last 3 years, we have been managing dyslipidemia almost every part of the world with this European guideline. But then the story does not stop here. In last couple of years, a few new molecules have been included in our therapeutic armamentarium. And it has been approved not only by international authorities, but even in India by the Director General of Drug Control. It has been introduced in the market by different pharmaceuticals company also. So as a practicing physician, it is our moral and scientific responsibility to know how to use these drugs effectively for management of dyslipidemia. As I said in the beginning, we have 4 panelists. So we have divided this panel discussion under 4 subgroups. In the first subgroup, we will have a brief introduction of European guideline. And for this section, the panelist will be Dr. Neeraj Kumar, who will discuss the details about this European guideline, especially certain aspect of it. Then we will discuss the established therapy of dyslipidemia, especially drugs which have been included in our European guideline, and for that reason even in American guideline, another guideline. It will be discussed by Dr. Devendu Bhushan, and Dr. Gagan Gunjan will discuss the emerging therapies, the newer drugs which have been included in last 2 years. And finally, we will have a miscellaneous section where Dr. Neerav will be discussing the different aspects of dyslipidemia which are not covered in these guidelines, or at least which will be requiring a separate mention. So with these few introductory words, I begin with the few slides related to this. जरा सा इसको start कर दीजिए. Hello. Panel discussion, Dr. K. Kelani. तो वहीं से दिखाया जाएगा. वहीं पे बोलिए start कर. हाँ. इसको रख दीजिए वहाँ पे. So we were talking about European guidelines, and according to European guideline, the first and the foremost responsibility of a treating physician is to do risk stratification. And this risk stratification is done in 3 stages, or you can say by 3 methods, different methods. The first one is clinical evaluation, and there are certain clinical features, clinical conditions on the basis of which we diagnose a patient as high risk or very high risk. These conditions are established atherosclerotic cardiovascular disease, familiar hypercholesterolemia, CKD, diabetes, and presence of other risk factor. We will discuss in detail, or Dr. Neeraj will tell you in detail about these clinical features and how they decide whether a patient is high risk or very high risk. The second method is by a computer generated formula which is known as SCORE, systemic coronary risk estimation. It takes into consideration certain facts about the patient, certain data about the patient. We feed in the computer and we get a score. If the score is more than 10, we call it very high risk. If the score is between 5 to 10, we call it high risk. If it is less than 5 and above 1, we call it moderate risk. And if it is less than 1, we call it low risk. And lastly, we also take into consideration certain risk modifiers. These risk modifiers are conditions which enhances the risk category of a patient. Suppose a patient is low category, but if these risk modifiers are present, it should be treated, it should be considered as moderate category patient. These risk modifiers are lipoprotein A, apoprotein B, C-reactive protein, diabetic dyslipidemia, especially high triglyceride, evidence of atherosclerosis on non-invasive investigations, and family history of premature coronary artery disease. So on these basis, we decide whether a patient is low risk, moderate risk, high risk, or very high risk. And as seen in this slide, the patients are classified into 4 categories: low risk, moderate risk, high risk, and very high risk. And we have different LDL goals for the treatment of these patients. For low category, it is 116 milligram per deciliter. For moderate, 100. For high, 70. And for very high, it is 55 milligram per deciliter. Here, I would like to mention one more thing. If there is history of recurrent coronary artery disease within 2 years, the LDL goal becomes even 40. So nowadays, this is the era of lower is better. So far, LDL cholesterol is concerned. All these things will be discussed by our panelist, Dr. Neeraj. I'm just trying to give him a direction And finally, the million-dollar question is how to achieve these goals. And these goals are achieved on the basis of three modalities. Number one, lifestyle modification. Number two, lifestyle modification followed by lipid-lowering drug. Or number three, lifestyle modification along with lipid-lowering drug right from the very beginning. Of course, this slide is a bit clumsy, but one thing is very clear, that at every stage of management of dyslipidemia, at every stage of prevention of atherosclerotic cardiovascular disease, lifestyle modification is very, very important. And only after lifestyle modification comes drugs and other factors. So with these three introductory slides, I include now Dr. Neeraj, our first panelist, to come into the picture. You can use the mic from there, Dr. Neeraj, and he will let us know, as a practitioner and as a physician, what is his opinion about risk stratification, how important it is, and what is the importance of different LDL goals for different category of patients, and how do we manage this issue, lifestyle modification, something which we talk every day, but we do not practice in our practice, clinical practice. So Dr. Neeraj, now it's time for you.
Hello.
You have 5 to 10 minutes time. I will request you to finish by 6-7 minutes so that we can have some questions also in 10 minutes. Please.
Thank you, Dr. Lohani, sir. Sir has already introduced the topic. I will start from the very basic that managing the dyslipidemia is not same for all the patient. The very common proverb is that not the same shoe fits all feet. Here it's very true in case of dyslipidemia. So whenever we will start from very basic, then why we do risk stratification? We do risk stratification so that we can avoid under treatment or over treatment. Some patients are being under treated, some are over treated. So we stratify the patients of dyslipidemia in low risk, moderate risk, high risk and very high risk. According to the European Society of Cardiology, we have 4 classes of different risk. So before going to that risk stratification, there is some scoring charts. So I will briefly elaborate the scoring chart. That is for whom this scoring chart is. This scoring chart is not for the patients who are already in very high risk or high risk. These scoring chart are for screening of the general population, like the 40-year and above male patient, 50-year and above female patients. There are many risk factors present in them, but they are not easily identified, and we often miss the coronary risk factor among them. So this is the score chart, systemic coronary risk estimation chart, where there 5 variables are used, that is age, sex, smoking status, then total cholesterol, and the systolic blood pressure. So different points are given according to all these 5 parameters. This is cumbersome as we see, but nowadays the app is available in our mobile, so we can easily calculate. So whenever a patient, young patient with his lipid profile report come to our clinic and we have to decide, he says that Dr. Sahab, mera cholesterol gadbad ho gaya hai, humko dawa de dijiye. So we have to decide that whether he needs the treatment or he doesn't need the treatment. So this is the score chart. This is not for very high or high risk patient. This score chart is for general population who doesn't come in that high risk group. So here is a very interesting concept of risk age. So for example, if a young male, 40-year male comes to us who is a smoker, who has high blood pressure, who has high total cholesterol, and say for example his point is 4, he gets 4 points. So 4 point is same for the 65-year male who is non-smoker, whose cholesterol is normal, whose BP is normal. So this risk age concept is that 40-year male has got same risk age at 65-year male. So it's used to convince him that if you modify your risk factor, otherwise you have the same chances of getting myocardial infarction or stroke as a 65-year-old male. So after this scoring system, now we will go in the 4 classes of risk factors. The very high risk factor, moderate risk factor and low risk factor. Who are the very high risk factor? Very high risk factor are documented ASCVD disease like stroke, MI, post-CABG, post-PCI, TIA, peripheral vascular disease. They are very high risk from very beginning. or even in coronary angiography or CT angiography, if there are significant plaques, they are very high risk person. So now diabetic patients, some diabetic patients are very high risk patients. For example, those who have got target organ damage like retinopathy, neuropathy and nephropathy, they are very high risk patients. Then diabetes of long standing more than 20 years, or diabetes with some other major risk factors like smoking, raised blood pressure, so they are very high risk patient. Another patient are very high risk patient are CKD patient with eGFR less than 30. Then from this score chart, if the person gets more than 10% chances, that person is also very high risk person. So these very high risk persons are on the top of the iceberg. So what is the target of LDL in them? The target is 50% reduction from the baseline or less than 55. Remember, this is less than 55. LDL target is less than 55 for this very high risk group. Then comes the high risk group. Who are the high risk group? The high risk group are again the diabetic patients who don't have the organ damage, who don't have target organ damage, but they have got long duration of diabetes, more than 10 years, or some additional risk factors. In high risk group, some people with significant elevated single risk factor like very high total cholesterol, more than 300, very high LDL cholesterol, more than 200, and very high blood pressure, more than 180, 110. Then CKD patient, eGFR 30 to 60, and score is 5 to 10. So again, these are the classes of high risk, and the target is again 50% from the baseline. LDL target is less than 70. This is less than 70. Again, there is a third group, that is moderate risk. Moderate risk are again diabetic patients who are young, like 35-year-old type 1, 50-year-old type 2, and the score is 1 to 5. These are moderate risk, and then low risk, the score is less than 1. So we have got 4 risks, and one take-home message I will like to give you, that all our diabetic patients, either they are moderate risk, or they are high risk, or they are very high risk. So always we have to target our LDL goal, keeping in mind that minimum LDL for diabetic, even at moderate risk, is less than 100, and even if other risk factor are there, then less than 70 or less than 55. So this is the risk stratification and the LDL goals. So there are some risk modifiers also. So risk modifiers are, for example, this classification is for European countries. So this, if we are coming to the Indian group, then there are some modifiers like socioeconomic deprivation, psychiatric illness, LVH, AF, NAS, obstructive sleep apnea. All these are modifiers. These modifiers basically upgrade the risk profile. If the patient is in moderate risk and there is risk modifier, then he will fit in the upper risk. So in this way, I have explained about the risk stratification, 4 risk, and the 4 goal. So 4 goals of LDL. We have targeted the LDL. Now how to achieve this target? We have got the very basic thing is lifestyle modification. Then we have the drugs. So about lifestyle modification, from very beginning we are teaching our patients diet and exercise. Very few important topics I will tell you, that regarding the diet. In diet we have the fat, we have the carbohydrate. So in fat, we should totally avoid the saturated and trans fat, and saturated fat should be less than 10%. Regarding the calories, the approximately 300 to 500 kilocalorie deficit should be advised to the patient. And coming on to the weight reduction, they should be asked to motivated that even 10 kg of weight reduction leads to lowering of LDL cholesterol by approximately 8 milligram per deciliter, and elevation of SDL by 4 milligram per deciliter. So how weight reduction is important? By that, with weight reduction, we should, with diet modification, weight reduction and physical activity, this is the baseline. Then we should advise people to completely stop smoking and alcohol. And if the lifestyle modification doesn't work, then we have to go to the drugs that our other panelists will discuss. Thank you.
Thank you, Dr. Neeraj, for elaborating all the introductory slides of European guidelines. One thing is very important which you have pointed out, that this score system is not necessary for patients
who has got clinical conditions associated with dyslipidemia. So, if we do a score system, it's good. Even if we don't do it, if we consider the different clinical criteria, we can decide which patient is high risk, which patient is very high risk. And the biggest example is diabetes.
Yes.
In the past, we did not take diabetes very seriously. The ATP3 guidelines said that it is risk equivalent to coronary artery disease. Now they have classified diabetes under 3 categories. It could be very high risk, it could be high risk, and it could be moderate risk, depending upon whether it is more than 20 years older diabetes with target organ damage, or more than 10 years with other risk factor, or less than 10 years without risk factor. So, as a clinician, our aim is to decide at what stage of diabetes the patient is having dyslipidemia, or lipid levels should be managed accordingly. And regarding lifestyle modification, you have pointed out the salient features, but in guidelines they have very clearly said that there are certain targets which we should achieve, like saturated fat, yes, no. Then sufficient fruits and vegetables and fiber should be taken, we all know. They have very categorically said that BMI should be between 20 and 25. They have also mentioned about the waist circumference, and for Indian patients, it is different from the European guideline, 90 for the male and 80 for the female. So we should stick to these guidelines also. Even blood sugar is important. It should be glycosylated hemoglobin should be less than 7. And according to American guideline, it is less than 6.5. Likewise, blood pressure, it should be 140 by 90, less than that according to European guideline, but in American guideline, it should be 130 by 85. So we have to take care of all these things, then only, and this is the era of treat to target. We must fix the target, and we must try to assess in every visit that whether we are near the target or not, and what else we should do. So thank you very much, Dr. Neeraj. And now we go on to the next part of it, that is lipid lowering drugs. And according to European guidelines, and for that reason, even in American guideline in 2018, nowadays they have included 3 drugs for the treatment of dyslipidemia, especially LDL cholesterol. Statin is the primary drug, we all know. It is the drug of choice for management of dyslipidemia since the beginning of this century. Exactly in ATP3 guideline was the first major effort to establish this drug as the drug of first choice in the management of dyslipidemia. If dyslipidemia is not managed with statin alone, then we have the option to add another drug, and this second drug is ezetimibe. And if both these combinations are not enough, we have got a very powerful drug in our armamentarium for last 5 to 7 years, and that is PCSK9 inhibitors. If I remember correctly, it was approved by FDA in 2015, so it is about 7-8 years now. So either statin alone, or statin with ezetimibe, or statin with ezetimibe with PCSK9 inhibitors. And they have given a data that moderate intensity statin reduces LDL cholesterol between 30 to 50%, high risk above 50%, high risk statin plus ezetimibe 65%, PCSK9 alone 60%, PCSK9 with moderate intensity statin 75%, and PCSK9 inhibitors plus high intensity statin plus ezetimibe 85%. So in nutshell, we can say that now we have enough drug to reduce LDL cholesterol. Even up to 85% reduction we can achieve with these drugs, either alone or in combination. And accordingly, we are supposed to use it. And definitely, it depends upon the baseline LDL level of the patient, the category of the patient, and the baseline LDL level. And accordingly, we can use these weapons. But then, it is also a fact that in majority of our very high-risk patient and high-risk patient, we do not achieve the target. Either we do not bother to add ezetimibe into it, or we do not use high-intensity statin, or we cannot afford PCSK9 inhibitors. Whatever the reason may be, 2 new drugs have been included in our therapeutic armamentarium in last 3 years. since 2020, 2 drugs have been included. One is bempedoic acid and second one is inclisiran. And from this chart, this is a very beautiful chart because it simply classified the mechanism of action of these drugs. Statin, we all know, inhibits synthesis of cholesterol in the liver by inhibiting an enzyme, coenzyme A reductase. Bempedoic acid also acts in a similar manner, but it works a bit earlier and it involves another enzyme. But both drugs have got similar mechanism of action. It inhibits synthesis of cholesterol in the liver. Ezetimibe, we all know, it delays the absorption of cholesterol from the gut. It is also there since 2004, if I remember correctly. And on and off we use it, but till date we have not used it for its full, its utility has not been taken care of accordingly. And the newer drug, PCSK9 inhibitor, we all know, it facilitates the excretion of LDL cholesterol from blood by upgrading the LDL receptors. It is a monoclonal antibody. Nowadays it is called PCSK9 monoclonal antibody. And a newer drug has been introduced, inclisiran, which is nowadays called the true PCSK9 inhibitor because it inhibits the formation of PCSK9 by inhibiting the messenger RNA responsible for it. So now we have got 2 monoclonal antibodies. One is 2 monoclonal inhibitors, PCSK9 inhibitors. One is monoclonal antibody, traditionally, which we are used to call monoclonal, antibody. Nowadays, previously it was called PCSK9 inhibitor. And nowadays, inclisiran is also included in the category of PCSK9. So altogether, we have 5 drugs, and we use it according to need. Statin, we all know, we have been using it for more than 2 decades. We all have used statin. We all are well aware of it. If anything new is there or any clue is to be given, our next panelist will give us. Just 2 things I would like to mention here. For last 5 years or 7 years, especially since this American guideline, 2014 guideline came, we have been using the term high intensity and moderate intensity statin. And it is very clearly written that by high intensity statin, we mean rosuvastatin in the dose of 20 to 40 milligram per day and atorvastatin 40 to 80 milligram per day. So there are only 2 statin which can be considered as high intensity statin, and every other statin is moderate intensity statin. So when we talk of high intensity statin, either we should use rosuvastatin in 20 to 40 milligram or atorvastatin 40 to 80 milligram. Another important thing about statin, we should know how often we should go for lipid profile. And according to different randomized clinical trials and its outcome, it has been found that we should do it, one at the baseline, second after 1 to 3 months, and thereafter every 3 to 12 months. In clinical practice, what I do, I take a baseline, I repeat it maximum within 3 months. Or if patient is very curious and very anxious and patient can afford, we can do it after 1 month also. And after that, I do it every 6 months. So as per guidelines also, it should be done every 3 to 12 months. So we should know about it. Then comes the newer drugs. Ezetimibe, we all know, we have been using it. It is available at 10 milligram tablet. It is a safe drug, and it gives you a reduction of about 24%. Evolocumab and alirocumab are PCSK9 inhibitors. We all know it is given as injectables, subcutaneous injection, monthly injection or fortnightly injection. It is a very, very costly drug. But as I said, it can give you about 60% reduction on its own. Bempedoic acid is the new drug, 10 milligram tablet, gives you about 30 to 35% reduction. And it should also be used as add-on drug. And inclisiran is another drug which can give you more than 50% reduction. It should be used as subcutaneous injection, but frequency of injection is less. So, in nutshell, we have 5 drugs. 3 drugs we can call established therapy: statin, ezetimibe, and PCSK9 inhibitors. And 2 drugs can be called emerging therapy, that is bempedoic acid and inclisiran. And as a clinician, our responsibility is to use these drugs in different combinations if and when required. Now, I would like to include our 2 panelists in this part. The first panelist, Dr. Devendu Bhushan, will discuss the established therapy, that is statin plus minus ezetimibe plus minus PCSK9 inhibitors in the management of dyslipidemia. And the second panelist, Dr. Gagan Gunjan, will discuss the newer drug, bempedoic acid and inclisiran, along with how to use it along with statin in the management. So one by one, Dr. Devendu, please, it's your time.
Thank you, sir. So first of all, regarding the lipid lowering drug, those are the gold standard drugs like statins and ezetimibe. So practically speaking, when we are treating dyslipidemia, only these 2 drugs come into the play. Yes, it is a recent advancement that we are talking about the high intensity statin therapy, and we are giving it especially in cases of MI, recent MI, stroke patients, very high risk cardiovascular risk patients. But still, I doubt that as those patients are also receiving various therapies, diabetic patient receiving metformin, they are receiving dual antiplatelets, so chances of adverse effect is more. Even when the person is using high intensity statin, the chances of developing gastritis, hepatitis is even more. So it is important to lower down the LDL, yes, and it is important to check it 3 monthly or 6 monthly. But how much it come into the real life, I am not sure. I think my cardiologist colleague will better tell us. But yes, we are using that high intensity statins. About the ezetimibe is an older drug. It is around 15 to 20 years old. But the chances again, along with the using statins, ezetimibe, there is a high chance of developing hepatotoxicity. So when the ezetimibe came into the market for around 5 to 10 years, it became a hot cake. But nowadays also the use of ezetimibe has decreased down. One word about the PCSK9 inhibitors. Yes, I don't know how many of us are using it. I tried to get the medicine in 2 or 3 patients, but I am failed to get it in my institute. So no real life experience with that medicine. But yes, it is a promising medicine. Even the other thing is more feasible, like LDL apheresis. Once we are searching about this PCSK9 inhibitors and we are not able to get it, then we talked about the apheresis team, our blood bank team, and they said it is quite possible to do a LDL apheresis to the patients. So at that patient we didn't tried it, but it can be a feasible thing. I would like to hear from someone who has used PCSK9 inhibitors. They are promising, but yes, their availability and cost are the issues. So this is from my side, sir.
Well, that is good. But certain things I would like to know from you, Dr. Devendu, about inertia about using high intensity statin. I'm very confident that most of us are not using the high intensity statin. What could be the reason? Is it the risk of side effect, or patient cannot tolerate it? And if the side effect occurs, what should we do? What do you suggest?
No, sir. It is not so that we are not using it. We are using it. We are now, as per the guidelines, we are following the guidelines and we are using the high intensity statins. But there are, I can't say it is not a large chunk of patients which I am seeing. So I can't say percentage wise, but few of them has developed hepatitis. So I lower down the dose. That is.
So what do you do when the patient develop side effect, muscle related side effect, or
mostly hepatotoxicity, sir.
Hepatotoxicity. What do? You stop the drug, or you reduce the dose, or you change
So for
drug?
few, if it is high, like if it is more than 3 to 5 times, then I stop for a few days and let the enzyme settle down to the little normal, about up to the 2 times, and then we can restart with them in a modest amount. Modest
Okay.
dose.
And at what stage do you think of adding ezetimibe to these patients? Okay, PCSK9 inhibitors were not available in India till recent past, and even if it is available, it is very costly. There's no doubt about it. But what about ezetimibe? Why people are so hesitant about using this drug?
No, sir, I don't think so. No, somebody is hesitant about it, but we can use it. We have to be very careful about the hepatotoxicity. Otherwise, it is a wonderful drug. And if you talk about my practice, I have not seen hepatotoxicity with this combination therapy. But many of my colleagues has experienced it.
And do you really think that the hepatotoxicity is more when you use ezetimibe along with statin?
Pardon?
Statin alone and statin with ezetimibe, the risk of hepatotoxicity increases with combination
Yes, sir.
therapy?
The data says that it increases. Yes.
It is increased.
Yes.
In that situation, what do you do? What is the substitute? Suppose cholesterol is high and the patient has developed hepatotoxicity.
So
then what do you do?
If the person develop hepatotoxicity on statin plus ezetimibe, then I would like to stop both the drugs at that moment, and then we will start statin alone in the modest dose.
Okay. And now I invite Dr. Gagan Gunjan about why these 2 new drugs have been included in our therapeutic armamentarium. What was the reason? Was ezetimibe and PCSK9 inhibitors not enough to deliver the goods, or just it was developed out of curiosity? And okay, if it is developed, now what is the best way to utilize these 2 drugs in our clinical practice? As individual drug or as an add-on drug? So please.
Thank you, sir. Good afternoon, everyone. Just now we heard Dr. Devendra Bhushan speaking about the established drugs, statins, ezetimibe, and PCSK9 inhibitors. Now there are 2 questions that arises after using these drugs. What if we fail to achieve the target level of cholesterol? First. Second, what if there is statin toxicity? We all know statin remains the gold standard drug for treating dyslipidemia in spite of all new inventories. But in these 2 conditions, even if the target level is not achieved, or we have statin toxicity after using it on a higher dose. So this was the basis for invention of new molecules. And surprisingly, we have 2 new molecules now, bempedoic acid and inclisiran. If we look back at the history of bempedoic acid, the inventor of this molecule, Mr. Roger, is the same person who invented atorvastatin long back. He got separated from Pfizer, and later on he came up with this molecule after 8 years of struggle. He started in 2012, and it got approval finally in 2020. So bempedoic acid is not a monotherapy or not as a startup therapy. It is always an add-on therapy to statins. This is clear fundamentally. If after using statins or ezetimibe we are unable to achieve, then we should think of adding on other drugs like bempedoic acid or inclisiran. So bempedoic acid basically acts by inhibiting ACL inhibitor. That is an upstream molecule in the HMG-CoA reductase pathway. So by inhibiting this, we have the basis of what is the basic main mechanism. Now this acts as de novo, that is a prodrug which gets activated in the liver itself, so there is no question of myalgia that happens with statins. The daily dose is 180 milligram OD. If it is used alone, it can achieve 25% reduction in the cholesterol. But if as add-on therapy to other drugs like statins or ezetimibe, there can be additional 15% lowering of lipid cholesterol. So the only molecule that is preventing us from using this drug in our country is cost effectiveness, and there are slight those adverse effects like hyperuricemia, gout, or tendon rupture, or in some cases reported cases of atrial fibrillation. But it is a promising drug if we can manage the cost effectiveness as an add-on therapy to statins. Now we come to the next molecule. Bempedoic acid, there has been various trials like Clear Outcomes trial, Harmony trial, SERENITY trial, TRANQUILITY trial, all have proved its beneficial role in lowering down cholesterol. Cardiovascular effects trial are being studied, and the result will be out in the next 1 to 2 years. If we move on to the next molecule, that is inclisiran, it is a PCSK9 inhibitor. So PCSK9 inhibitor acts extracellular monoclonal antibodies used to act extracellularly by inhibiting PCSK9 inhibitor, but this inclisiran acts intracellularly and inhibits the PCSK9 enzyme itself from its production. The molecule PCSK9 inhibitor used to be given usually within 15 days, that is twice a monthly, but inclisiran has the advantage of being used subcutaneously once, 0, and then after 90 days, and then 6 monthly, that is twice a year. So this is the advantage of using a inclisiran with a few doses of injections. Besides, it also gives us reduction of almost 50% cholesterol, which is very similar to PCSK9 inhibitor, slightly lower, but dosing frequency is making it popular. So we look forward to all those trials of inclisiran like Orion 10, 11, and 12 in the second phase trial, where approximately 3,457 patients were enrolled, and all of them have shown favorable outcome. So whether it be Clear Outcomes trial or Orion trials, both the trials have shown favorable outcome in lowering down the lipid cholesterol level, as well as in patients when used with atherosclerotic cardiovascular established disease. So thank you, sir. This is from my side.
Thank you, Dr. Gagan. You have explained everything very nicely, but there are 2 questions for which I would like to have answer from your side. Nowadays, it is becoming a tendency either on the part of pharmaceutical companies or whatever the reason may be, that people are tempted to use bempedoic acid as a monotherapy. Everybody is saying that this is the substitute of statin in clinical practice. What is your opinion?
No.
Do you see the future of bempedoic acid as monotherapy in the treatment?
No,
or whenever, what is the situation when we should consider this drug as monotherapy?
Bempedoic acid is still not to be used as monotherapy. First, I already made it clear. First, statin remains the gold standard. After using statin, if we are unable to use statin due to some reason like myotoxicity or anything for the adverse effects, then only bempedoic acid should be considered as a monotherapy. But if patient is able to tolerate statins, and statins, there is no replacement to statins.
Second thing is, by and large, it is a safe drug, but uric acid is a problem with bempedoic acid. It is increased. It has been observed in different trials. So, should we stop it, or it is written in the literature that we should continue with bempedoic acid and we should add uricosuric agent also if the patient is suffering from hyperuricemia or GOT. So,
the incidence of hyperuricemia or tendon rupture is very less, even with bempedoic acid. But still, if we can lower down, the recommended dose is 180 milligram daily. But in such cases where we have the hyperuricemia or GOT reports, we can either decrease the dose or we can continue with add-on therapy of uricosuric agents.
One thing which we did not discuss while discussing the lipid-lowering drugs, there are 2 situations where we should use, either we should not use or we should use very cautiously. Statin in elderly population, above 75 years of age, it is said that we should use it only when there is definite indication or if the patient is having high or very high risk category. In mild to moderate case, we should not use statin in elderly patient because the risk of side effect is a bit higher in elderly. And number 2, nowadays in pregnancy for last 5 years or 6 or 7 years since 2016, it has been absolutely it has become contraindicated in pregnancy. We will discuss issue this pregnancy-related dyslipidemia in the end. But what about the treatment of dyslipidemia in elderly individuals? What do you suggest? What should we do?
Even in elderly populations, the new 2 drugs, bempedoic acid and inclisiran, are promising drugs. In cases of mild to moderate liver or renal failure, there is no contraindication to these new drugs. These drugs can be used safely. Only some literature says that in severe cases we should avoid. Even that research is going on, and we will have more research publications in the coming next 2 years. So there is no contraindication to these drugs in mild to moderate liver or renal failure.
Very good. And as such, till date, bempedoic acid is an add-on drug for statin. It should not be encouraged as a monotherapy. And the explanation, one explanation is very simple, which is related to commerce. Nobody will like to buy a Maruti 800 in the cost of Mercedes-Benz. 5 milligram of rosuvastatin or 10 milligram of atorvastatin cost 5 rupees, if I remember correctly. There are many companies, but one tablet of bempedoic acid costs you 20 to 25 rupees. So reduction is less than 25% with bempedoic acid. So this much of reduction you can get even with moderate intensity statin. So there is no need to become very, advanced physician to use bempedoic acid as monotherapy. We should still stick to statin, and when required, we should not hesitate to use either ezetimibe or bempedoic acid. Both are tablet form. And if situation arises, we can have the services of two very good molecules. Number one is this PCSK9 inhibitors, and number two is inclisiran. So thank you, Dr. Gagan Gunjan. And now we come to the third section. And during this section, first of all, we are going to discuss, naturally for this last section, our panelist will be Dr. Nirav. During this section, first of all, we are going to discuss how to utilize these drugs in clinical practice. What we have been discussing for last half an hour. There should be a scheme. Naturally, these two drugs are not included in our guidelines till date. But in 24, we are expecting some guidelines where these drugs will be included. Then we will act accordingly. As on date, how to use these drugs? How to utilize these 5 drugs which we have in our armamentarium? And they have given an example. Naturally, I have taken it from a journal about the newer lipid-lowering drugs. And message is very straightforward. Example they have given is that of acute coronary syndrome, because that is one situation where you need maximum reduction in LDL cholesterol. So a patient of acute coronary syndrome, suppose comes to your clinic or your hospital, he can come with 5 different situations. Either patient is not on lipid-lowering therapy. In that situation, our aim is to start lipid-lowering therapy, definitely high-intensity statin. So that is the first situation. Second, patient is already on statin, but not high-intensity statin. Then we should increase the dose and make it high intensity. This is the second situation. Third situation is patient is already on high intensity statin, still the LDL is above 70. LDL is not at goal. In this situation, first aim is to add ezetimibe. Even after ezetimibe, if the goal remains high, the LDL remains high, then we have 2 options. If we need about 20% further reduction, we should add bempedoic acid. If we need about 30-40% further reduction, then we should use either PCSK9 inhibitors or inclisiran. So this is precisely this graph is all about. So at this stage, I will request Dr. Nirav to let us know, is it correct or we can have a different protocol in our clinical practice about using these 5 drugs. Dr. Nirav, please.
Good afternoon, sir. I think in real practice, in our clinical practice, reducing the cholesterol level is not very big deal. In Bihar, particularly in Bihar, LDL cholesterol is slightly raised. There is combined hypertriglyceridemia. Usually there is triglyceridemia as well as lipid LDL level is around 90 to 100. So usual, and because of a small size, maybe something related with gene, usually there is fall in LDL cholesterol level. So we should start in our practice like we should start with giving the scoring is not possible in our clinic, and we do not follow our patient how much percentage there is fall of LDL cholesterol, whether it is 50% or 20% like that. So better to start with the seeing the original report, the basic report, how much is the LDL cholesterol, and we should certify the risk factor right side, because every scoring system is because of the age, smoking, diabetes. So we should score the risk factor. If risk factor is more, we should treat the patient, and we should follow those patients whether it is down or not. Definitely we should have a clear idea regarding very high risk patient, moderate risk and low risk patient. And regarding the addition, in my practice, I found only 2 patients in which PCSK9 was required. and only one patient was able to afford it, because I am in poor hospital, maybe in Vedanta and other hospital they must be using more than that. So it is very rare to use PCSK9. Ideally we should start with a statin, add azithromycin. This is very good combination for reduction, and there is motility benefit also, because in IMPROVE-IT trial there was motility benefit. So these two drugs, there is no doubt about that. The third addition, PCSK9 in our region, it is very difficult, because almost $500 is required for naphtha drug, which is available in Bihar. So that is the problem.
Thank you, Dr. Nehru. Just two quick questions I would like to ask you. Number one, nowadays, are we using this PCSK9 inhibitors in Patna?
Yeah.
Is it available?
My one patient is on PSK.
Inclisiran is also available in Bihar, Patna? Inclisiran?
No, it is not available.
But PCSK9, Evolocumab, we are using in Patna. Anyway, another question is a very old issue. In most of the cases of acute coronary syndrome, a statin which is advised is atorvastatin 80 milligram, high intensity atorvastatin. In all the recommendations, in all the trials, you will see atorvastatin, not rosuvastatin. So is there any logic behind using atorvastatin in acute cases? Or we can use atorva or rosuvastatin, anything?
I don't think there is head-on comparison between atorvastatin and rosuvastatin in any trial. And definitely with high dose rosuvastatin or atorvastatin, there is problem within 2 to 3 week patient complain that he is having vague type of pain, he is not feeling energy, he is getting down every time. So that is the problem with high intensity. All our angioplasty patient are high intensity patient, high intensity statin, and after 2 to 3 week or 4 week, we are bound to reduce it because of these complaints. This is very common in Bihar, in a small size patient.
If I remember correctly, somewhere I was reading in an article that when you need acute reduction in LDL level, say after acute myocardial infarction, atorvastatin is the choice. But if you need long-standing reduction in LDL cholesterol, rosuvastatin is more potent. It gives you 5 to 10% extra reduction in LDL, but immediate reduction choice is atorvastatin. Do you agree with it?
I think that in most of the SKS patients, LDL is around 90 to 100, and after giving 40 milligram rosuva or atorva, it fall to 20 or 30 like that. Majority of cases there is huge fall.
So anything can be used, either atorva or rosuvastatin.
And there is these logic are given by some conspiracy theory. I don't think there is.
So that is why I asked
no head and trial.
But in most of the trial, it is atorvastatin and written. That is why I ask you.
Yeah,
okay, I come to the
only one condition, sir. If there is renal failure, atorvastatin is better than rosuvastatin.
Another very important issue is homozygous familial hypercholesterolemia. We always talk about this condition, and it is considered as a condition for which there is no treatment. Nowadays, there are few drugs in the pipeline, like Mepro, Mersen, and Lomitabide. Just in brief, can you let us know what is this condition, especially homozygous familial hypercholesterolemia, how to suspect it in clinical practice, and how to approach it? apheresis, what Dr. Devendu was talking, is perhaps the only treatment till date for this condition. But nowadays they say that with Lomitabide or Imepopersen, the chances of apheresis is reduced to a great extent. So can we have just expert opinion from you on this issue, familial hypercholesterolemia? In short.
In familial hypercholesterolemia, there is very high level of cholesterol, maybe more than 500, and it is very rare, 1 in 14,000 or 16,000 like that, it is present. The suspicion is if there is premature coronary artery disease in family history, father or mother suffer before 55 or 60 years of age, if there is tendinous xanthoma in the patient or in the relative, if there is sudden death in the family, in all those conditions we should suspect and we should confirm it by the DNA study also. So whether there is usually the PCSK9 gene, ApoB gene, and LDL receptor gene, there is a mutation of that, and it is because homogeneous, the maximum patient died within 30 years of age. The maximum patient present within 12 to 20 years of age. So in this condition, only treatment available is the lipoprotein apheresis, which cost in Europe is around $2,500. In Europe it is cost. So it's very expensive treatment. Treatment is available, but it is you can give the medical therapy. There may be some response, and the target for child is below 150, it should be below 150 for child. And for adult, it should be 50 to 70, depending upon how much is the risk factor. So
in nutshell, if it is heterozygous familial hypercholesterolemia, to some extent the drugs are effective. But if it is homozygous, none of these drugs act. Because the excretion of LDL, that mechanism, there is mutation in the gene. So there is no excretion. So none of the drug act. Fortunately, this mepomersen and lomitapide, these two drugs have been developed which act by different mechanism. And they have shown a lot of promise. Mepomersen is used as injectable, but it has got again the same problem. It causes hepatotoxicity and steatosis. So it has been withdrawn after approval by FDA. This lomitapide is another very promising drug. It is oral drug and it causes about 30%, 25 to 30% reduction in LDL cholesterol in homozygous variety. And let us hope in future it will come in our clinical practice, and then the risk of apheresis will be reduced. It won't be completely,
Sir, one small correction, sir. If it is homozygous hypercholesterolemia, if we are using ezetimibe, it will reduce, it will act as niamine-like protein in intestine. So it is effective. It is effective, but the extent of impact is not same as other person. So you should use the medical therapy also, and you should use the lipoprotein apheresis also.
Now we come to another very important issue which you were talking about, everybody was talking, mixed dyslipidemia or dyslipidemia where LDL is high and triglyceride is also high, which is a very common problem in our clinical practice in Indian diabetic patients. How do you deal it? What drug is the choice nowadays?
So if the triglycerides are high along with the LDL, then yes, we can use statin plus fibrate product and derivatives. And yes, if the person is having little bit of impaired glucose tolerance or diabetes, yes, we can add saroglitazar. Saroglitazar is a very good drug for controlling the triglyceride. I have used it in many patients. It is quite effective. The only side effect is its cost. So after say it is not that costly also, but after 3 to 6 months, patient says कि डॉक्टर साहब को ये सस्ता दवाई तो नहीं है. So that is the thing, but it reduces the triglyceride like anything. It reduces it.
So as per a guideline, they say that if the triglyceride is between 150 to 500, we start treatment with statin. And even after treatment, if you find it high, then you add a drug specifically for this group. Nowadays, the choice is icosapent ethyl, 2 twice daily, 2 grams twice daily. In the past, we were using fibrates. The newer drug, saroglitazar, can do the same work. So that is the approach. If triglyceride is less than 500, start treatment with statin, and after 1 or 3 months, if it is high, then add 2. Now we are coming to the last slide. We are running short of time. The last slide is dyslipidemia in pregnancy. And in one line, I convey the message. All lipid-lowering medications, aside from bile acid sequestrant and omega-3 fatty acid, should be stopped before conception or immediately when pregnancy occurs. This is a very unique information which we should know. None of the drugs which we were talking about can be used in pregnancy. There are only 2 drugs safe for cholesterol, bile acid sequestrant, cholestyramine, and for triglyceride, omega-3 fatty acids. Everything else is contraindicated according to guideline, according to different trials. So that is a very important message we should know. And I would like to conclude my talk here by quoting a very famous anecdote. Someone asked Buddha, what is poison? He replied, everything excess in life is poison. What Buddha said more than 2,500 years ago is very, very true even today, especially in context of atherosclerotic cardiovascular disease. We talk a lot about LDL cholesterol, but it is not only cholesterol which is bad. Excess of body weight is bad, excess of blood sugar is bad, excess of blood pressure is bad, excess of smoking is bad, and excess of inactivity is bad. Smoking was always bad, and excess of alcohol is bad. That is precisely inter-heart study. So when we want to prevent atherosclerotic cardiovascular disease, we should take care of all the 9 modifiable risk factors. Yes, dyslipidemia is one of the most important modifiable risk factors. Thank you very much, all the 4 panelists, and thank you everybody for your patient hearing. I wish I had some questions from the audience, but we are getting repeated ring from the organizers. So I think we have tried to cover almost every practical aspect of dyslipidemia management. Thank you once again, and thank you organizers once again.
Thank you, sir. Everything has been covered. So please proceed for felicitation.
Thank you so much, sir. And I would expect each one of you to kindly put your hands together for all our panelists as well as our honorable moderator for this wonderful panel discussion. And I would now request our honorable moderator, Dr. Ccdsicon, sir, to come forward in order to honor all our panelists for this particular panel discussion. I would request Romani sir to kindly honor Dr. sir, along with Dr. Diabetic sir, Dr. sir, and Dr. sir. Let's have a huge round of applause for our all esteemed panelists. It's been our sheer honor to have all of you as a very integral and significant part of this event, and specifically for this panel discussion. और एक बार शानदार तालियां आने चाहिए हमारे तमाम panelists के नाम for their wonderful contribution. तो एक करके आप देख पा रहे हैं हमारे तमाम panelists को सम्मानित किया जा रहा है डॉक्टर सर, डॉक्टर दिवेंदु सर, नीरज कुमार सर and डॉक्टर सर. और अब मैं अनुरोध करूंगी कि हमारे बीच उपस्थित श्री प्रमोद कुमार सिंह सर हमारे बीच पर हमारे और वो अपने कर्तव्यों द्वारा हमारे बीच हमारे माननीय मॉडरेटर डॉक्टर ccdsicon सर को सम्मानित करें. शानदार तालियां आनी चाहिए. डॉक्टर ccdsicon सर हमारे माननीय मॉडरेटर for this particular panel discussion. It's truly been a delight for all of us to have all of you, and thank you so much, Dr. Singh sir, Dr. Pramod sir, for doing the honors on this very happy and exciting note. We are announcing the formal conclusion of this particular panel discussion, and now we are all set to head toward our next session, which is going to be moderated by Dr. Neeraj Kumar sir from there. So we request him to sign up upon today in order to moderate this particular session. And I would request all of you to kindly give it up for Dr. Neeraj Kumar sir. And I would now like to hand over the proceedings of this particular session to you, sir. Thank you so much.
Hello. Are you now? So we are running short of time. So very quickly, I would like to call upon the stage our chairpersons, Dr. Bhavesh from Bugusarai. Kindly come on the stage, Dr. Bhavesh. And
I will like to inform all the speakers who are yet to deliver their lecture that they will have to bear with us. We have reduced the lecture delivery time by 5 minutes, so it will be a favor to us if they finish within 15 minutes. Thank you.
Dr. Bhavesh from Bugusarai, Dr. Birendra Kumar sir from Bhagalpur, and Dr. Sambhu Kumar from Bugusarai. Kindly come on the stage. Then Dr. Ajit Kumar Sinha sir from Bugusarai. All the 4 chairpersons, please kindly come on the stage. And as Dr. P.K. Singh sir informed, the time limit has come, 5 minutes has been cut from the talk time. So please, the speakers, bear with this. So only 15 minutes time is there. So I would like to hand over the mic to the chairpersons. Kindly proceed the session. Thank you.
Hello. First of all, good afternoon, everybody. It's already been late in the session. So, as a first speaker, I'm glad to invite Dr. Sudhir Kumar to have a presentation on rheumatic manifestation of the diabetes. Dr. Sudhir Kumar sir from Patna.
Good afternoon, everyone. Respected chairperson, moderator, respected seniors, and my colleague. Today I am going to talk about one of the neglected aspects of diabetes mellitus, that is the rheumatological different manifestations. We all know that diabetes is a chronic metabolic condition which is characterized by persistent hyperglycemia, which can result in increased mortality and morbidity by in the form of different microvascular and macrovascular complications. Diabetes, we all know, is a multi-system and a multi-organ dysfunction which can lead to a lot of morbidity. And at current, the total prevalence is around 550 million, and by 2030, the total prevalence will increase up to 4.4% of the total population. Now, depending upon the duration of disease, the extent of control, and the end organ damage, diabetes may pose diverse musculoskeletal manifestations of both clinical and the subclinical nature. Musculoskeletal manifestations are usually under-recognized and poorly treated, unlike other conditions like nephropathy, neuropathy, and cardiovascular complications. Now, there are different causes of rheumatic manifestation. Persistent hyperglycemia is one of the common cause. Hyperinsulinemia in the cases of insulin resistance. Advanced glycosylated end products and inflammation is also the major cause of rheumatic manifestation. There are different classifications. In this classification, we have classified different rheumatic manifestation into 5 groups. The first group is syndromes of limited joint mobility. Limited joint mobility, which consists of 4 parts. Number 1 is stiff hand syndrome. B is dupuytren's contracture. C is trigger finger. D is frozen shoulder. Second one is directly related to bone health, that is osteoporosis. Third one is diffuse idiopathic skeletal hyperostosis or Forster's disease. Now, the fourth part is related to neuropathies. Among the neuropathies, the different manifestations are in the form of Charcot joint, very common, carpal tunnel syndrome, diabetic amyotrophy, a very uncommon condition, reflex sympathetic dystrophy, and the fifth one is direct muscular involvement, that is diabetic muscle infarction. Now, one by one, we will look for all the different conditions. Number 1 is diabetic chiroarthropathy, that is stiff hand syndrome. It is characterized by the painless limitation of the mobility of the small joints of the hand, and its prevalence is very high in type 2 diabetes mellitus. And prayer sign and tabletop sign is very a common sign which is seen in the case of stiff hand syndrome. This is the photograph of prayer sign. In prayer sign, normally when we keep our hand together, palm together in the prayer position, all the aspect of the palm gets in contact with each other. While in case of stiff hand syndrome, only a few contacts are there and most of the palm are separated from each other. Now this also one first photograph of the prayer sign, and second one is about the tabletop sign. When you talk about the second condition, that is ductus contracture, it is characterized by the thickening of the palmar fascia causing a contracture in flexion of the affected finger. In individuals with diabetes mellitus, it mainly affects the third and the fourth finger. In non-diabetic, the fourth and the fifth fingers are the most commonly involved. And the prevalence is very high in case of diabetes in comparison to non-diabetic. The diabetic duration, long-term poor control, and the presence of microvascular complications are the major deciding factors. The good glycemic control, physiotherapy, local steroid injection, local collagenase injection, and in refractory cases, surgery are the major treatment. Now in this photograph, in the first one, we can see the nodules which is present in the palmar fascia leading to slight contraction of the finger. In the second one, a band is there which is very thick leading to slight flexion of the finger. And in the third one, it is full flex position of the fourth and the fifth finger. The trigger finger, also known as snoozing flexor tenosynovitis. It is the tendinous inflammation of the flexor sheath that travel along the fibroosseous tunnel and causes the finger blocking in flexion and active extension failure. The classic presentation of popping and locking of the trigger finger is sufficient for the diagnosis, and incidence of this disorder is very important that it is associated with the actual duration of the disease, not with the glycemic control. And the treatment consists of immobilization with splinting, NSAID, corticosteroid injection, and surgical release. So this is a picture of trigger finger. On palpation, you can easily find the nodules at the base of the finger. Frozen shoulder, one of the common conditions. This is characterized by insidious and the progressive loss of the active and passive mobility of the shoulder joint due to the capsular contraction. And the prevalence is around 11 to 30%. Long duration diabetes, poor control can lead to shoulder calcification. And the treatment includes physical therapy, local corticosteroid injection, and the complete recovery is, it may take a longer time, even up to 5 to 8 months. So this is the photograph. In the first photograph, you can see the shoulder capsules are non-inflamed, healthy, and second one related to the frozen shoulder, where the shoulder capsule is inflamed and it leads to painful mobility. Now osteoporosis. Diabetes is an added risk factor for osteoporosis, and it can lead to increased risk of fracture in women and elderly. The hip the fracture risk is increased by about 6 to 9 times. And in the type 1 diabetes, that is the reduced insulin and insulin-like growth factor is the main cause of the reduced bone mineral density, and it can occur in diabetic patient as a direct consequence of the disease, but it can also be a treatment manifestation. We all know pioglitazone is very prone to develop osteoporosis in bone. Normoglycemia, exercise, and bisphosphonates are very helpful in managing this condition. So this is the classic picture of osteoporosis. We can see here that the fourth lumbar vertebra is the fish sepet. Now, diffuse idiopathic skeletal hyperostosis is the ligamentous ossification of the anterolateral aspect of the spine column, and it is an asymptomatic condition, but numerous clinical symptoms can develop, including pain, stiffness, limited range of spinal motion, and increased susceptibility of the fracture. Insulin has been proposed as a factor that can promote growth in this Forester disease. And the diagnosis of Forester disease is based on the radiological feature. Treatment is mainly symptomatic. So here you can see the yellow arrow is classically showing the ossification of the anterior ligaments. Now Charcot joint. The Charcot osteoarthropathy is associated with a long-standing duration of the diabetes and associated with peripheral neuropathy. A reduction in the normal afferent protective neural impulses and therefore loss of protection from the trauma to the joint leads to the progressive painless joint destruction. It is characterized in the early stage by the acute inflammation without pain that leads to the bone and joint fracture, dislocation, instability, new bone formation, and gross deformities. And the progressive bone resorption, fracture, dislocation increases the deformity and classical rocker bottom appearance observed in the foot. And the treatment is based upon the disease stage. Initially, we can immobilize with the total contact plaster, and rest can prevent the further destruction of the joint. Appropriate orthosis and the crutches, bisphosphonate, and in the last stage, the fusion of the joint, that is orthodesis, is option. So this is the classical picture of the Charcot joints. We can see the deformed foot with the clawing of the toe, and the curvature is increased convexally downward, that is rocker bottom. The carpal tunnel syndrome is a painful disorder caused by the compression of the median nerve in the carpal tunnel. The severity of the disease is not related to the duration, but rather to its association with different microvascular complications. The clinical features include nocturnal paresthesia, spontaneous pain along the distribution of the median nerve in the hand. Shaking sign, tinel sign, and Phelan tests are positive. The diagnosis becomes definite in the nerve conduction test, and the treatment consists of conservative measures or surgical release. Of the conservative measures, only splinting and the corticosteroids are supported with the high quality evidence. So this is the picture of carpal tunnel syndrome, where the nerve is compressed in the carpal tunnel, and paresthesia, numbness, and pain is seen in the fingers, which are median nerve, that is thumb, index finger, middle finger, and half of the ring finger. Diabetic myotrophy is characterized by burning, severe aching, and lancinating pain in the hip and the thigh, followed by weakness and marked weight loss. We can see the weight loss up to 30 to 40% in the case of diabetic myotrophy. The most likely mechanism of this condition is inflammatory, immune-mediated lumbosacral radiculoplexopathy. And the treatment includes immunosuppressive therapy in the form of IVIG and high-dose methylprednisolone, in addition to good glycemic control with marked recovery in majority of the patient is seen. So this is the classical picture of the diabetic myotrophy. We can see the wasting of the muscle, which may be very painful. Reflex sympathetic dystrophy. It is also known as algodystrophy, Sedex dystrophy, and chronic regional pain syndrome type 1. Typically it presents with the allodynia, burning pain, and hyperalgesia with marked autonomic features. Main modality of treatment are analgesic, physiotherapy, bisphosphonates, oral corticosteroid, and sympathetic ganglion blockage. The outcome is usually good, and some patients may develop the chronic pain and contracture in the hand. So this is the classical picture of reflex dystrophy, where the hand is seems to be painful and swollen. Pseudomotor sign will be present. Now the last is diabetic muscle infarction. Diabetic muscle infarction has an acute onset characterized by muscle pain and the swelling. Thigh muscles are the most frequently involved, followed by the calf muscle. and it is most commonly seen in insulin-dependent diabetes mellitus. Diffuse diabetic microangiopathy, hypercoagulability, vascular endothelial damage, and advanced atherosclerosis are the responsible mechanism. MRI is the diagnostic test, and it gives a typical picture on T2 weighted images with the marked muscle edema. And the recommended management is symptomatic with pain relief, and short-term immobilization is needed. So this is the condition of diabetic muscle infarction. You can see in the MRI, the edema is there in the. So the take-home message is, diabetes mellitus is a systemic disease, not only causes metabolic problems, but also can lead to wide variety of musculoskeletal problems. Assessment and early management of musculoskeletal problem in diabetic patients can prevent the pain and the morbidity. Euglycemia and exercise are important for primary prevention as well as the disease management. Different orthosis, physiotherapy, splinting, medication and surgery are needed for different rheumatic manifestations. Thank you.
Extremely sorry that no questions would be allowed just now. Now, I would request Dr. Sudhir Kumar to remain on the dais. And
so, very good afternoon, first all of you. And I would like to invite Dr. Nirav Kumar from Patna. And topic is thrombolysis, where it stands today. Please, well.
Good afternoon, everybody. I must say thank to organizer for giving me this opportunity. So after masterly talk by Dr. Sudhir, my topic is also very common, the thrombolysis. There is always question ki whether we should do the thrombolysis or not, or what is the appropriate time, what is the dose. So there is always confusion regarding thrombosis. So we should start how and why thrombolysis is required and what is role of thrombolysis. So when heart attack takes place, initially it started with plaque rupture. Here you can see the plaque, the yellow one is the plaque, then there is rupture. The pro-atherosclerotic material goes into the artery. So there is activation of platelet, and that will cause activation of coagulation system also. So after plaque rupture, there is activation of platelet, then there is activation of coagulation system, and fibrin is get deposited over there. So ultimately, the prothrombin converted into thrombin, fibrinogen converted into fibrin. So this fibrin form a firm base for the clot formation. It is the scaffold for the clot, and it make the clot solidify. It can block the artery easily, and it cannot be break with the usual the drugs. So when we go to the history, James Herrick in 1912, he mentioned that after doing the autopsy of one of the myocardial patient, the hope for damaged myocardium lies in the direction of securing a supply of the blood. So almost 50 years gone to prove this, ki whether death was due to the blockage in the artery or blockage takes place because of the death. So there was confusion initially in the 19th century. So then the things was settled. The first use of thrombolytic therapy with patient with acute myocarditis was reported by Fletcher and colleagues in 1958. So 1958, the first thrombolysis was done, and more than 2 lakh patients has been randomized in clinical trial of thrombolytic therapy, and no other area of medicine has the therapy been so extensive. So it was the most extensively studied area. So how it works? The plasminogen is get converted to plasmin by these medicines like streptokinase, the LT-plase, the TT-plase, and the plasmin convert the fibrin into fibrinogen. So this the most important thing is fibrin. It should be break to open the artery. So that's why the thrombolysis is required, and after thrombolysis or the other medicine like to break the platelet, break the viscous cycle of proatherosclerosis is also required. So this study was published in Circulation in 1998. According to this study, they mentioned that thrombolysis is life-saving, and in every aspect from 0 hour to up to 12 hours, there was benefit. So in 1998, before 1998, it was clear that up to 12 hours, we will do thrombolysis, there is motility benefit, and after 12 hours, the motility benefit was less. So according to this, the ideal thrombolytic agent should be rapid perfusion. It should be given within 15 to 30 minutes. Close to 100% efficacy for reperfusion, can be given as rapid venous injection, low rate of intracranial hemorrhage, low rate of systemic bleeding, specific for recent thrombi, low rate for early reocclusion, sustained patency in long term, no effect on blood pressure. So these are the ideal characteristics should be in thrombolytic therapy. So why thrombolysis is important? With every minute there is myocardium is dying. So within a few minutes there is damage of myocardium takes place. As the time goes on, the extent of damage is more and more. So early opening of the artery is very important. Otherwise, if there is delay, the death will be more. So definitely the rapid perfusion is very important, and every minute counts. So this is very important to open the artery as early as possible to save the important myocardium, because if myocardium get damaged, the patient will develop breathlessness, heart failure later on. So it is very important to reverse the process, arrest the myocardial infarction at that time, and this is very important. So we can arrest the process by two ways. We can do it by mechanical way. We can pass a wire through the artery. We can put a balloon, and balloon can be dilated, flow can be maintained, and then stent can be placed. So by doing this, we can establish the flow, and that is TIMI-3 flow, means normal flow. TIMI-0 flow is there is no flow. TIMI-1 is sluggish flow. We can establish the TIMI-3 flow easily with angioplasty. The second option is we can do the thrombolysis. And with thrombolysis, fibrin get destroyed. It will convert it into soluble fibrin product, and patency can be maintained. So by both the method, we can solve this problem. So by doing the thrombolysis, main things is whether the whole clot will dissolve or not. So like in this ECG, here we can see the upper one is how to, this is also important, how to see the response. So in upper ECG, you can see that there is ST elevation from V1 to V4. So this is massive myocardial infarction, because in maximum leads there is changes, and there is reciprocal depression in second, third AVF also. So this is massive myocardial infarction, and after 60 minutes of thrombolysis, there is response. So more than 50% settlement of the ST segment elevation is there. So there is positive response. If positive response is not there, that means the clot is not dissolved, and patient will require rescue PCI. So in this condition, if response is not there, if ST segment is not settled, rescue PCI is required. So in all those hospitals, if rescue PCI facility is not there, the patient will not be saved, and recurrent MI can take place, and heart failure and cardiac shock can take place. So in this patient, there is a response, but if there is no response, the PCI will be required. So every minute counts. So what happened if ambulance is in the road? So what will, where is the minute? It can take hour from going here to there, especially the jam of Patna and other places. So our principal, our main motto will get defeated. So can we do pre-hospital thrombolysis? It is very important. If we do thrombolysis inside the hospital, the early the artery will open, the more myocardium will be saved. So is it, there is evidence in favor of this. So according to this trial, this is STREAM trial. This trial was released in 2013, and within 3 hours, they did the thrombolysis inside the hospital, inside the ambulance, and the rest of the patient, they did the PCI. So the result was that it was almost, the result was similar in PCI group as well as thrombolysis group. Death reduction was almost same. So it was feasible, it was useful also, and early you will start the thrombolysis, the better will be the benefit. So the only thing was that in some of the patient, almost 36% of patients were requiring urgent angiography in fibrinolysis group. So, and there was more intracranial hemorrhage, like almost 1.6% in fibrinolysis group. So more hemorrhage was there, and recurrent PCI or rescue PCI was required in this patient. Although mortality was same, only a stroke event was more in this trial. So another trial was CAPTAIN trial. This is also very important trial, last trial, and this is the follow-up of the 5-year follow-up, and the mortality was same in both the group. In thrombolysis group, which was done in pre-hospital. In this trial, within 6 hours pre-hospital thrombolysis was done. So it is feasible to do the thrombolysis, it was safe, and it was as good as PCI if done early as early possible. So we have two options. We can do the primary PCI if facility all available within 3 hours, or we can do thrombolysis within 3 hours. The result was almost same in terms of mortality reduction. If we are getting the patient between 3 hours to 12 hours, we can do the PCI, we can do the thrombolysis, we can send those patients for primary PCI, and primary PCI can be done within 24 hours. That is called pharmacoinvasive PCI. If we are getting patient after 12 hours, there is more and more fibrin is there, clot is more organized, so thrombolysis is not effective. If some patient develop recurrent MI, if some patient develop heart failure, if patient is cardiogenic shock, in all those conditions, primary PCI is better because it establishes the flow mechanically, it establishes the flow. So if synergy is there with PCI and thrombolysis, there is benefit. So in 1986, the trial was done only with the thrombolysis, and their mortality was 13%. Then arrival was streptokinase, then arrival was aspirin and streptokinase, TPI was arrived. So there was decrease in mortality, and after this trial, the origin MI, the mortality in MI was almost 2.5%. So with improved stent, with improved patency, and with improved synergy between the thrombolysis and PCI, the mortality was much less in this trial. So these are the terms which is used, often used, the first medical contact. First medical contact means the first person who can diagnose the condition, the MI at the place. ST elevation diagnosis should be done within 10 minutes of first contact. The primary PCI should be done within 12 hours of infarct-related artery, and rescue PCI when thrombolysis is failed, the PCI can be done. So these are, and the pharmacoinvasive study means you give the thrombolysis and you do the PCI up within 24 hours. That is pharmacoinvasive. These are the common terms which is used. So what is the ideal condition? Ideally, there should not be any patient delay. If there is chest pain, patient should cut it immediately to the competent doctor. So here in patient part, there is always gas problem. MI, frank MI, always they presented late, and all problems they explain with the gas. Even with doctor, they are presented much delay, and this is a very common problem. The other thing is the system delay. So ideally, if the first medical contact is there, within 10 minutes the thing should be diagnosed. And if diagnosis is done, in that condition, if possible, if primary PCI is possible within 120 minutes, meaning by if primary PCI is possible in that town within 2 hours, it should be done, and it should be done as early as possible. If not possible, in that condition, the thrombolysis should be done. And ideally, thrombolysis should be done within 10 minutes. So in Bihar, there is always problem. Even relative takes 1 to 2 hours to explain that whether they are going for thrombolysis or not. Patient take time because of this could be a gas problem. There is inherent delay in doing ECG, and there is inherent delay in diagnosing the condition. Ideally, in ambulance, it can be diagnosed. If possible, the staff can diagnose the condition, or he can send those ECG with WhatsApp or other group to the core hospital, and the thing should be diagnosed within 10 minutes. That is the ideal condition. So ideally, this should be the condition. So first medical contact to ECG and diagnosis should be within 10 minutes. If possible, PCI should be within 2 hours. If possible, thrombolysis should be done within 10 minutes. So these are the thrombolytic agent. The streptokinase, it is given 1.5 million unit. The alteplase, which is given. So these are the fibrin specific product, tenecteplase and reteplase and alteplase, and the non-fibrin, the streptokinase is there. So there are other indication of thrombolysis also, like in a stroke it can be used. If a stroke is mild to moderate, it can be used up to 4.5 hour. It is drug of choice in case of pulmonary embolism, if RV function is jeopardized, or if there is a shock because of pulmonary embolism, if there is threatened limb, if thrombus is there inside and it's threatening the limb, in that condition thrombolysis can be done. In a stuck valve, if mechanical valve is there, it can be done. So in summary, it is relevant. Thrombolysis is relevant in every aspect, and it should be done, and there should not be a delay in everything. And there is inherent fear that the patient can have intracranial hemorrhage. But only 3 conditions are: if advanced age is there, if weight is less, if female sex is there. In all these conditions, the chances of intracranial hemorrhage is there. So we should recognize all an advanced age. So we should recognize all those group, and we should not thrombolize in those group patients. And there should be ease of administration, particularly in pre-hospital thrombolysis. So the bolus drugs should be used, like tenecteplase, and there should not be any taboo in using the thrombolysis, because it is life-saving. If intracranial hemorrhage risk is, it is around 1% or 1.5%, but the life-saving is around 15 to 18%. So it should be given. And we should look for the contraindication also, if there is intracranial hemorrhage, AV malformation, if there is large surgery. So if at presentation very high blood pressure is there, so contraindication we should remember that, and we should look for the response for the therapy. If thrombolysis has been done, after 60 minutes ECG should be done, and whether the settlement of STT segment more than 50% or not. If it is failed, we should send those patients immediately for the rescue PCI. And early transfer, if thrombolysis is done, it should be transferred to PCI capable hospital as early as possible, because within 24 hours the angiography and the pharmacoinvasive PCI should be done to save important life and save recurrent MIs, to save cardiogenic shock and all other complications. And there should be synergy between the physician and the cardiologist, and there should be synergy between the pharmacoinvasive therapy, the thrombolysis and primary PCI. Thank you.
Thank you, Dr. Nirav. Please stay on the dais. And now I would request Dr. Shambhu to.
Our next speaker is Dr. Shamshad, and topic is very interesting from cardiology and physician point of view. It's approach to a patient of syncope. Dr. Shamshad, welcome.
Yeah, good morning everyone, and I am very thankful for being invited at this platform. So today we will be discussing about how to approach a syncope. It is a very vast topic. It will be quite difficult to cover up in 15 minutes because we have to classify whether it is cardiac or non-cardiac, neurological syncope or other idiopathic causes. Let's start. Usually the best thing which is available to us for approaching a syncope are the guidelines, whether ASCC or ESC guidelines. ESC guidelines, they are the best one because these are the more apt when it comes to our Indian population. So let's first define syncope. It is a transient loss of consciousness which is due to transient global cerebral hypoperfusion. It has a rapid onset, it should be a short duration, and it should have a spontaneous complete recovery. Any syncope which is not having a complete recovery, it is not a syncope, it is a stroke. Other definition which should be kept in mind are what is a transient loss of consciousness. It is a state of real or apparent loss of consciousness with loss of awareness, and it should be characterized by amnesia for that period of unconsciousness, abnormal motor control, loss of responsiveness, and it should be of short duration. It is a syncope when the features of reflex, orthostatic hypotension or cardiac syncope are there. And also specific features of other forms of syncope such as seizures, they should be absent to classify it as syncope. This is the basic classification of transient loss of consciousness. One is traumatic, usually seen after head trauma, and others are non-traumatic, which can be classified as syncope due to reflex, orthostatic or cardiac, epileptic seizure, psychogenic syncope, psychogenic transient loss of consciousness, and other rare causes, which can be vascular causes or causes due to vertebrobacillary TIA, hemorrhage, and cyanotic children. The reflex syncope, it can be reclassified into vasovagal syncope. It is usually orthostatic. Situational, those syncopes associated with micturition. We often confront patients who say that I have got a syncope while in the bathroom. So we usually ask them कि क्या आपको ऐसा हुआ था कि पेशाब जोर से लगी थी, उसके बाद पेशाब करने गया और बेहोश हो गए. So this is a typical history which is seen. At times syncopal patients, because we know that in our patients of Bihar, they have their own reasoning. We have diagnosed the reason why it has occurred. At times patients come with syncope and they say that ki gas ban gaya or syncope ho gaya. It is not gas formation. This is basically a gastrointestinal stimulation associated syncope. It can occur. Usually it is precipitated by abdominal discomfort and abdominal pain too. Those associated with cough or sneeze. We have confronted a lot of patients during COVID times. COVID times the prevalence of syncope increased. That was basically due to recurrent cough. And it was associated with syncope because recurrent cough excites vagal stimulation. Others are post-exercise, laughing continuously, and other syncope are reflex syncope are due to carotid sinus syndrome and other non-classical forms. Due to orthostatic hypotension, they can be drug-related. Most commonly, drug which is used is diuretic-associated orthostatic hypotension is commonly seen. And others are which our population most commonly use is the drugs for BPH, benign prostatic hyperplasia. Usually, it is said that those drugs should be taken at night, but usually most of the patients take it in the morning. So that's why syncope is precipitated by these drugs too. And other common reasons which in summer, volume depletion, hypovolemia, primary autonomic failure, mostly in the patients of multiple system atrophy and Parkinson's disease, and other neurogenic causes can be seen. What comes to a cardiologist perspective, basically my perspective is cardiac reasons of syncope. Usually they are mostly associated with arrhythmia. Bradyarrhythmia are more common as compared to tachyarrhythmia. Also the structural heart diseases, most commonly severe aortic stenosis, they are associated with syncope. At times patients with hypertrophic cardiomyopathy, due to dynamic LV aortic obstruction, syncope is seen in these patients, and those patients who have atrial myxoma, young patients, if they present with syncope and we suspect a structural abnormality, they can present with atrial myxoma which remains undiagnosed if a good echo is not done. And cardiopulmonary blood vessel pulmonary embolism, those cases of severe pulmonary embolism, they usually present with syncope, first presentation. So these are the classification. The pathophysiology of different kinds of syncope varies, and at times it is not said that a single pathophysiology is responsible for a single kind of syncope. It can be related to other kinds of syncope too. So these all pathophysiology are interconnected. That's why this circle is made. This is a diagrammatic depiction for understanding the pathophysiology. So as we have a less amount of time, we have to move forward as fast as possible. When it comes to epidemiology, the most common cause of syncope as per the Framingham data, it is idiopathic. Unexplained syncope, they are most common. But when it comes to assessment from data from the emergency department, reflex syncope is the most common cause of syncope. Whenever a patient of transient loss of consciousness presents, and if we diagnose it as a syncope, then initial examination, ECG, whatever is required, we do. if there is a certain diagnosis which is made in the emergency department, then obvious treatment is to be done. But most of the cases, they are not diagnosed exactly in the emergency. So the risk stratification has to be done, whether we need to admit these patients and further proceed with further investigation or not. If the patient is low risk, very rare events of syncope, then obviously these do not need any further evaluation. They can be sent off home, and they say, we have to say that if this occurs, then you have to come back again. But low to medium risk patients and also high risk patients, these patients have to be admitted at least. High risk have to be admitted in IPD, and low to intermediate risk patients have to be taken for a daycare kind of management. So this is the flow chart which has to be followed, which I have discussed just now. History is very important. Vasovagal syncope has a typical history. Precipitating factors are there: pain, fear, standing, long prolonged standing, or summers. As summers are coming, so sweating, prolonged sweating is a very important contributing factor. Situational syncope can occur during defecation, urination, and orthostatic hypotension. Diagnostic criteria: whenever we get ECG with a complete heart block or Mobitz type 2 heart block, alternating left and right bundle branch block, and also non-sustained or sustained events of VT or rapid onset of paroxysmal SVT, then obviously these are cardiac causes of syncope. And if the patient is on pacemaker or AICD, if any malfunction is there, they can really be responsible for syncope. And not only cardiac arrhythmias cause it, even cardiac ischemia also lead to syncope. So acute myocardial infarction, they often present with syncope. Usually these are most commonly seen with inferior wall myocardial infarction. Even in absence of any arrhythmia or even in absence of any heart block, these patients present with syncope. Usually when right ventricle is involved in inferior wall myocardial infarction, then obviously the blood flow from right side of the heart to the lungs is impaired. So that obviously leads to hypotension, and that leads to syncope. These are the echo when it is required in case of atrial myxoma, ball valve thrombus, severe aortic stenosis and pulmonary embolism, and acute aortic dissection. When it involves the carotid, it has the dissection flap. When it moves towards the carotid artery, extension in the carotid, then it leads to syncope too. When we require blood tests, so basic blood test has to be done in every patient, because we have to rule out whether the patient is hypovolemic or not, anemia is there or not, if the patient is cyanotic, if the oxygen saturation is in the required amount or not. We have to rule out pulmonary embolism. For that, D-dimer test is required. Any myocardial infarction has to be ruled out for cardiac ischemia related syncope. The clinical features and ECG, they have to be matched. Whenever we deal with a patient of syncope, we should not be a robot. Basically, we have to match the clinical features and associated investigation, the results which we are getting. That's why we can further approach and further follow up manage these patients. So the history, different maneuvers, different exposures, they have to be find out in these patients whenever we approach these patients. So this is the initial evaluation. Whenever there is uncertain diagnosis, if we suspect it is a cardiac, obviously echocardiogram, ECG is required, APA study if required. We can go for a stress test and coronary angiogram if it is required. We have to do that. If we are thinking that the cardiac cause is unlikely, then ECG monitoring and implantable loop recorders or external loop recorders can be used. If we are very much sure that this is not a cardiac cause of syncope, then obviously no cardiac investigation is required, and we have to reassess these patients. That's what we are dealing with. The basic, whenever we deal with autonomic failure, we have to perform active standing test. We have to monitor blood pressure fall and heart rate increase or any heart rate fall in that patient. Valsalva maneuver, deep breathing, cardiac carotid sinus massage, tilt-table test, which is very rarely used nowadays, and ambulatory BP monitoring has to be done. The active standing test, we say that after 3 minutes, if any significant fall in blood pressure, that is 20 mm systolic blood pressure or 10 mm diastolic blood pressure, or a heart rate decrease, it is seen, then these can be contributing to the cardioinhibitive reflex syncope, basically. The response is of two different types, whether it is cardio-inhibitory or vasodilatory. In vasodilatory, usually blood pressure is falling, but in cardio-inhibitory, the heart rate also falls. These are the guidelines of ESC, that how we have to do standing tense, and what are the predictors which say that if these changes are seen, then these patients have to be further evaluated and managed. Carotid sinus massage, any asystole for more than 3 seconds or any blood pressure fall of more than 50 mm, then it is said to be a positive test. If it is associated with symptom, then it is carotid sinus syndrome. If it is not associated with symptoms, it is carotid sinus hypersensitivity. These are the graphs which you usually get when we perform carotid sinus massage. So the indication of carotid sinus massage, any patient below 40 years, usually it should not be done, because carotid sinus hypersensitivity, even it is not seen in younger patient. When it comes to ECG monitoring, different types of ECG criteria has been prefixed for these patients. Type 1 is asystole. Asystole usually leads, it combines complete heart block, sinus arrest, AV block, or type 2 AV block. Bradycardia, if the heart rate is more than 30% or heart rate is less than 40 beats per minute. Slight rhythm disorder, but uncertain effects of that rhythm disorders are seen. And finally, tachycardia, usually rapid onset supraventricular tachycardia and ventricular tachycardia. ECG indications of ECG, we now at time we see that any patient of syncope, everyone is ordering a 24-hour Holter test. It should not be a universal test for everyone. There are guidelines that when we have to do a long-term ECG monitoring and what kind of long-term ECG monitoring has to be done. So whenever the symptoms are uncertain and we are not able to diagnose, if it is a high-risk patient, high-risk criteria have been depicted. If the patient fulfills those criteria, then obviously the patient has to be admitted. In hospital, ECG monitoring has to be done in these patients. If in hospital ECG monitoring is negative, then these patients have to be implanted an ILR. Implantable loop recorder has to be done for these patients, so that a long-term ECG continuous monitoring should be done in these patients. Whenever an event occurs, we can easily catch these. In low risk but arrhythmia prone patient, we have to go for ILR. It is a class 1 indication, or ELR, that is a external loop recorder. It is usually performed for 7 days. It is a 7 days Holter. Or if it is not available, then we can go with a 24-hour Holter test. So the importance of Holter monitoring, it is very low. It should not be used that much frequently as compared to external loop recorder or internal loop recorder, implantable loop recorder. And if for low risk patient also, we need a ILR. Those patients who experience symptom at prolonged intervals. Suppose if a patient is experiencing cope once in a month, then obviously our 24-hour Holter test is not going to catch that. Even 7 days Holter monitoring, ELR is not going to catch that. So we need ILR in those patients. And if the episodes are very rare, suppose the episodes occur usually at 3 months or 6 months, then no monitoring is going to benefit. We are not going to achieve anything by doing any prolonged monitoring. So these are the diagnostic criteria. EP study, it has to be done when where we suspect that it is due to any arrhythmia, and we are not able to diagnose that. Then we have to induce that arrhythmia on electrophysiology lab. Echocardiography, if we are suspecting any structural disease which might lead to syncope, usually severe aortic stenosis, hypertrophic cardiomyopathy, left atrial myxoma, or any kind of ball valve thrombus, if it is obstructing any forward flow in the heart, then obviously it has to be ruled out. Exercise testing, it is very rarely required, but there are certain subsets of patients, especially nowadays, younger patients, they experience syncope after doing gym or after doing exercise. So then in these patients, we have to perform exercise testing. We have to induce whether if syncope is occurring after exercise or during exercise or not, whether we are getting any ECG changes during exercise or after exercise. And finally, need of coronary angiogram. So the indication of coronary angiogram, it is not different for those patients of syncope. The guidelines remain same what it is done for coronary artery disease patients. So that same guideline has to be followed for coronary angiogram in these patients too. Thank you.
Thank you, Dr. Samshad Alam. Kindly be seated on the dais. And for the last talk, I would request Dr. Sumit Kumar Verma. He would be presenting few interesting cases.
Good afternoon, everyone. Without wasting time, I am directly proceeding to my case. Yes. This is a case who comes to my OPD, a 28-year female who underwent both aortic and mitral valve replacement 18 months back, presented with persistent dry cough for 5 days, shortness of breath which increased in last 5 days, and at present patient is dyspneic even at rest. She was febrile 5 days back, but fever subsided in next 48 hours. The history itself says the diagnosis, but I'm proceeding further. She is on warfarin 2 milligram and diuretics. She was also taking oral antibiotic, anti-allergic and antitussive for last 5 days. I am only explaining the relevant things. On general examination, pulse was, she was tachycardia. It was 112 per minute and BP was 90 millimeter of Hg systolic. What should be the next investigation for decision making? I opt for 2D echo, and let's see what happened there. Okay. So here is the 2D echo picture. The cursor is along the LA and LV. Here we can see that there is pressure gradient between LA and LV, that the mean pressure is 36.70. The normal limit is 5 to 8, but it is 36.70. So from here we can directly say there is obstruction between the LA and LV. So it is a case of, and the onset is acute, so it is a case of a stuck mitral valve due to thrombus, acute thrombus. It is further physics of 2D echo, I don't want to go into it. So the diagnosis of stuck mitral valve was made, and after that the routine examinations come, and then the INR was 1.7. So we have option there for thrombolysis because of the cost burden of the surgery. I go for the thrombolysis, and patient was put on the continuous infusion of a streptokinase for 24 hours. Patient's dyspnea and cough subsided, and repeat 2D echo done after 24 hours. And here in this echo we can see the mean pressure gradient decreased to 3, that is a normal. So after that, target INR was achieved by low molecular weight heparin and warfarin. Patient was the main thing. The patient was counseled about the importance of INR after valve replacement surgery and discharge. This is the first case. The second one is a 62-year-old male, known case of type 2 diabetes, peripheral arterial disease, CKD, presented with shortness of breath on exertion with minimum effort, swelling of both lower limb, dry cough, more on lying down posture, and all complain with last 1.5 months. He didn't have any history of chest pain during this period. So I took the drug history, and patient was on metformin, glimepiride, empagliflozin, sitagliptin, torsemide, and intermittent inhaler. Blood reports are the relevant things is the anti-proBNP, which is 2700, and CRP, it was 11. The diabetic status was uncontrolled. So, and the further dose of diuretics was increased thrice in last 1 month as per record, but there was no satisfactory improvement in patient symptom. After that, there was a report of 3 months back 2D echo, which shows concentric LVH with normal EF. After seeing the report, I just asked to the patient why you went to the cardiologist for echocardiography. Then he told me that 3 months back I have a big chest pain that was not fully explained by him, and it was subsided in 1 to 2 days. So patient went to the cardiologist, and there was 2D echo was done. It was okay, and then patient said, "Sir, I was okay." And after that echo, after 3 to 4 weeks, I started developing shortness of breath. So the physical examination done, it was the relevant BP was 110/70, pulse was patient has tachycardia, JVP was raised, there was pedal edema. In ECG there was sinus tachycardia, no specific STT changes, so I did again the 2D echo, and here as the slide, the patient was not prepared for the academic purpose, but I just put the what I did. Echo was not done according to academic protocol. But here what we can see is there is a pericardial effusion of 12 mm with there is no early diastolic collapse, so no evidence of cardiac tamponade. And yes, there is brightening of pericardium. So there is increased thickness of pericardium. It is around 6 mm. Though 2D echo is not accurate to say, but it somehow at some level it suggests there is increase in thickness of pericardium. So there was pulse wave Doppler across the mitral flow. Blood flow across mitral valve was seen. There is almost 20% variation of the blood flow across a mitral valve with respiration. So it shows there may be the diagnosis was the moderate pericardial effusion with effusive constrictive physiology. It was not effusive constrictive pericarditis, but effusive constrictive physiology. So I have options, 3 drugs we can use, whether NSAID, corticosteroids and colchicine, but because of the renal status and the diabetic status, I prefer colchicine as first choice, and 0.5 milligram it was given according to the renal modified dose, but patient did not tolerate this even this dose, so I reduced it to 0.5 milligram alternate day. After 3 weeks, I repeated 2D echo, and here when see there is no pericardial effusion, and also there is decrease in pericardial thickness. Perhaps in the next slide, yes, it has reduced to 4 mm. So there is a settlement of and patient. This is the echo picture, and there was drastic improvement in patient's NYHA status. So still patient is on colchicine, and there is decrease in thickness of, in view of patient may develop constrictive pericarditis. So I put the patient to continue on the colchicine for the next 3 months. After that, I will plan to withdraw this after 3 months. So in every cardiac dyspnea, diuretics are not effective. Thank you.
Thank you, Dr. Sumit. Please stay with us. And now we would have the felicitation ceremony.
Chairperson for this particular session. Can you come forward? And Dr. Neera Kumar, sir. And let's have a huge round of applause for Dr. Neera Kumar, sir. Has come all the way from Ghana and over to here. I will now request Dr. Virendra Kumar, sir, who will be honorable chairperson for this particular session, to kindly come forward and honor our speaker, Dr. Samshad, sir. Let's have a huge round of applause for Anand, sir. Heartfelt thanks to you, sir. And I will now request Dr. Shampoo Kumar, sir, who will be honorable chairperson for this particular session, to kindly honor Dr. Surya Kumar, sir. Let's have a huge round of applause for Surya Kumar, sir, as well. And I would now request our honorable moderator for this particular session, Dr. Neeraj Kumar, sir, as well as from there, to kindly come forward and honor our speech chairpersons. I would request our moderator, Dr. Neeraj Kumar, sir, to kindly honor Dr. Ajit, sir, as well as Dr. Bhavesh, Dr. Virendra, and Dr. Shamu, all the honorable chairpersons for this particular session. And I will request Dr. Abhishek to kindly come forward and honor our chief moderator, Dr. Neeraj Kumar. And I will request all of you, let's have a huge round of applause for this. Very beautiful. Let's have a huge round of applause for this. Sweet, beautiful moments, बहुत ही प्यारे स्वर्ण क्षण की हम सभी लोग हैं आगे बढ़े मंच पर सभी गणमान्य अध्यक्षों के साथ साथ सभी वक्ताओं को हमारे आदरणीय मॉडरेटर को सभी को सम्मानित किया जा रहा है। कहते हैं कि सुंदर क्षण हम सभी लोगों के लिए बरसात का कार्यक्रम चाहिए आप सभी लोगों की ओर से। और आप सभी लोगों से अनुरोध है कि आप ऊपर पूरा आगे आ जाए ताकि एक बहुत ही प्यारी सी तस्वीर ये सभी हमारे फोटोग्राफर्स इस बहुत ही प्यारे से और अद्भुत से क्षण की और आप सभी को मैं बहुत बहुत धन्यवाद कहना चाहूँगा। once again heartfelt thanks to each one of you, to all the speakers, to all our honorable chairpersons as well as our chief moderator. So, as all of you can see, we are formally concluding this particular session, and we are all set to commence our next session. And in order to moderate this particular session, I will now like to call upon stage Dr. Professor Bugusarai, sir, has come all the way from Patna. Let's have a huge round of applause for Dr. Professor Bugusarai, sir, who is now going to moderate this particular session for all of us. A very, very warm welcome to you, sir. I would now like to hand over the stage and mic to you, sir, so that you can take the proceedings further. Thank you.
Good afternoon to everyone. I welcome you all in this last plenary session of today. It is completely dedicated to the nephrology. There are 3 different talks which are very brilliantly chosen from the different parts of the nephrology which we come across in the daily practice. And there is one case presentation, so just cut down the time. I will call upon the chairpersons Dr. Om Kumar, Dr. P.K. Singh, Dr. Padmakar Singh, and Dr. Rupak Kumar Singh on the dais. The first topic is dedicated to the management of kidney disease in the diabetic patients. This is the most common problem we come across the practice. There are two main important pillars in the management of the diabetic, the control of the hypertension and hyperglycemia. But there could be some other factors which may modify the disease, like dietary modification, control of hyperlipidemia. There could be drugs which may modify the intraglomerular pressure and the intraglomerular hyperfiltration. So these will be discussed by our esteemed speakers. I hand over the mic to our chairpersons to introduce the speakers.
I think Dr. Pankaj Hans doesn't need any introduction. He is one of the most renowned nephrologists of Bihar. Presently, he is working in prestigious Patna Medical College and also heading the Department of Nephrology at Reuben Memorial Hospital. He is a regular speaker in state conferences, zonal conferences, and national conferences. He is a very learned nephrologist. So without wasting time, I request Dr. Pankaj Hans to deliver his lecture on management of CKD in diabetics. We have to listen his lecture very carefully because it is very important and tricky one. Dr. Pankaj.
Honorable Moderator Dr. Bugusarai sir, respected chairpersons, seniors and my dear colleagues. The topic of my presentation is like playing a test match in a 20-over IPL match, but I will try to justify it. So as we all know that the diabetes is quite common in India, and India is known as the diabetic capital of the world. And so far as CKD is concerned, numerous studies have been done, and it has been found that the prevalence of CKD in India is about 6 to 17%, averaging 10.4%. And you all must be familiar with this heat map of CKD. The red one indicates that they are bound to progress rapidly, and active intervention is needed, and timely referral is needed in these stages. Not going to discuss the staging, coming to the topic proper. So for diagnosing CKD in diabetes, what is needed is screening. And all these odd guidelines, ADA, KDIGO, ESC, and combined ADA, KDIGO consensus guideline, they recommend the necessity of screening. So how to screen? Two methods. One is the estimation of urinary albumin creatinine ratio, and the second one is to measure the eGFR. Don't go by serum creatinine, you go by eGFR. And the frequency should be annually, and in some cases, this frequency may be decreased if the patient is a high-risk patient. So the red ones, as I told, these stages need referral to a nephrologist timely so that active interventions may be done. Coming to the topic of management, glycemic control. I am not going to discuss DCCT and UKPDS. You all are quite versed with those things. I will discuss only those changes that has occurred over the last 5 years. So this is, we all know. Now this, previously we said that tight control of diabetes is needed in a patient suffering from diabetic kidney disease, and the HbA1c should be around 6.5 to 7. But it has been now come into literature that it has to be individualized depending upon a stage of CKD, presence of microvascular complications, comorbidities, life expectancy and associated hypoglycemias, etc. If the patient belongs to higher grades of CKD, in that case the HbA1c should be higher, like 8. And in earlier stages, you can keep HbA1c at the lower level of cutoff, that is 6.5. This slide is very important for all of us to know that when to use metformin and when not to use metformin. So if you come across a patient of diabetes with CKD and the GFR of the patient is less than 30, straightforward, don't initiate metformin, and if the patient has been on metformin, it may be discontinued. If it is more than 30, between 30 to 45, then metformin may be started in 50% of the dose. Above 45, full doses may be initiated, and that has to be titrated at interval of 7 days. And depending upon yearly change of the GFR, you may go on changing the dosing of metformin. The burning topic is SGLT2 inhibitor. Today morning, Dr. Chandramohan has discussed the various cardiological trials in quite detail, like EMPA-REG, CANVAS, DECLARE, etc. These were the primary cardiological trials, and the secondary renal outcomes were studied. Likewise, in EMPA-REG trial, there was 46% risk reduction in the renal outcomes. In the CANVAS and DECLARE TIMI trial, there was 47% risk reduction in the renal endpoints. So there was a need for dedicated renal outcome trials, and the first such trial was Credence trial. In this trial, the patient selection was in the A3 group and the GFR was less than 60, and as is shown over there, there was 30% risk reduction compared to placebo in the renal outcomes and 20% risk reduction in the cardiovascular outcomes. Then came the famous DAPA-CKD trial, after which the treatment of CKD has been revolutionized. It was done in 21 countries, including India, from where 210 patients participated. Total 4,304 patients were there in this study. 2 arms, one was DAPA arm, the second was placebo arm, and this study was stopped prematurely because of the clear-cut benefits that were encountered earlier. So the results were that primary outcomes like sustained decline in eGFR, ESRD, and death from renal or cardiovascular causes that declined by 39%, and overall mortality decreased by 31% in all these patients. And this benefit was not only limited to DKD patients, all patients having CKD because of glomerulonephritis, hypertensive CKD, and other causes of CKD, they also benefited from it. Lastly, in this last year, one trial came EMPA-CKD trial. Earlier, we used this SGLT2 inhibitors only up to the GFR of 25 or 30, but this EMPA-CKD trial has advocated that this drug can be used up to a GFR of 20, and it has been concluded that among a wide range of patients with CKD who were at risk for progression, EMPA therapy leads to lower risk of progression of CKD or death from cardiovascular causes. This is just a comparison of these 3 trials, Credence, DAPA-CKD, and EMPA-CKD. Then comes the KDIGO guideline. What does KDIGO guideline say? That apart from the important role of diet, exercise, smoking, and weight, it is metformin and SGLT2 that comes in the hierarchy before RAS inhibitors and statins. That I wanted to emphasize upon you. This is the dosing protocol of various SGLT2 inhibitors, DAPA 10 milligram, EMPA 10 to 25 milligram, and CANA 100 milligram. And the GFR, I told you, EMPA up to 20, CANA up to 30, and DAPA up to 25. This is the recommendation. And if a patient is fasting, undergoing surgery, or is having a critical illness, then these patients, this drug should be discontinued. And there may be a slight reversible decrease of GFR upon starting SGLT2 inhibitors, and this is not an indication to discontinue it. And if you start SGLT2 inhibitor and GFR falls below 20, then there is no point in discontinuing it. It has to be continued. And in renal transplant recipients, this drug should be avoided. Reasons I will discuss later on if time permits. Now, since most of the patients that come to us are in the advanced stage of CKD, so the onus is upon the primary care physicians to start SGLT2 inhibitors well in time. So now this slide already I have discussed. This pie chart actually just discusses the choice of drugs, that if the patient wants to avoid hypoglycemia, then what drug to be used. If you want to cut off the cost, then better you use sulfonylureas and thiazolidinediones. If the patient wants weight loss, then GLP-1 receptor agonist should be used. Now this chart actually shows that GLP-1 receptor agonists, they can be used up to a stage 5 CKD. That has of late come into literature recently. Now coming to one newer drug in CKD, that is imeglimin-based approach for management of DKD. In diabetes, there is actually mitochondriopathies, just as depicted over there. And imeglimin has been shown to correct this mitochondrial dysfunction and decreases GFR, decreases this HbA1c by about 1. The structure of imeglimin and metformin is quite similar. And it has been first used in Japan, with multiple benefits as depicted over here. And this imeglamin has been shown to improve mitochondrial density and function and decreases albuminuria and interstitial fibrosis, thereby helping patients of diabetic kidney disease. The dose is 500 milligram BD if GFR is more than this 15, and below 15, some trials still advocate using it, and it can be very safely used up to a GFR of 15, but I don't say that don't use metformin, start using it, because mara hua hathi bhi sawa lakh ka hi hota hai. It is a famous saying. So metformin is still the drug of choice, not imeglamin. It has cardiovascular benefit also, lesser side effects like reduced lactic acidosis. It improves cardiac, interstitial fibrosis and lesser side effects. Then comes the management of hypertension. Hypertension, we very well know the various ACE inhibitors and ARBs when to use. Now there is no cutoff of creatinine above which ACE inhibitor or ARB can't be used. You will start it, the patient should not be dehydrated, he or she must not be in a potassium-rich diet or using a potassium-retaining drug. After 2 to 4 weeks, measure serum potassium and serum creatinine. If the patient is normocalemic with less than 30% increase in creatinine, you should increase the dose of ACE inhibitor or ARB. If the patient has got hyperkalemia only, then you should review the drug list of the patient and diet of the patient. Start using GI cations, exchangers, and sodium bicarbonate and diuretics. If it is more than 30% rise of serum creatinine, then the various reversible causes of AKI should be thought for. Dehydration and use of NSAID, that should be taken care of, and we should try to rule out bilateral renal artery stenosis in these patients. Now it has been shown that a rise of creatinine up to 30% after starting ACE inhibitor or ARB is going to help the patient, rather than it is not going to deteriorate the condition. But apart, not only this, in all these trials it has been shown that this renal, IDNT, microhope, etc., it has been shown that there is not complete blockade of the RAS system, there is aldosterone breakthrough. So can we block the mineralocorticoid receptors and yet not cause hyperkalemia? The answer is nearly yes, with the usage of finerenone. This is a bulky non-steroidal molecule with a high selectivity. 3 trials were done. One was a Fidelio trial in which the primary outcomes were the renal failure, sustained decrease of GFR, and death from the renal causes. Cardiological outcomes were MACE and MAYER. MACE were the secondary outcomes. Just see the bottom line. The hazard ratio is better with the usage of finerenone, with just marginal increase in the incidence of hyperkalemia. Figaro was just reverse. The primary outcomes were cardiovascular, secondary were renal. MACE was primary, MAYER was secondary, and in this study also it has been shown that finerenone is better as compared to the placebo. The third trial was the Fidelity trial, which incorporated both Fidelio and Figaro trial, and this trial also showed that by using this finerenone in patients with DKD, the risk of hyperkalemia doesn't increase markedly, and in the long term it is going to benefit the patient by decreasing the incidence of ESRD and doubling of. So what should be the dose of finerenone? Depending upon the GFR, if the GFR is more than 60, the dose should be 20 milligram per day. Below 25, don't use it. Between 25 to 60, the dose should be 10 milligram. And after 2 to 4 weeks, you measure potassium, and depending upon the level of potassium, you titrate the dose of finerenone. And all these guidelines, AHA, ACE, ADA, KDIGO, ADA 23, they advocate the uses of finerenone in the management of diabetic kidney disease. AHA, it is 1A recommendation, and in KDIGO, it is 2A recommendation for this. So the takeaway for finerenone is famous 5. In this abdominal distension, we use 5A: fat, fluid, feces, fetus, etc. Here also there is 5-5. Initiate treatment when serum potassium is less than 5. Withhold treatment if serum potassium is more than 5.5. Initiate treatment when eGFR is more than 25. Finerenone reduced the risk of EAD by 1/5, and finerenone reduced the risk of heart failure by more than 1/5. Then comes the other strategies. We all know about aspirin and dual platelet therapy, not going to discuss, and the lifestyle measurements like protein restriction, salt restriction, etc. Proteinuria regression is very important because patients who have got increased proteinuria have got higher grades of loss of GFR. So this should be tackled quite well. So lastly came the consensus guideline between ADA and KDIGO. And this guideline advocates this ACE inhibitor or ARB is recommended in diabetic patients with albuminuria titrated to the highest approved dose, that is 1B recommendation. SGLT2, 1A recommendation up to a GFR of 20. MRAs, 2A recommendation. Then metformin, 1B indication, more than 30 GFR. And GLP-1 receptor agonist, that is 1B recommendation. So I will end by just completing the difference between KDIGO 20 and after 2 years only KDIGO 22 came. Not much of difference. One notable difference was regarding the use of SGLT2. In 2020 it was up to 30 GFR. Now it is up to 20 GFR you can use. And MRAs were not there in 2020 and that has been included in 2022. So summarizing, Finerenone should be used in the management of diabetic kidney disease if the GFR is more than 25. We should use this in our patients. SGLT2 inhibitor should be used in patients with type 2 diabetes, CKD, with eGFR less than 20. And if we are not able to control diabetes of the patient, then GLP-1 receptors may be added. This is about the referral. That's albuminuria more than 300 and eGFR less than 30 should definitely be referred. And thank you for your patient listening.
Thank you, Dr. Hans, for an elaborate and precise description of the management of diabetic CKD. Actually, we have come a long way. From it in the 80s, our annual GFR loss was about 12 to 13 ml per year, and which has come to about 2 to 3 ml per year due to all these drugs you have mentioned. And we all know that GFR loss in normal healthy individuals is 0.7 to 0.9 ml per year. So we have come a long way and hope with these advancements we will achieve even brighter diabetic management with kidney disease in the future. Thank you. No questions are allowed. I will now invite Dr. Mrityunjay Kumar to deliver his topic, case presentation.
Respected Chairperson, sir, at the outset I would like to thank the API CCDSI Bihar chapter for conducting this nice Ccdsicon. And as our society is clinical one, so I have some good clinical cases for you. So let us see the first case. A 21-year-old female patient, she presented with weakness of all 4 limbs that occurred a day prior to her admission. There was no history of trauma, insect or animal bite, loose motion, exposure to insecticides, recent vaccination, fever, headache, blurring of vision, difficulty in swallowing or altered sensorium. On examination, BP was 110/70. On systemic examination, she had hypotonia with grade 1/5 power in all 4 limbs. Superficial reflexes were also absent. Other systemic examination was within normal limit. So see this ECG. There is a clue in this ECG. Can anyone tell what is the what this ECG tells to us? Can anyone predict from this ECG? So this is the ECG which shows that this is a case of hypokalemia. Actually, QT prolongation is there, and there is a U wave. So this is a ECG of hypokalemia. And on investigation, his potassium was 1.5 milliequivalent per liter. Other parameters are normal. And repeated urine analysis showed alkaline urine. So once you are dealing with a case of hypokalemia, then you have to decide 2 or 3 things. First, whether redistribution is occurring or not, because there are several molecules which can cause redistribution of potassium, like insulin, these beta-2 adrenergic salbutamols, alkalemia, hypoperiodic periodic paralysis. In this case, what happened, that your amount of body sodium is normal, but there is a redistribution of potassium from inside the cell, so there will be hypokalemia. And other we have to decide whether there is a renal loss or extra-renal loss. So it can be decided by either history or by doing this 24-hour urine potassium or spot urine potassium creatinine ratio. Beside this, we have to see for acid-base estimation. Come to our case. In our case, fractional excretion of potassium is more than 20. It is 21. So there is an inappropriate loss of potassium occurring through kidneys. So from here, we have done the ABG, and ABG is showing metabolic acidosis. pH is 7.33, bicarb is 17.5, sodium is 140, and chloride is 113. So we can calculate anion gap in this case, and anion gap is 9.5. So it is a case of normal anion gap metabolic acidosis. So from here, if we summarize our case, it is a case of hypokalemic quadriparesis, non-anion gap metabolic acidosis, high fractional excretion of potassium, and alkaline urine, repeated alkaline urine. So from here, what could be the DD? This is the summary with which our patient has presented. Yes, of course, there is a renal cause, and renal is renal tubular acidosis. Once we have established that this is a case of renal tubular acidosis, then there are various types of renal tubular acidosis, mainly type 1, which is distal, and type 2, which is proximal. So how will we differentiate between type 1 and type 2? Because this patient is showing repeated alkaline urine, so it is a case of distal renal tubular acidosis, because distal the H plus excretion is not occurring in the this convoluted tubule, so renal acidification is not occurring. So it is a case of distal renal tubular acidosis. Now, distal renal tubular acidosis can occur due to many things. Drugs can cause autoimmunity, genetic predisposition. There are 3 or 4 headings in which we read distal renal tubular acidosis. So in search of causes, when we have done this ENA, extranuclear antigen examination, then we have found that ANA is strongly positive, and anti-Rho is strongly positive, anti-Li is strongly positive, and others are negative. So on the basis of this is a case of hypokalemic quadriparesis due to distal renal tubular acidosis, and etiology being the primary Sjogren syndrome. So she was managed with oral potassium supplementation, sodium bicarbonate in a dose of 1 to 3 millimole per kilogram per day, prednisolone, HCQ, and azathioprine. With this treatment, she improved to grade 4 power in both upper and lower limbs. So learning point from this case is that Sjogren syndrome should be suspected in any patient presenting with hypokalemic paralysis in the presence of renal tubular acidosis, even in the absence of Zika syndrome. Early recognition of the presence of hypokalemic paralysis due to the underlying this Sjogren syndrome related RTA with institution of prompt therapy not only helps in treating the potentially life-threatening hypokalemia, but also improves the renal outcome. So this is all about the first case. Any comment? Okay, sir. So moving on to the second case, a 28-year-old female presented with complaint of fever for 3 month duration. She also complained of weight loss, loss of appetite, general body weakness. Fever was of low grade associated with night sweats and responded well to antipyretic. She was taking ATT for last 1 month. All the history was negative, so I am skipping this slide. Only thing we have found that she had also painful oral ulcer and bilateral axillary non-tender leaf endopathy. So Sambi is a 28-year-old female with fever and constitutional symptoms for 3 month duration. On examination, she was febrile and pale with bilateral axillary lymphadenopathy and painful oral ulcer, and she was taking ATT for last 1 month. So it was a case of pyrexia of unknown origin, and we all know that pyrexia of unknown origin can be due to infection, can be due to connective tissue disorder, these tumors, these drug fevers, and miscellaneous. So we have to further examine this case. So we have done investigation and found that full blood count has shown normocytic normochromic anemia, leukopenia and thrombocytopenia. ESR is 100, CRP is 20, Montox is negative, HIV negative, thyroid function test normal, and other examinations are normal like chest X-ray, ultrasound. And we have also done lymph node biopsy, and that was suggestive of reactive hyperplasia of lymph node. From here, this is the summary. So how should we proceed in this case now? This is the summary till this stage. So how? Okay, so thank you, sir. So we have done ANA, which is a strongly positive, and that is of a speckled pattern, and serum C3 is low. So we have again done ENA, and that was showing that has anti-histone, anti-R1 and RNP is positive, anti-SSA was positive, anti-SM was positive. So various immune system, various antibodies are positive. So this is a case of actually SLE, and if you will go by this EULAR criteria, then it will fit into the SLE. So we will discuss something about lymphadenopathy in SLE, which is only found in 5 to 7% of cases, and besides the disease, it can occur due to other causes, like it may be associated with infection, tuberculosis, immunological or malignant disorder. And the increased risk of lymphoproliferative disorder in SLE was well reported. Since there is a considerable overlap between the features of SLE and lymphoma, there can be a difficulty in diagnosing lymphoma in these patients. Now, can it be drug-induced lupus erythematosus? So there are various heading by which we can differentiate it from drug-induced lupus, because in our patient is old, our patient is younger, our patient has low C3 and ANA pattern is speckled, so it can't be drug-induced lupus because he was on ATT, and ATT drug are found to be causing this drug-induced lupus. So what should be the treatment? As far as treatment is concerned, in milder form, HCQ plus oral glucocorticoid is sufficient. In refractory cases, we can add methotrexate or azathioprine. In severe cases, HCQ plus IV glucocorticoids plus this MMF and cyclophosphamide is used. And there are newer 2 molecules like belimumab or this volcosporin, which can be used in moderate to severe cases, especially in stage 4 and stage 5 SLE nephritis cases. So my patient has been treated with HCQ, prednisolone with calcium supplementation. Later on, prednisolone was tapered off and she was on maintenance dose of 5 mg daily when last seen. So learning point from this case is that SLE needs to be suspected when analyzing a cause for PO coming with a compatible clinical picture. After establishing the diagnosis, prompt management should follow. In the follow-up process, early detection of organ involvement is crucial, as the management protocol differs accordingly, and so will the prognosis. So as Dr. Sumit has told me that I have to finish within 10 minutes, so I am stopping here. I have 2 or 3 cases more, but I am stopping here. Thank you very much.
Still we have 2 minute time. Any comment from the audience or chairpersons?
Thank you, Dr. Mrityunjay, for presenting 2 excellent cases. And we are sorry that due to paucity of time, we are not able to discuss the cases in length. Now it is time to invite none other than Dr. Harshvardhan from Patna. He is presently working in Patna Medical College and Hospital and heading the Department of Nephrology in Big Apollo Hospital, Patna. He is pioneer in starting kidney transplantation in IGIMS, and he has also started kidney transplantation in Big Apollo Hospital. I have privilege to work with him for 4 or 5 years in IGIMS. So with this short introduction, I invite Dr. Harshvardhan to deliberate on a very important topic of contrast-induced nephropathy. Because today's in the era of Consumer Forum Act, it is very important to avoid iatrogenic nephrotoxicity by the use of contrast. So Dr. Harsh, please deliberate on this topic.
A very good afternoon to you all, and at the outset I would like to thank the organizer for giving me this opportunity, and Professor Om Kumar sir, as usual you have been very kind in introducing me all through my career. So the topic which has been given to me is contrast-induced nephropathy, what a physician needs to know. So in next 15 minutes I'll try to rush as fast as possible. So I begin with a case. It's a 76-year-old male who was diabetic for 20 years and hypertensive for 15 years. He had underwent coronary angiography for some indication. He was referred on day 7 to us with nausea and vomiting for 3 days, decreased urine output. On examination, he was hypertensive, had pedal edema, and his creatinine shot up from a baseline of 3.3 to 8.3. So we suspected something which was happening there, acute on chronic kidney disease. The patient received multiple sessions of hemodialysis, and he remained dialysis even after 1 month. So in view of non-recovery of renal function, we did a kidney biopsy, which was suggestive of acute tubulointerstitial nephritis. The case 2 is a very common scenario which we nephrologists encounter in day-to-day practice. He was a 62-year-old male, diabetic for 10 years and hypertensive. He was referred to nephrology OPD for clearance for coronary angiography. His creatinine was 1.7. So what is the risk of contrast-induced nephropathy? So definition of contrast-induced nephropathy is, it is a rise in serum creatinine which is more than 0.3 milligram per deciliter, or 0.5 milligram or 25% increase from baseline value, which is assessed at 48 hours after a radiological procedure without an alternative etiology. It was first reported in a case of multiple myeloma who underwent intravenous pyrogram. It was first reported in 1954. It remains the third most important cause of hospital-acquired renal failure. It occurs in around 1.5% of patients without diabetes or CKD, and around 50% of the patients with both diabetes and CKD. But there is a wide variation in epidemiology because of definition, the settings which is being used to define, route of administration, underlying kidney disease, and the level of sickness. And as we all know, that renal failure has a great impact on mortality. The type of contrast agent which is routinely available these days are, high osmolar, low osmolar, or isoosmolar, and basically they differentiate on the basis of benzene ring which they are possessing. And the advantages of non-ionic contrast is less cardiac toxicity, less depression of ventricular contractility, fewer hypersensitive reaction, less disruption effect on endothelium. The pathophysiology has been, contrast enters the renal vasculature, leads to sustained intrarenal vasoconstriction, renal ischemia, and acute kidney injury. The risk factors can be divided into patient-related and the procedure-related. Patient-related, you are having non-modifiable risk factors in which age is most important. Pre-existing chronic kidney disease. Modifiable is anemia, intravascular volume depletion, concomitant use of nephrotoxic drugs. The procedure-related is that PCI performed in acute setting, emergent intervention. Modifiable are high contrast volume, high osmolar versus ionic contrast. So what one should do? The KDIGO in 2012 recommends that we should assess the risk of contrast-induced AKI and in particular screen for pre-existing impairment of kidney function in all patients who are considered for a procedure that requires IV contrast administration. So there have been some, scoring systems. The famous one was Mehran, which was introduced way back in 2004, which had certain criterias, and the risk was calculated on that. That was presence of hypertension, use of IABP, NYHA class 3 or 4, age, anemia, diabetes, contrast media volume. And on the basis of that, you could predict the risk. Then there were some online calculators. This was the calculator which is being which is all there on your mobile, which you can use. the approach software, which is quite commonly used in Canada. There have been many preventive strategies which have been used. I would just discuss the main things. The use of, the contrast. So the contrast related issues. One should be using as minimum contrast as possible and avoid procedures which requires a very high volume of contrast. And use staged procedures if possible. And recommendation is either we should be using iso-osmolar or low osmolar iodinated contrast media rather than the high osmolar iodinated contrast media in patients at increased risk of contrast-induced AKI. And there is some suggestion that, you should try to use minimal contrast and use newer technologies to locate the lesion so that you can do intervention. So this was a study in which IVUS was used with very minimal risk of, in fact, there was no reported kidney injury in this study. Hydration as a prophylaxis, we all know, which I'll discuss in later slides. So IV volume expansion is the recommendation right now. So there have been various trials which have proposed that the IV hydration remain the most important and significant strategy in prevention of contrast-associated acute kidney injury, especially those who are having eGFR of less than 30, and prophylaxis may be considered at the discretion of clinicians having GFR which is more than 30. But there is no clear evidence to guide the optimal rate and duration of fluid infusion, but some suggest that it should be begun at least 1 hour before and 3 to 12 hours after with doses which is as fixed as 500 ml or 1 to 3 ml per kg per hour. Then comes N-acetylcysteine. The recommendation is 2D, that is using NAC, which was way back in 2012. Now more data has come, and this was the PRESERVE trial which was published in 2018, which suggested that IV saline infusion with as compared with IV saline with bicarbonate or N-acetylcysteine was non-inferior. So IV saline remains the method of choice for prevention. And sodium bicarbonate, it had poorly defined mechanism. It may decrease the generation of free radicals and may also scavenge potent oxidants like peroxynitrates and other molecules. Then combination strategies, the biggest benefit which the literature suggested was with IV saline infusion and sodium bicarbonate with an N-acetylcysteine. Now again the important topic is discontinuation of drugs. What you should discontinue? Well, there is some recommendation that those with eGFR less than 30, one should avoid using high dose diuretics, ACE inhibitors, ARBs at least 24 hours to 48 hours after the procedures. Definitely one should avoid NSAIDs and other nephrotoxic drugs. Role of hemofiltration and hemodialysis. Well, hemodialysis removes more than 80% of the contrast material from plasma within 4 to 5 hours, but does not prevent contrast nephropathy. Hemofiltration provides hemodynamic stability as compared to hemodialysis and permits 10 to 15 times the usual hydration without adding intravascular volume. But this is the commonest problem which we normally face. Whenever our radiologist colleague, we insist on doing a contrast procedure, they say that we should, first you write that you are going to do dialysis after giving contrast. So the current recommendation is not using prophylactic intermittent dialysis for contrast removal in patients with increased risk of CKI. Now the whole point of delivering this talk is that I am going to present a nihilistic view. The view which was there, through the ages that, there is something which is called contrast induced. So actually, the debate started that does contrast induced nephropathy, does it really exist? So we moved from contrast induced AKI to contrast associated AKI. So there are a lot of clinical settings, that is contrast associated AKI, that is any AKI which is occurring 48 hours after administration of contrast media. And there were some trials which were there which suggested that really we need to think about it. This was a trial in which around 32,000 patients who were hospitalized and their creatinine was followed. Even if they were not giving any contrast, there was some rise in creatinine even during their admission because of various reasons. So why was contrast implicated? That was a question. Then this was also a trial which suggested that risk of AKI without contrast is 5.6 and with contrast is 5.1. So risk of contrast associated nephropathy may be overstated in literature and overestimated by clinicians. So more accurate AKI risk estimates may improve clinical decision making, and this led to a concept which is called renalism. Renalism was when we were so particular of not giving contrast that a lot of patients were bereft of, the contrast procedures which were there to save his life. So there are a lot of evidence, so I'll have to rush fast. And this was a recent paper. Now, a lot of times your cardiologist colleague, they ask you, said that we are having a history of AKI. Can we use contrast or not? So this was a paper which suggested that among patients with pre-existing AKI, contrast administration was not associated with either persistent AKI at hospital discharge or initiation of dialysis within 180 days. So current consensus recommendation for use of IV contrast in patients with stable renal disease may also be applied to patients with pre-existing disease. Even, in emergency settings also, when we were supposed to do, contrast pulmonary angiography and other procedures, there was no evidence for harmful effect of kidney function on IV contrast administered for CTPA or emergency setting. Now debates versus intravenous versus intra-arterial. There was some paper which suggested no difference. Some suggested that it was more with intra-arterial. So this was a latest recommendation in 2020 which suggested that you divide patients on the basis of GFR who are going to go for a contrast procedure. If GFR is less than 30, prophylaxis is indicated. If it is more than 30, ideally no prophylaxis is indicated. In patients who are in the GFR range of 30 to 44, prophylaxis may be considered on the discretion of clinicians. And what is the prophylaxis? IV saline. Depending on the volume status of the patient. One should be less aggressive if you have evidence of heart failure and all. Now, I would like to end my talk with a thought to ponder for my cardiologist colleague. That even in those with eGFR less than 30, why to go for invasive procedures when current evidence suggests that invasive treatment did not reduce the rate of death or non-fatal MI or improve angina-related health issues in patients with advanced renal failure. But then that discretion is there. So in emergency setting, the overall approach is if you see a critically ill patient who needs a contrast imaging, what is the GFR? Actually forget it. In emergency setting, we don't really care. Go for contrast if it is good for the patient. So my take-home message is CI remains an important clinical issue, even those overstated. A team approach is of utmost importance. In high-risk, alternative, non-iodinated contrast studies should be considered. High-risk patients, when contrast imaging study is deemed absolutely necessary, render renal prophylaxis. More adequate power studies are required. Don't stop if a life-saving procedure is there. Thank you.
Thank you, Dr. Harsh, for excellently explaining how to prevent and minimize the contrast-induced nephrotoxicity. Thank you very much. Because due to a scarcity of time, we are not taking questions. Now, for the last session, I invite Dr. Megha Saigal. She has done her DM nephrology from prestigious Nizam Institute of Medical Sciences, Hyderabad, and now she has joined as assistant professor and in charge of the Department of Nephrology at AIIMS Patna. Now she is having a new department and she has got responsibility to do so many wonders in the Department of Nephrology at AIIMS Patna. I have come to know that she is going to start DM course and she has planning to start transplantation at AIIMS Patna. Dr. Megha Saigal, and she will be dealing with the emerging treatment of cardiorenal syndrome.
Thank you, sir. Thank you, Dr. Om, for those kind words. And I want to thank the organizers of Ccdsicon for inviting me to this prestigious conference and letting me explore this wonderful city of Bugusarai. So I will be starting with my topic. My topic for the day is emerging therapies for the management of cardiorenal syndrome. So why should we talk about this? We should talk about this because CKD, as you know, is increasing daily. As we are progressing more and more in our treatment for cancer and for other cardiovascular diseases, and our population is aging, so CKD is increasing. And as you can see, this is the chart from ISN, and even though this is 2022 ISN, but however, it is showing the data of 2017, and in 2017 itself there were 850 million people across the world who were suffering from CKD. And as we progress, in 2040 there will be CKD causing death will be the 5th largest reason for mortality in the world. Now why is this important? Because as you can see, as the CKD stage increases, the chance of developing cardiovascular disease increases. That can be both, and the person will be prone to both atherosclerotic cardiovascular event as well as more prone to non-atherosclerotic cardiovascular events in the form of left ventricular hypertrophy, arrhythmias, and sudden cardiac death. And as the different stages of CKD increases, as you can see, when stage 1 and 2 compared to stage 4 to 5, the all-causes heart failure, which is both systolic and diastolic, increases in these patients. Now coming to how does CKD lead to, what does CKD cause? So everyone with CKD is afraid that they will undergo dialysis. However, you should know that the 5-year probability of having a death because of cardiovascular disease in a CKD stage 4 and 5 is 33% compared to only going for dialysis is 12% in these population. So there is more chance that the population of CKD 4 and 5 will have a cardiovascular event or a cardiovascular mortality as compared to reaching end-stage kidney disease and undergoing dialysis. Now what about heart leading to kidney problems? As you know, as a patient with heart failure, he will have a rapid eGFR decline as compared to a patient who is not having heart failure with concomitant CKD, with a decline of 22% compared to 9 ml per year. And a patient with incident CKD and heart failure will have a higher mortality. That is why this topic of cardiorenal syndrome is so important for us. So the first person to describe cardiorenal syndrome was not Professor Arthur Guyton, but actually it was Robert Bright, who first described this syndrome in 1836 when he was describing the Bright's disease or the albuminuria. He found out that the patients who were having increased albumin in urine, on autopsy they were having an increased heart muscle as well, which was like a hypertrophic cardiac muscle. But this was described, cardiorenal syndrome was described in detail by Professor Arthur Guyton, who talked about the cardiac output, the role of kidneys, hypertension, and the crosstalk between the heart and the kidneys. So what is the exact definition of cardiorenal syndrome? It is a disorder of in which the heart or kidney, disorder of the heart and kidney, whereby the acute or chronic dysfunction in one organ can cause acute or chronic dysfunction of the other. So the organ that is involved first is known as primer movens, and based on that we have divided the cardiorenal syndrome into the 5 classifications. These 5 classifications were given by Edo Key, and especially by Professor Ronco had given a lot of work in these classifications, and they have divided the classification into 5 types. Type 1 and 2 are the ones in which the primer movement or the first organ to be affected is the heart, and that leads to kidney failure, that is acute cardiorenal or chronic cardiorenal. Type 3 and 4 are primer movement being the kidney, that is acute renocardiac and chronic renocardiac syndrome leading to heart involvement. And type 5 is when there is a systemic involvement which is leading to both heart and kidney dysfunction, for example being sepsis, amyloidosis, or say diabetes. The only thing that you need to know that these are not compartmentalized. These classifications are not compartmentalized. A patient can have at one moment of time either one or both or maybe several of these. For example, a patient who is having currently chronic cardiorenal can, that is chronic congestive cardiac failure leading to AKI. If this AKI is not resolved, he can go into type 4, that is he can have AKI with CKD and he can have a chronic renocardiac syndrome. Or a patient with chronic renocardiac syndrome can be diabetic and therefore can have type 4 and 5 together. So we need to know that this is not a compartmentalized classification. Now I was told that due to a paucity of time I should not dwell much into the pathophysiology, but we need to know a little bit about pathophysiology so that we can start the treatment for the patient. The three important mechanisms which play a very important role in the pathophysiology of cardiorenal syndrome are hemodynamic mechanisms, neurohormonal mechanisms, and inflammatory mechanisms. So hemodynamic mechanisms, we all know about left heart failure, and we all know that left heart failure causes a forward failure in which there is a decreased ejection fraction, which leads to decreased cardiovascular flow in the kidney, and therefore you can have a kidney failure. But we also need to know that sometimes the right-sided failure can also lead to congestion, which can lead to a renal hypertension, and this renal congestion or a renovascular hypertension is supposed to be causing more damage to the kidney, and this is what is the condition that we see in heart failure with preserved ejection fraction, where the right-sided is affected more than the left side. Other things are, as you know, because when there is decreased renal perfusion, it can lead to RAS activation, and it can also cause the activation of sympathetic nervous systems. So this is how the heart is affecting the kidney. Kidney, however, on the other hand, if the patient is having CKD, as you know, CKD is an inflammatory stage, it can lead to chronic inflammation, malnutrition, FGF23 can be released, and that itself can cause more calcification and lead to heart failure. So who are the patients at risk for cardiorenal syndrome? Patients at risk are those who have a pre-existing CKD, who have a pre-existing heart failure, who are diabetic, who are aged, and who have anemia. So we have a lot of organizations, the heart organizations, the kidney organizations, who have given us suggestions, but there are no proper guidelines on how to manage the cardiorenal syndrome. So before starting the actual drug treatment, this is something that you should follow in all the patients. That is, first thing, these are the non-drug related therapeutic managements, that is smoking cessation. That should be called for all the patients. Blood pressure control. According to the SPRINT trial now, the blood pressure should be less than 120/80, but in our CKD patients, we will still give it a little more higher margin of at least controlling the blood pressure to 130/80. Lipid management should be there according to the atherosclerotic cardiovascular disease score of less than 10%. If it's more than 10%, start statins. Then weight management, tell the patient to reduce weight. And one more important thing that we don't manage mostly in our patients is vaccination. So these patients are very prone to get LRTIs, so it will be advised that these patients should have a regular influenza vaccine, yearly vaccinated. So this was the treatment protocol that was followed earlier. That was actually a stepwise protocol. That is, you start with loop diuretics, add beta blockers, add ACE inhibitors, then give them to the highest dose. Then if not responding, give MRAs, and still if the heart rate is higher, give ivabradine. And if the patient is symptomatic, you can give either implantable cardiovascular defibrillator, or you can give CRT, or in the end heart transplant. However, now according to the 2019 papers, you don't need to go for a stepwise approach. You can start all the things immediately, and then follow up the patient and increase the dose gradually. So these are the treatment strategies for cardiorenal syndrome, starting with decongestive therapies in the form of diuresis and ultrafiltration, neurohormonal modulation and vasodilator inotropic therapy in the form of nesiritide, tolvaptan, and dopamine, RAS inhibitors in the form of ACERBs, ARNIs, MRAs, and beta blockers, and the cardiorenal syndrome and type 2 diabetes, which will be SGLT2 inhibitors. So starting with the diuretics, there was a very important trial called the DOSE trial, which wanted to see how much diuretics should be given and whether they should be given in a continuous dose or a bolus dose. So they divided the patients into 2/2 factorial, in which they give one set of patients normal dose of diuretics that they were on initially, and the other set of patients got a high dose diuretics, that is 2 times the normal dose, oral dose, and one set was given a bolus infusion and one set was given a by 12-hourly bolus dose. One set was given a continuous infusion and the other set was given a bolus dose, and they found that actually even though the patients who were given high dose diuretics and a bolus dose symptomatically felt better, but there was at the end no difference in the primary endpoints. So there were other data, other analysis that also showed that if you give a stepwise goal-directed diuretic algorithm and try to decrease the weight by around 2 to 3 kgs with a urine output of 3 to 4 liters by giving stepped diuretic management, it is ultimately helping the patient. And high-dose intermittent furosemide is therefore safe and effective, and that is what you should be given. Continuous infusion does not provide any further advantage. So after this, they tried to see, instead of diuresis, if we can give ultrafiltration. So there were many studies, and one of the important studies was unload study, which actually showed that ultrafiltration has some benefit in preventing the rehospitalization of the patients. However, there was a lot of criticisms regarding this study because firstly, they did not give the higher dose of diuretics, and secondly, it was actually sponsored by the company which was there for the ultrafiltration. The other studies, especially the CARIS-HF study that has been done, provides a strong argument against the use of ultrafiltration as a primary treatment for any type of CRS. And ultrafiltration is given only if the patient is not responding to the highest lows of diuretic that you are given or is gone into oliguric AKI, then you can start ultrafiltration. Now coming to neurohormonal modulation in the form of tolvaptan and nesiritide. So in tolvaptan, a lot of studies have been done. However, they have not shown to be much benefit, though Japanese cardiologists and nephrologists do use tolvaptan, especially in patients who do not show response to diuresis. Other thing is that nesiritide and dopamine has also been tried on these patients, but however, at the end point, they have not shown any significant improvement. Now coming to something that we know that does show improvement, that is ACE and ARBs. So as you know, a lot of studies have been done for the use of ACE in ARBs in cardiorenal syndrome, including the important and famous consensus study and the SALT study, and both have shown that ACE and ARBs, even though they may increase the creatinine to a certain level at the beginning when you start the diuresis and you start ACE-ARBs, but at the end, if you continue with ACE-ARBs, the patient does have a mortality benefit. So, especially this is regarding ARBs also. ARBs have shown that with patients with reduced heart ejection fraction of less than 45%, EGFR less than 60%, if you continue ARBs, they have a significant reduction in all-cause mortality. So, should we stop ACE-ARBs at some creatinine level? No. There's been a trial called the Stop ACE Inhibitor trial, in which they either continued the RAS inhibitor up to stage 4, after stage 4 and 5 also, or they discontinued RAS inhibitors when the people reached stage 4 and 5 CKD. They found that there was no difference in the increase of EGFR, fall in EGFR, but however, there was a better outcome in people who continued ACE-ARBs, and there was decreased MACE events in these people. So these are some of the studies regarding ARBs. This is the same as I told earlier. In patients with heart failure with reduced ejection fraction, you should continue ACE-ARBs unless there are some very strong indicators like the patient is having uremia or the patient is hypotensive or in shock, then only you should stop. For hyperkalemia, you should manage the causes of hyperkalemia, see for any other cause, try to prevent hyperkalemia before starting ACE-ARBs. Now coming to ARNIs. ARNIs are very famous among the cardiologists. However, nephrologists have not used ARNIs so much. But there have been trials, especially the Paradigm HF trial, which has compared ARNI with the ACE inhibitors, and they have shown that ARNIs have a much better response. They have lesser EGFR, however the albuminuria decreases. Nowadays the latest guidelines are that ARNIs should be used in patients who are not tolerating ACE-ARBs for some reason or the other. After ARNIs, the next drug to be used is the mineralocorticoid receptor antagonist, out of which now we have mineraloreceptor antagonists in the form of eplerenone, and now the newer ones, which is the non-steroidal one, that is finerenone, and that has also shown to be of much benefit, especially to prevent the aldosterone escape effect when we give diuretics for a long time. Beta blockers. If someone has to ask what is the greatest study or greatest drug that has been used in cardiorenal syndrome in the last 60 years, that is the beta blockers. Beta blockers themselves have managed to reduce mortality by about 40 to 50% in patients with cardiorenal syndrome. The beta blockers that have specifically been used in these are metoprolol, bisoprolol and carvedilol. So there have been many trials, the most famous being the MERIT-HF trial, which has shown that you can use beta blockers up to class 4 of heart failure with ejection fraction less than 40% and with EGFR even less than 45 ml per minute. Last but not the least, SGLT2 inhibitors. We have been talking about it since the starting of this program, so I will not be going into much detail. Just that SGLT2 inhibitors have shown a very good cardioprotective as well as renal protective effect. renal protective mechanism in both our patients, patients with cardiorenal syndrome, and you know the mechanism in which they act against both the kidney, to prevent both kidney as well as heart damage. So these are the trials, and all the trials have shown very positive effect. So coming to my last slide, this is the ACC-AHA guidelines, and as you know, SGLT2 inhibitors are now the first line along with metformin for any diabetic patients. And these are the latest evidence-based evidence-based trials against for cardiorenal syndrome. As you can see, ACERBs, ARNI, MRAs and beta blockers have strong evidence up to stage 3. Stage 4 and 5 also, we don't have actually much trials, but beta blockers can be used up to stage 4, and now we know that ACERBs can also be continued up to stage 4 and 5 CKD. Other than that, digoxin and isoniazide dinitrate do not show much improvement, and CRT and ICDs are based on the cardiologist, and it has been said that if left ventricular ejection fraction is less than 35%, they are recommended. The things that I have not talked about are peritoneal dialysis, though we know that peritoneal dialysis can also help in patients with cardiorenal syndrome, but there have not been much studies regarding that. Another thing that is now in vogue is acetazolamide. That has also been told that it helps in cardiorenal syndrome, but the studies that have come have not been very promising, and we have to wait for future to see whether it helps or not. So thank you so much.
Thank you, Dr. Megha, for finishing almost in time this vast topic. And I would like to congratulate Megha, Harsh, Hans, all similar here words of rainy season, and Mrityunjay, the god who likes the rainy season. So I will like to do all the ritualities of giving the honor to all our speakers.
Thank you so much, sir. Thank you so much, Meena.
Now we come to the end of this session. Thank you to every speakers.
I request all of you to kindly remain on the seat as I wish to have a very small and brief felicitation ceremony. And without any further delay, I would now like to request Dr. O. Kumar, sir, who is the honorable chairperson for this particular session, to kindly come forward and honor our speaker, Dr. Pankaj, sir. Dr. Padmakar Kumar Singh, sir, to kindly come forward and honor Dr.
So, good afternoon. This is session particularly designed by the organizers for PG students. This is first time we are holding this type of meeting. The first speaker for this session is Dr. Rashmi Singh from Indira Gandhi Institute of Medical Science, Patna. She is PG in the Department of General Medicine. Dr. Rashmi Singh, you have 10 minutes. 7 minutes. Okay. You have to finish it in 7 minutes. The topic is diabetic patient with acute coronary syndrome.
Good afternoon, honorable chairpersons, respected doctors. I am Dr. Rashmi Singh, junior resident of the Department of General Medicine, IGIMS. Today I am presenting a case of diabetic patient with acute coronary syndrome. 66 years old gentleman, resident of East Champaran district, farmer by occupation. He was a known case of systemic hypertension for 5 years, diabetes mellitus type 2 for 2 years, presented to the emergency department of IGIMS on 28th April 2023. The chief complaints were following: chest pain for 4 months with shortness of breath for 1 day. The history of presenting illness: chest pain for 4 months was intermittent in episodes, retrosternal in location, each episode lasting for 10 to 20 minutes, mild in intensity, aggravated by exertion, relieved with rest, and it persisted till 1 day before presentation. On the day of presentation, he had an acute onset of pain, which was severe retrosternal chest pain, radiating to both the shoulders with sense of chest tightness and associated with profuse sweating. Dyspnea was present for 1 day, which was acute in onset, progressive, increasing with exertion, associated with orthopnea. There was no history of cough, expectoration, fever, syncope. Past history: known case of hypertension for last 5 years, taking telmisartan 40 mg plus chlorthalidone 6.25 mg OD. Known case of type 2 diabetes mellitus for 5 years, taking metformin 850 mg plus glimepiride 2 grams BD. There was no history of tuberculosis, asthma, COPD, rheumatic fever. Patient had a cataract surgery in right eye 5 months back. Family history: mother is a known case of type 2 diabetes mellitus. No known history of cardiac illness in family members. Personal history: no history of smoking, alcohol or IV drug abuse, vegetarian diet consumer, normal bladder and bowel history. Socioeconomic history: lower middle class according to the modified Kuppuswamy scale. Summary: so here it is a 66-year-old gentleman who was a known diabetic and hypertensive, presenting with a history of anginal chest pain for 4 months with acute onset severe retrosternal chest pain of 1 day duration with acute onset dyspnea associated with orthopnea. So my provisional diagnosis was coronary disease with acute coronary syndrome, left-sided heart failure, complicated in left-sided heart failure, NYHA class 4. On general examination, he was conscious oriented to time, place and person. The height was 181 centimeter, weight 61 kgs and the BMI was 18.6 kg per meter square. The pulse rate was 80 per minute, regular in but low in volume. All peripheral pulses felt, no radial delay or radiofemoral delay, no vessel wall thickening. The BP was 92 by 60 mm Hg. Respiratory rate was 36 per minute, abdominothoracic type. Temperature was afebrile and the SpO2 was 88% on room air. JVP was 8 cm from angle of Lewis. Pallor, icterus, cyanosis, clubbing, lymphadenopathy all negative. Pitting, pedal edema present in both lower limbs. On systemic examination, on inspection, the precordium is normal. Apical impulse, 5th intercostal space can be seen in the mid-clavicular line. No visible pulsation, no dilated veins or scars. On palpation, trachea position was confirmed. Apical impulse, left 5th intercostal space on mid-clavicular line was normal in character. No palpable thrills, heave, no palpable pulsation. On auscultation, S1 was normal, S2 was also normal with normal split. S3 could be heard in the mitral area with the bell of the stethoscope. There was no audible S4, no murmurs heard. On respiratory system examination, inspiratory fine creps were present in the bilateral infrascapular and infraaxillary regions. Abdominal system, soft and non-tender. No organomegaly in the CNS system. He was conscious oriented. So the ECG we can see there's QS complex in V1 to V3, ST depression and T wave inversion present in the lead 2, 3 and AVF. The echo showed RWMA in the LED territory, no mitral regurgitation, no tricuspid regurgitation, and LV ejection fraction was 35%. These are the investigation. The HS tropi was 3,747, while the serum BNP was 1,393. The patient has HbA1c 9.4%. The chest radiograph shows the signs of pulmonary edema. So the diagnosis was a coronary artery disease, acute coronary syndrome, anteroseptal MI, which had a delayed presentation, complicating into acute left ventricle failure, NYHA class 4, CLIP class 2, and normal sinus rhythm. Risk factors were age, systemic hypertension, and type 2 diabetes mellitus. On the day of admission, the patient was managed with moist O2 inhalation to keep the target SpO2 above 92%. Tablet clopidogrel 300 mg stat with 75 mg per oral was given. Tablet aspirin 300 mg stat and 75 mg per oral was given. Tablet atorvastatin 80 mg statin 40 mg ODHS, while injection low molecular weight heparin 60 mg subcutaneously BD was given. Tablet nicorandil 5 mg per oral BD along with injection furosemide 40 mg IV stat followed by 20 mg IV BD was given. Injection regular insulin subcutaneously 644 units was given and injection pantoprazole 40 mg IV OD was added. On day 2, coronary angiography was and PCI was planned. Patient was loaded with 2 tablets of ticagrelor, 90 mg stat and then BD, and Orsido 30 into 45 mm stent was placed in LAD and Orsido 15 into 25 mm stent was placed in right coronary artery. This is the coronary angiography report of the patient. On day 3, the patient was stabilized and need for the oxygen support decreased. The patient BP, pulse rate, they were all in normal range. Day 4, the most IV medications were changed into oral form, and on day 5, the patient was discharged with the following advices. Tablet ticagrelor 90 mg per oral BD, Ecosprin tablet 75 mg per oral OD, tablet torsemide and spironolactone, the combination of 10/50, half tablet OD to be taken in the morning. Tablet atorvastatin 40 mg per oral to be taken at the night, metformin 850 mg with tablet glimepiride 2 gram before breakfast, tablet dapagliflozin was added 10 mg OD, ramipril 2.5 mg OD, tablet metoprolol succinate was started from 12.5 mg OD and tablet nitroglycerin 2.6 mg BD. Along with that, tablet Pantop 40 mg was given. Review in cardiology OPD was advised. So the summary is that diabetes mellitus increases 2-fold risk in males and 4-fold risk in females for heart failure. Hyperglycemia, insulin resistant and hyperinsulinemia, all these three play the central role in pathogenesis of heart failure in a diabetic patient.
Dr. Rashmi, please conclude.
Okay, sir. And so heart failure, and the interesting thing is that even heart failure is also a risk factor for diabetes mellitus. So lifestyle management and SGLT2 inhibitors have been a preferred glucose lowering agent in all patients of heart failure. And the target HbA1c should be less than 7%. That's all. Thank you, everyone.
Why did you suspect it to be a case of acute coronary syndrome? There may be other causes, acute chest pain with sudden onset dyspnea. What are the other causes of paroxysmal dyspnea?
So other causes of, so the patient can present with aortic dissection if paroxysmal, so can you repeat?
Paroxysmal dyspnea, acute onset dyspnea.
Yes, sir. So pulmonary embolism can be a cause of paroxysmal.
Just wait. How do you differentiate between massive pulmonary embolism and acute? In both the cases, the patient will present with paroxysmal dyspnea, means acute onset dyspnea.
Yes, sir.
Or sudden onset dyspnea with acute chest pain. Your stetho will help. Thank you.
One more question. You have told that apex beat was in the 5th intercostal space and the patient was having ACS. So I don't think it can be localized. Ideally, it should have been diffuse apex. BP was also low, so it can't be localized in that case.
Yes, sir.
And why did you use OHAs in ACS? You should have used insulin.
Sir, I have used insulin in the when the patient was admitted, but when we discharged the patient, then we gave him insulin.
Okay.
Why you have not thrombolized him? Simple. Why you have not thrombolized? Simple.
So because we are a PCI equipped center, so when the patient arrived, we and the patient arrived after 12 hours. So so the patient has arrived after 12 hours. The time has passed, so therefore we preferred PCI over.
Okay, thank you, Rashmi.
Thank you, sir.
The next speaker is Dr. Anjali Kumari. She is also from Indira Gandhi Institute of Medical Science, and she is junior resident in the Department of Medicine. The topic is a case of 75-year-old diabetic man with acute decompensated heart failure.
Good afternoon, Honorable Chairperson and the respected doctors present here. I am Dr. Anjali Kumari, PG Second Year, Department of General Medicine. I am here to present a case of 75-year-old diabetic man with acute decompensated heart failure. Heart failure. What is heart failure? According to American College of Cardiology Foundation, American Heart Association and Heart Failure Society of America, guideline defines heart failure as a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection fraction of blood, leading to cardinal manifestation of dyspnea, fatigue, and fluid retention. Heart failure, why it is a concern? Okay, sir. A patient named Chandeshwar Singh, 75-year-old male, resident of Sitamarhi, unemployed, informant patient himself, presenting complaint, difficulty in breathing since 1 year, bilateral lower limb swelling on and off since 6 months. History of presenting complaint. Patient was apparently normal till 1 year back when he started developing breathlessness on exertion. It occurred on climbing 2 flights of stair, which he was able to climb previously without any difficulty, class NYHA2 symptoms. It was relieved by rest and progressed over past 1 year, such that he now has breathlessness on exertion even on walking on level ground for few minutes, class 3 NYHA symptoms. History of worsening of dyspnea on lying down, that is orthopnea, and history of symptoms suggestive of PND, and all symptoms got aggravated since 2 to 3 days. No history of breathlessness at rest, no history of associated wheezing, no history of fever, cough, and hemoptysis. Patient past medical histories were type 2 diabetes mellitus on OHA with visual complications and chronic kidney disease, and a known case of hypothyroidism and was on Thyrox 25, was admitted 3 months ago on October 22. He had dyspnea on exertion, NYHA3, orthopnea was present at that time also, a diagnosis of CAD with severe LV dysfunction with reduced ejection fraction of 25%. He had hypertension since approximately 5 years ago. However, the patient doesn't take medication regularly. When the patient headache, he only took the medicines he bought himself at the shop and rested. Patient has also had diabetes since approximately 6 years ago. The patient routinely took a blood sugar lowering drug taken every morning after breakfast, but he didn't remember. Patient family history include hypertension and type 2 diabetes mellitus in his mother. His father had a heart disease. The patient was a previous smoker for 15 years and a chronic alcoholic and has stopped smoking since 20 years ago. During physical examination, patient had dyspnea, was hydrated, didn't have fever, got good peripheral perfusion, blood pressure was 100/70 and a pulse rate of 90 per minute, and 92% oxygen saturation. There was jugular turbulence, chest was bilateral symmetrical, vesicular breath sound was present, presence of crackles was present in both the lung bases, normophonetic, rhythmic sounds in 2 stages without murmur. There was no hepatomegaly, patient abdomen was flaccid, painless, and a bowel sound was present. The lower limb presented +2 pedal edema or +4 edema. The calves were free and there were symmetrical pedal pulses. Laboratory parameters include hemoglobin of 9.3, total count was 8,2100, platelet count was 3,30,000, was 29.2, creat was 4.3, HbA1c was 6.7, and BNP was 2707 with tropi 38.7. Electrolyte, sodium was 134, potassium was 4, chloride was 90. ECG revealed a sinus rhythm, low voltage of QRS complex in frontal pain and ST segment depression 1 mm horizontal from V2 to V5 and a reduction of left ventricular potential. Echocardiography was suggestive of CAD with ejection fraction 35% and a chest radiograph showed cardiomegaly, bilateral minimal effusion with prominent vascular markings. These are the ECG and chest X-ray showing cardiomegaly with pulmonary congestion. During hospitalization, the patient had dyspnea and signs of pulmonary and systemic congestion. The patient was given infusion furosemide 20 mg 1 ml per hour over 24 hours. Tablet cilnidipine 10 OD, rosuvastatin, aspirin and clopidogrel 25, 10 and 75 tab. Sodium bicarbonate 500 mg tab, dapagliflozin 10 OD and metoprolol 12.5 OD and Thyrox as he was taking before. Patient was given education to bed rest, limit fluid intake per day so that the patient's workload is not heavy, diet low in salt, that is 1.5 gram per day, and limit excessive sugar consumption. After 5, physical examination showed that respiratory rate turned normal, the pitting edema and effusion were reduced. Patient went home from the laboratory results are stable, was informed to take medicine regularly and control every month. Diagnosis of heart failure is confirmed based on the history and physical examination and laboratory investigation. The Framingham criteria for diagnosis of heart failure require the concomitant presence of two major, one major and two minor criteria. This include major criteria and minor: acute pulmonary edema, cardiomegaly, hepatojugular reflex, neck vein distension, paroxysmal nocturnal dyspnea, orthopnea, rale, and third heart sound or gallop sound. Minor criteria were ankle edema, dyspnea on exertion, hepatomegaly, nocturnal cough, pleural effusion, tachycardia, more than 120 beats per minute. Patient had a history of type 2 diabetes. Insulin resistance is a significant risk factor for development of heart failure. Presence of diabetes mellitus significantly increases the development of heart failure in patient without structural heart disease and has a negative influence on outcome of heart
final
failure.
Final diagnosis. Last slide. Final diagnosis.
Final diagnosis is acute decompensated heart failure in a type 2 diabetes mellitus, and conclusion is early and accurate diagnosis is crucial so that the treatment may start immediately to prevent severe complication. Therapy for risk factor can slow the progression of heart failure. Patients are recommended to take medicine routinely, to exercise regularly and change diet and lifestyle.
Okay, Anjali, you have written third heart sound with gallop. What is the difference between third heart sound and gallop?
S3 and S4 are said to be gallop rhythms, sir. It is used interchangeably.
Any heart sound associated with tachycardia is gallop. Do you agree?
Actually, in your first slide, you have shown that the patient complains of shortness of breath for 1 year and
Yes,
edema
sir.
for 6 months.
Yes, sir.
So these are the two presenting complaints.
Yes, sir.
And why did the patient come to hospital? Ideally, you should have added shortness of breath also in your presenting complaint. For 3 to 4 days prior to hospitalization,
symptom got aggravated.
that should have been added in the presenting complaint also.
Okay, sir.
Okay. How do you differentiate between PND and orthopnea?
Orthopnea is a short duration symptom, sir. On PND, patient suffers PND after 2 hours of sleep. Because of the exudation of the fluid, patient complains or feels like he is deficient of breathing.
Anjali, make it simple. What are the signs of heart failure in your patient? Positive heart failure signs in your patient?
Dyspnea on exertion, orthopnea, PND.
I have asked about signs.
Yes,
what
sir.
signs?
Orthopnea, PND, raised jugular venous pulses, and bilateral pedal edema. Bilateral basal clefts were present, sir.
Where do you compress to demonstrate abdominojugular reflex? Which part of the abdomen should be compressed?
Mid of the chest, sir.
Mid of the chest?
Or it can be pressed at the hepatojugular reflex.
The compression is not done in the chest, or it is done in the epigastrium, not in the
region.
hypochondrium.
Epigastric region.
It is in the epigastrium.
Thank you, Anjali.
Thank you, sir.
Now the next speaker is Dr. Ajinkya from All India Institute of Medical Science, Patna. His topic is hypoglycemia in emergency room.
Hello. 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 देखिए ना पीछे 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 बैक बैक नहीं हो रहा है. Good afternoon, everyone. Respected stage, below teachers, and my dear friends. It's been a pleasure presenting a case of hypoglycemia in emergency room. So, what we have done is we have evaluated all the patients of hypoglycemia which came to our emergency department, and we have evaluated what were the associated risk factors so that patient came into emergency room. So, it's not showing. As we all know, the hypoglycemia is one among the leading causes for emergency medicine, emergency department visits, as well as it is the most common and easily preventable endocrine emergency. So with increasing evidence of diabetes and with the various modalities of intensive control of blood glucose level, there is always a risk of proportional increase in the incidence of hypoglycemia. As the prolonged duration of hypoglycemia may lead to the significant morbidity as well as mortality. So each hypoglycemic episode should be addressed accurately in the aspects of etiological diagnosis as well as preventive measures. So what were the aim? Actually we have, it's like a more of a study what we have conducted. It's a pilot study and the aim was assessing the prevalence as well as evaluating the underlying causes of hypoglycemia in emergency room as well as associative factors with hypoglycemia. It was a prospective and pilot study which we had been done in emergency department. So the materials and methods were, it was a prospective as well as observational study and pilot study. We have included all the patients in emergency department with blood glucose of less than 70. The department ethical clearance was taken before the study. Patient age who's more than 15 years at the time of arrival as well as blood glucose less than 70, they were included into the study. And this study was conducted from 14th of March to 13th of March, and those with inadequate data, they were excluded from the analysis of the cause of hypoglycemia. So the data collection method was on arrival, patient's identification number as well as blood glucose, their values, age and gender of the patients was noted. Patient's clinical data, it was retrieved from previous reports. So the patient presented with signs and symptoms of hypoglycemia like giddiness, sweating, palpitations, altered mental status, seizures, syncope, paresthesias, numbness and motor deficits. Sir, results. So our results was out of total 56 patients who presented with hypoglycemia, we have found that the total male were 32 and female were 24. And out of all the 54 responses, what we have found that the 51.9% they were non-diabetic along with hypoglycemia, and 48.1% they were diabetic, and 54% they were non-hypertensive, and 46% were hypertensive. So the hypoglycemia was more common in non-diabetic as well as non-hypertensive patients. This was the RBS response. So the 44.6% they presented with blood glucose of 60 to 70, followed by 19.6% in the range of 40 to 50 and onwards. So the lowest RBS which was found was 15 milligram per deciliter. So the signs of hypoglycemia what we have included were the 41.2 patients they presented with altered sensorium, 11.8% presented with coma, and 9.8% they presented with palpitations, and less than 5% they presented with tremors and seizures. Out of all the 26 responses, out of all the diabetic medication in the diabetic group, what we have found that the 34.6% patients, they were having hypoglycemia in sulfonylureas group, and 19.2% they were on insulin, and 19.2% they were on DPP-4 inhibitors, and 11.5% they were on bigonides. So we have to be very cautious because 34.6% patient who were on sulfonylureas, they were causing hypoglycemia. And these were the diabetic drugs which were causing maximum hypoglycemia. So the combination like metformin plus glimepiride along followed by sulfonylureas alone, insulin alone, insulin plus metformin followed by glimepiride plus metformin. Out of this metformin plus glimepiride, they were causing maximum hypoglycemia. So the others, what we have found the associative risk factors like 24.5% patient they were having association with chronic liver disease, followed by 11.3% they were having associated with sepsis with hypoglycemia, but the 24.5% they were not having any of these symptoms. They were not having associated with features like CLD, sepsis, CVA, CHF, malignancy. So in CLD, there might be possible because of impaired hepatic gluconeogenesis, followed by there is decreased glycogen, depletion of glycogen storage. So in the diabetic group with hypoglycemia, what we have found that out of total 25 patients, 16 were male and 9 were females. And out of in the diabetic group, out of 25 patients, what we have found the 11 patients they were they were hypoglycemic because of OH-induced hypoglycemia. Followed by 4 patients they were having CKD, and 3 patients they were having CVA, and 2 patients having CLD, followed by malignancy and none of the above, and 1 patient were having sepsis. In the non-diabetic patient which presented with hypoglycemia, out of total 30 patients, 17 were male and 13 were female. The total causes of hypoglycemia non-diabetic, what we have found, out of 30, the 9 patients they were having CLD, followed by sepsis, followed by TB, malignancy, and thereafter. And associated with, out of 54 response, what we have found, 63% they were non-alcoholic as well as non-smoker. Only 29.6% they were alcoholic. So the discussion is the underlying causes of hypoglycemia in diabetic group. It can be because of intensive control of blood glucose, either by oral hypoglycemic agents or by insulin, or by the both, insulin plus oral hypoglycemic agent. Whereas in the non-diabetic group, it might be it was mostly because of CLD, sepsis, CKD and CVA, and other like malignancies, infections and unknown causes. So the conclusion is hypoglycemia is mainly because of medication related in diabetics, that is OHA related, and CLD and infection is the leading cause in non-diabetics. In CLD there will be impaired hepatic gluconeogenesis, followed by there will be depletion of hepatic glycogen storage. Whereas in CKD there might be impaired renal clearance of insulin. Because of that hypoglycemia might be occurring, as well as because of renal impaired gluconeogenesis. So the strength were, we have evaluated the risk factors as well as we have found out the association. Also the combination of anti-diabetics like metformin plus glimepiride, which were causing severe hypoglycemia, which has been found out. So the take-home message was none of the patients should leave the ED without the proper evaluation of etiology of hypoglycemia, and the problem should be addressed at each individual level. Thank you.
What are the order differential diagnosis?
Sorry, sir?
Mimicking the symptoms of hypoglycemia.
Sorry?
Differential diagnosis. Mimicking the symptoms of hypoglycemia.
Sir, CLD, sepsis, CKD, CVA, Most of them, they were having like skip meals also. The patient having blood glucose level, recurrent falling down of glucose.
What is the cause of hypoglycemia? It is more common in CKD patients.
CLD.
CKD patients, it is more common.
CLD as well as CKD.
Yeah, why is it more common in CKD?
Sir, maybe because of impaired renal gluconeogenesis followed by impaired excretion of insulin, or it might be because of impaired excretion of diabetic drugs because of kidney failure.
What drugs are safe in renal failure?
Sir, gliptin groups can be given.
Which gliptin?
Sitagliptins.
No, it is linagliptin.
Linagliptin.
Thank you. Now, the last speaker is Dr. Souvik. He is from Patna Medical College Hospital and a junior resident in the Department of Medicine. His topic is a case of pulmonary Langerhans cells histiocytosis.
Good afternoon, honorable chairpersons, all the doctors present here, and my dear friends. I'm Dr. Souvik Chatterjee. Is going to present a probable case of pulmonary Langerhans cell histiocytosis admitted under our head of the department, Dr. P.K. Agarwal sir. Patient's name is Mohammad Dilshad, 16 years male, resident of Darbhanga, is 7th class school dropout, unmarried, got admitted in PMCH emergency department and then to our respiratory medicine ward on 3rd March 2022, and then was examined by me on 10th March 2022, informant being himself and his mother, and is of lower socioeconomic status. He came with the chief complaints of cough with expectoration for 4 months, anorexia for 2 months, shortness of breath on exertion for 1.5 months, on nasal cannula oxygenation with chest pain, weight loss of 5 kg in 2 months. Patient was asymptomatic when he resided in Jaipur with his brother and walked in local shops 7 months back. He was then captured by Rajasthan police and kept in custody for 4 months. 2 months post-release in November, he developed cough with expectoration, whitish 2 to 3 teaspoonful, and fever, low grade, without chills and rigor, and continuous. Treatment was sought from local practitioners, but symptoms didn't subside. After 1 month, patient developed shortness of breath, gradual in onset, progressive in nature, present on hurrying on level ground or climbing upstairs, MMRC grade 1. No diurnal variation present, no V's present. Patient continued seeking medications from local practitioners. Shortness of breath was accompanied by dull aching chest pain, more towards the right side than left side. It exacerbated on coughing and got temporarily relieved by antitussives prescribed by the local doctor. In February, when there was sudden exacerbation of shortness of breath, his family decided to take him to a private hospital in Darbhanga. Patient was inserted intercostal chest drains bilateral and given symptomatic treatment. The cause of ICD insertion was unknown as patient couldn't produce any documents for the same. He denied any history of violent coughing, trauma to chest, lifting of heavy weight, violent vomiting or retching. He had no history of hospitalization or any medical or surgical procedure in the recent past. No previous history of breathlessness was elaborated by the patient. No significant past or treatment history except for treatment received in Darbhanga. Personal history is significant since he was an alcoholic and toddy consumer occasionally and also smoked 3 to 4 cigarettes on average per day. General examination revealed poor nourishment with thin and toxic look, pallor and grade 1 clubbing was present. Vitals were normal during examination except for an increased respiratory rate of 30 per minute with the use of accessory muscles. Upper respiratory tract was normal. On inspection, there was reduced bilateral chest movements with intercostal fullness. Apical impulse couldn't be visualized due to presence of ICD. On palpation, there was diminished movement bilateral, right more than left. Trachea was deviated towards the right with reduced vocal fremitus bilateral, right more than left over inframammary, axillary, infraaxillary, and infrascapular areas. On percussion, tympanic note was heard bilateral, right more than left, over same areas of reduced vocal fremitus with obliteration of liver dullness. No shifting dullness was present. On auscultation, diminished vesicular breath sounds were heard, bilateral, right more than left, with diminished vocal resonance bilateral over inframammary, axillary, infraaxillary, and infrascapular areas. Coarse crests were present bilateral over mammary and interscapular areas. No rhonchi or pleural rub was heard. Other systems, CVS, GIT, CNS were within normal limits. Preliminary workup and with routine tests and chest X-ray, he was diagnosed to have pulmonary Cox, clinico-radiologically diagnosed with secondary spontaneous pneumothorax bilateral. This was the initial X-ray which we conducted on 28th March 2022. We can see fibrobronchiectatic changes and infiltrations, but characteristically sparing of bilateral claustrophrenic angles. On 27th April, based on clinical evaluation, we removed the right-sided ICD and then did a check X-ray. Viral markers, rat for COVID-19 and sputum AFB was negative. Chest X-ray showed right-sided pneumothorax, for which we again planned ICD insertion. This was the patient and this was our chest X-ray. Bilateral ICD in situ. Treatment given in PMCH was moist oxygen inhalation, injection amoxiclav, vancomycin, arzol, 4-FDC, cough suppressant, pyridoxine 40, doxovant, N-acetylcysteine, aciprofilin combinations, and 5 episodes of intrapleural povidone iodine liquid for pleurodesis was done, and injection hydrocortisone was kept on SOS. This is the DICOM images of the same patient, HRCT chest, and it shows right-sided pneumothorax and presence of irregularly shaped cystic lesions and nodules in the upper and mid zones of both lungs. With sparing of bilateral claustrophrenic angles, there is interlobular septal thickening present. Areas of consolidations are seen with air bronchogram along with ground glassing, and mediastinal adenopathy is evident from the mediastinal window. Anticox was put on hold after 2 weeks, and patient was eventually discharged after performing bilateral pleurodesis and removing both ICDs. Prednisolone was prescribed at a dose of 40 mg per day in spite of repeatedly trying to reach out to the patient through his given mobile number. He was lost to follow-up. Now talking about pulmonary LCH, it's a smoking-related ILD characterized by monoclonal proliferation and infiltration of Langerhans cells. Clinical entities include Littler CV disease, pulmonary LCH, sir. What is the basis for your diagnosis? Sir, basis for the diagnosis was his presentation and history. He presented with spontaneous pneumothorax. Actually, the ICD that was placed in private hospital of Darbhanga, we took meticulous history and found out that it was inserted for bilateral pneumothorax, which was spontaneous, and by taking the relevant history, we removed the causes of primary spontaneous pneumothorax. So our provisional diagnosis was pulmonary Cox with secondary spontaneous pneumothorax. But after the HRCT images were obtained, we found that upper and middle zones of bilateral lungs were filled with irregularly shaped cysts and bizarre shaped cysts along with the presence of pneumothorax.
Without bronchoscopy or without lung biopsy, you can't be definitely sure that it is pulmonary.
Yes, sir. That's why I mentioned it is a probable case of pulmonary Langerhans cell histiocytosis. Yes, sir. It was a possible case, and in consultation with the radiologist, he guided us.
Bronchoscopy you could have done over there.
Yes, sir. Actually, our light source was a bit weak that time.
Langerhans cell histiocytosis.
Yes, sir.
How could you diagnose a case of Langerhans cell histiocytosis without it is a tissue diagnosis?
Yes, sir. But lung biopsy is the gold standard, actually.
Even in this valve, you can get more than 5
Yes, sir. Yes, sir. Yes, sir. That is also diagnostic, sir. Yeah. Yes, sir. That one.
Now come to your X-ray chest.
This one, sir? Huh.
Diagnosis. What are the differential diagnoses?
Sir, firstly, pulmonary cox, possibly miliary pattern since it involves bilateral lungs, bilateral fibrobronchiectatic changes, and other cystic lesions can be ruled out from this chest X-ray. Thank you, sir. Yes, sir.
How do you define miliary shadow?
Sir, miliary shadow is any shadow in bilateral lung fields 1 to 3 millimeter in diameter.
लाइए अनाउंस कर देते हैं बुलाइए So I request Dr. Rasmi Singh, Dr. Anjali Kumari, Dr. Ajinika and Dr. Somik to come over the desk. Before announcing the result, I would suggest not to be depressed. Oh, who is first, who is second, who is third, who is fourth. The best part is that you presented the case. That is all. So the first is Dr. Rasmi Singh from IGMS. Second is Dr. Ajinkya from AIMS. Third is Dr. Anjali Kumari from IGMS, and fourth is Dr. Soubik from Patna Medical College. Second, अपना नाम आ जाओ बीच में आ ना ये मोमेंटो ये Dr. Anjali. पैथोलॉजी में एमडी थोड़े कर रहा है उनको पहचानते हो पंकज सर उससे मिला करो वो नहीं पहचानेंगे तो किसको so thank you everyone and this is now so I would like to thank the organizer and would seek permission to leave. बहुत अच्छा किया चलो भैया
challenge their past, and hopefully all who have come here got satisfied with the academic content, and it must be said by them objectively also. We are very thankful to our dear motherly figure, Dr. S.K. Lal, especially the scientific committee chairman, Dr. Ajit Kumar Sinha, Dr. Dinesh Singh, Dr. Vinay Kumar, Dr. B.K. Sharma, Dr. S.K. Goenka, INL President, Dr. A.K. Rai, Dr. Ranjan Chaudhary, ED, IOCL, Sri Rajendra Kumar Chaudhary and his team for providing us the grand venue to fulfill our aim. Founder President Dr. N. Rai, who is in his late 80s but still works like a young boy. And he has so much zeal, it inspires us, and he will be an example to find in the future also. We must thank Dr. A.K. Birmani, Dr. Mrityunjay Kumar, Dr. R.R. Chaudhary, and Dr. Abhishek for their tireless effort. I must also thank Mithlesh Ji and Pramesh Ji for their effort day and night for months together, and all pharma companies who have contributed so profusely and make it a success. At last, I must thank our better halves who have given support to and ceremony master Mrs. Gupta is also to be promoted. That is the end of the this session I will invite. And at last, no conference can succeed if every member and every person of the community thinks that this conference is here. This is exemplified by the last 3 days attendance of here. So I am very, very grateful to them from the core of my heart. जिंदगी के सफर में जो गुजर जाते हैं जो मुकाम फिर नहीं आते।
जिंदगी के सफर में गुजर जाते हैं जो मकाम वो फिर नहीं आते, वो फिर नहीं आते। जिंदगी के सफर में गुजर जाते हैं जो मकाम वो फिर नहीं आते, वो फिर नहीं आते।
जन गण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गणवङ्गा विन्ध्य हिमाचल यमुना गङ्गा उच्चल जलधितरङ्गा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे